Hello, check, check, check. Hey, hello, 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 check one, check. Hey,
Hello.
hey, check. Hello, hello, check,
Hello. Check. Check one. Check two.
check.
Hello.
Hey, 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 hello, hello, check, check. Hey, check. Hello, check one.
Good. So first we'll go medial actually, and then from lateral side you have one more camera that this person will come. वो फना वो वाला फाइन लो और ये अच्छा अच्छा वो दो कैमरा नहीं इधर आने के लिए बोलेंगे हाँ because we'll go on medial first I'll go separately medial and then separately lateral.
So first two camera you want on this side and then on this side.
Yeah,
Hello,
and
hello,
this,
check.
we can shift that.
We can
Check.
Just can instruct them.
Check.
both the camera on
Check.
that side, ना?
Yeah.
उस side है, वहाँ पे.
First I'll go medial, so I'll stand here. So the camera also to be from behind.
नहीं, you're
It's okay, no?
you want trolley on that side or this is okay? You want
This
trolley
can
on
be here. Yeah,
this
no
side?
problem.
So just you can announce silence and
Yeah.
then we can start and then we can later on show the layers.
Okay, sure.
Better.
Yeah. Bullet pens. Yeah, just 3 colors separately.
Morning, Dr. Neha, are you there?
I just will use 2 or 3. That's all.
Morning, Dr. Neha, are you there?
Hello?
Yes, ma'am. Can we start, ma'am? So,
We'll be starting in few minutes. So, just few more minutes.
by the
You're all
time
set?
announce silence and then.
Yeah.
Hello?
Yes, ma'am. We all set.
Okay, sure. We'll be starting in few minutes. I'll let you know.
Okay. Silence.
Silence.
You
now.
announce.
I'll announce now.
You can yes better.
No, when they tell start, that time
Later
you
we
can.
will start this thing.
No.
You announce.
Hello? There are hardly any audience. They're still coming.
साइलेंस करके अपन खत्म करते बल्कि वेलकम एड्रेस होता रहेगा.
What is the time now? 8:30.
क्या था जैसे तो ये ठीक रहता है. मुझे एट अ टाइम आपको डिसेक्शन इतनी देर में हो नहीं पाता.
9 o'clock will tell that that silence and this thing will start
What is good that we start
before the dissection. Will tell that.
we can now announce silence and we can start the dissection just we won't show it.
Okay.
Just the time you will say like I have done this thing medial side this one because it will save our time.
Okay.
Otherwise, concurrently in the 20-30
20
minute
minutes
time,
it will be
it's
difficult.
very less. So even if for you also you can
Separate
precisely
it.
dissect, you
Yeah.
will have ample amount of time.
Yeah.
Otherwise,
I thought you want everything to be shown in live. That's why I was like waiting.
just
Start. Yeah.
if you want, we can discuss it with Dr. Neha also.
Yeah.
Because simultaneous concurrently it will be for medial and lateral side,
Lateral.
both the thing
So
covered to 20-minute time will be
difficult. So, Dr. Neha, Dr. Neha,
Hello?
yeah, Dr. Neha.
Yes?
So we'll just start with the dissection, and before going actually with the for the respect of the cadaver, we'll just stay silent for a minute, so to give the respect, and then we'll start. Okay?
Uh, yeah, Dr. Ramakan, can I just run Arumugam sir's video and then we can start with our session?
Okay.
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 I'll just start the program in a minute and I'll coordinate with you in a minute.
Okay. Sure.
Yeah.
You can do it fast. Don't worry. It's just a cadaver. So
बात करके उनको समझा सकते हैं कि ना silence के good start with that you can simultaneously you run your this thing only thing कि 20 minutes में lateral और medial side दोनों का dissection करना मुश्किल है तो भी हम खुद शो करते जाएंगे ना मतलब you don't run this program we will just start dissecting 1 मिनट का साइलेंस शो करके इधर से चालू कर देते हैं
टेबल ऊपर हो सकता है थोड़ा.
जो इम्पोर्टेंट भी वो डिसाइड मतलब कुछ तो रहेगा तो साथ में करते रहेंगे ऐसे पूछ लो समझा दो तो बोला नहीं तो फिर वो जैसे बोल रहे हैं वैसे कर लो
Table height.
Oh,
Yeah. Yeah. No, we'll have it here so that I can pick
we
it up.
have one more set similar one more set
Mm-hmm.
so if you want anything in access you can ask
Okay, sure. Yeah. No, nothing. So far, I think it should be okay. Hmm? No, 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 nothing.
मतलब ऐसा ठीक है लेकिन नहीं चलेगा नहीं मेरे हिसाब से इसमें टाइम बच जाएगा और वो प्रॉपर रहेगा ठीक है फिर हम ही साइलेंस करके और स्टार्ट कर देते हैं
Yeah.
मैडम से बात हो गया
Yeah.
तो उसमें क्या हो जाएगा आपके लिए भी आसान रहेगा
Okay, sure.
you can take your time you can precisely dissect it but then you can show layer by layer and lateral side is definitely you can do so
Okay.
whatever is
Yeah, we'll keep that silence slack.
अब जब लगता है कि एक ठीक ठाक डिसेक्शन हो गया, आपको लगता है कि दिखाना है अभी,
अच्छा।
तो वो फीड चालू कर देंगे।
अच्छा।
तो वहाँ पे जब तक वो फॉर्मल इनॉग्रेशन और वो सब हो जाएगा सर।
being conducted in Nagpur in collaboration with Vidarbha Orthopedic Society and Arthroscopy Society of Nagpur. So I hope you all will have a great learning experience today. Our two national faculties today are Dr. Srinivas Kambampati and Dr. Ramakant R. Dr. Srinivas is an eminent arthroplasty and arthroscopy surgeon from Vijayawada. He has more than 10 years of experience, work experience in various parts of UK. He's an associate editor of IJO, JCOT and JASSM, which is an official journal of Indian Arthroscopy Society. So he currently is in a private practice at Sri Dhatri Hospital Ortho Center at Vijayawada. He has more than 50 publications and multiple presentations in national and international conferences. Dr. Ramakant is an arthroscopy surgeon from Ganga Hospital, Coimbatore, and after his post-graduation, he has been extensively trained in arthroscopy and sports medicine around the world, including Korea, Greece, and Italy. He has won many gold medals for his presentation research of his work and also received ISACOS Young Investigators Research Award recently. So he has also got more than 50 publications in index journals. So we welcome our both national faculties, Dr. Ramakant and Dr. Srinivas Kambampati. Welcome you all. Welcome all the delegates. And without any ado, let's start with our first session. For our first session, I would like to invite our chairpersons, Dr. Sumed Chaudhary sir and Dr. Samid Widmute sir. And we'll start with a welcome of our president, Dr. Arumugam sir.
It's my pleasure to welcome you all to the IASONE program. The presentation team of the Indian Arthroscopy Society this year is Bridging Boundaries. With this mission, IAS is committed to bringing arthroscopy to every corner of India, ensuring that arthroscopic surgery is accessible to all. The IAS one initiative was conceived to realize this ambitious goal. Today, I also wish to encourage our young surgeons to join the IAS family. Membership in IAS comes with multitude of benefits that are invaluable for your professional growth. As a life member, you will gain access to your own personal digital secure logbook, which is the IAS registry. Our new registry is among the best globally, and we are soon launching the Shoal registry. Additionally, we have significantly increased the number of IAS inland and foreign fellowships. These fellowships provide an exceptional opportunity for members to enhance their skills and knowledge. By becoming an IAS member, you can apply for these prestigious fellowships and gain unparalleled exposure and experience. Moreover, we have expanded the number of IAS accredited training centers across the country. This ensures that a high quality training is available to you at a location convenient for you. thereby supporting your continuous professional development. As you engage in today's program, I wish you a day filled with rich learning experiences, vibrant interactions, and of course, a bit of fun. I extend my thanks and appreciation to the organizing team for conducting this IAS 1 program. Long live IAS. Jai Hind.
Thank you, Dr. Arumugam sir, President IAS. Now I hand over the program to our chairpersons.
Good morning all. So now we are beginning with the session 1, that is the basic of knee arthroscopy, and we are going to start with cadaveric live dissection. It's a relay from Dr. Ramakant R is going to demonstrate the live dissection from Shalindya Medical College, Nagpur.
Hello.
Dr. Ramakant, can you hear us?
Yeah, I can hear well, loud and clear. May I know who
Yes.
is this?
Yes, sir. We are ready. We can start, sir. Please proceed.
Yeah, so actually they have very good facility here, the cadaver facility. And first I would like to thank Dr. Mukesh Ladda and Neha for this great opportunity. And we have Dr. Siddharth and Tejas helping out for this demonstration. This is a very good facility here. This is my second time here. Last time I was here for patellofemoral conference and demonstrated the Fulkerson osteotomy. So what we have done is we have just opened the skin and the subcutaneous tissue. Generally for the medial approach, we take slightly more medial, but here I have taken slightly anteromedial so that we can expose the patella, the quadriceps tendon, the patellar tendon. So from the skin incision, about 10 centimeter I've just opened and then opened the subcutaneous plane here. So once we open the plane here, this is what we can see. Can you see it clearly? Can you dim the light bit? I think it's okay. Are you able to see this?
So you can see there. So,
Yeah. So here to start off, once we open this anteromedial region, so the first thing would be to identify the pes. So this is where we see the pes upper border. Can you see that? Yeah. So just opening the pes here and then dissecting it out and then erasing the pes will be exposing the deep portion of the MCL. Okay, so the anatomy has changed quite a bit from what we have studied. It's all because of the work of the Laprade, where previously the anatomy was qualitative exposure. Now what he has made from the Laprade studies from 2005 onwards, he has given us the quantitative anatomy, so that where we have to put the exact tunnels and everything. So this is the medial. I am just erasing the pes from its insertion, so that will give a exposure to the MCL, the superficial MCL. So what the structures what we are going to see, I'm going to expose is the superficial MCL, where the tunnels has to come, where will be the MPFL, how to identify, and what are the bony prominence on the femur and on the tibia. So MCL is the long flat band like a structure. It is about 10 centimeters in the length. So it starts just posterior and proximal to the medial epicondyle to 6 centimeter below the joint line. So here once we have exposed it, so we can see the MCL. So this is the superficial MCL. Okay. So
Request to
to
the
expose
camera person to only
proximally,
focus on the medial
we
side.
dissect this retinaculum. So here we have this pes layer, and in the pes layer we have, you can see the 3 tendons. This is semity, this is the gracilis, and the proximal thin one is the sartorius. So this sartorius forms the sartorial fascia, which winds around the posteromedial tibia, and here it forms the retinaculum. And the proximally here we can see the demarcation, and this is the VMO, vastus medialis obliquus. Now what I do is I just dissect and open the retinaculum or the portion of the sartorius, so that will expose the full length of the MCL. Okay, so this is what is being exposed, the superficial MCL. Okay, Okay, this is the full length of superficial MCL. As you can see, this is the flat band-like structure. The whole portion. So this is the epicondyle. Okay, so I'll just spin it. So the three bony prominences, what we need to follow during surgery is the epicondyle. So I can see that this is epicondyle and just proximal and posterior. So Laprade has given the exact measurements of how many millimeters, like around 2 to 3 mm proximal and posterior. So that is where the MCL is attached. So this is the full length of the MCL. So that is seen by opening this retinaculum layer. So in surgery, we have to preserve this layer because that gives a blood supply to this. So here in the cadaveric demonstration, this we can see that MCL. The other important structure is identification of the adductor magnus tendon. Okay, so this is the VMO. This is the upper border. We can see. You're able to see that. Yeah. So this is the adductor magnus. So what we can do is we can just put some, artery, and then even in the surgery, it will help us to keep our anatomical locations identified. So this is the adductor magnus tendon, and that is just inserted just posterior to the adductor tubercle. Okay, so I'll pin it with another pin there.
Yellow, just.
So probably with a different color, with the yellow. So yeah, so that is the adductor tubercle, and it's attached, just adductor magnus just attaches to the groove just posterior to that. And one more bony prominence what Laprade has given us is the gastroc tubercle. So these three important bony points are the important part. So I can feel here. Okay, so this is a retinaculum layer. I'll just open it, and the important bony prominence is the posteriorly is the gastroc tubercle. Okay, yeah. So these are the three important bony prominences which we have to identify surgically for all our reconstructions. So from here the superficial MCL forms, and the posterior aspect just in front of the gastroc tubercle, from here what goes posteriorly is the posterior oblique ligament, or POL. So surgically reconstructing the POL is also very important. Okay, so the POL has three bands, that is superficial band, the central band, and then one goes to the capsule of the knee in the posteromedial corner, that is the capsular band. Okay, so that winds around the semimembranosus. Can I just leave this? So semimembranosus is what we see here. This is the direct head of semimembranosus that goes attaches to the posterior aspect of the tibia. So this portion is forms like a hammock, like to have the stability for the posteromedial corner of the knee. When this layer is injured, that is when we have the opening of the medial side in 0 degree of extension. When POL and superficial MCL is gone, the knee becomes too much lax and then opens. So that is the POL attachment that is in front of just the gastroc tubercle. And what is in front of adductor is nothing but our MPFL. So MPFL, this is the upper pole of patella, this is the lower pole of patella, and what they tell is about 20 to 30, 40% is where the MPFL gets attached. So if I dissect the, how to identify is, this is a lower border of the vastus medialis obliquus. So the distal portion, this is the portion where there is a MPFL. Okay, so this is the MPFL. Just split it here a little bit. Okay, so this becomes the MPFL. Okay, so it is in the upper two-third or 40% of the patella, and then it goes around and then it gets inserted just in front of the adductor tubercle, that is around this region. So this is the important three bony prominences. The yellow is the adductor tubercle, the red is the medial epicondyle, and the white is the gastroc tubercle. So these are the three bony important prominences which we have to see surgically to identify the isometric points for a reconstruction of superficial MCL, the POL, and the MPFL. Okay, so that forms the medial anatomy. These are the important structures in the medial portion of the knee. So coming to patella, this is the patella. We can see that quadriceps tendon. So quadriceps tendon is formed by the what is it? Rectus femoris, part of VMO, the intermedius, and the VLO. And this forms the patellar tendon from the lower port of patella to the tibial tuberosity. This forms the patellar tendon. And from the patellar tendon, we can see the beautiful layer of the retinaculum. So we have opened this retinaculum to expose the superficial MCL. And this is about the medial side. Any questions from the medial side? So the surgical anatomy for these are the important structures which we have to identify for our reconstruction for the superficial MCL, MPFL, and the POL.
Dr. Ramakant,
Yeah.
can you show us the deep MCL?
Your voice, can you
Can you show
The deep MCL is nothing but it is the meniscofemoral and meniscotibial. If I cut open the superficial MCL, so that is where we'll find the deep MCL. So deep MCL attaches to the meniscus. So that is why it is called as meniscofemoral and the meniscotibial. So just below the articular, just above the articular surface, where the deep MCL would get attached in the femur, and the meniscotibial would be attached just at this region. So the MCL has a superficial MCL that is a oblong oval shape of attachment about 6 centimeter from the joint line. Okay, so here we'll just see how much it is. So if we consider this as the joint line, and so here we can see that around 6 to 7 centimeter is the oval oblong insertion, and this is the posterior flare of the tibia, and we can see that oblong insertion here. So any other questions? So this forms the primary anatomy for our reconstruction on the medial side, and if it is okay, then we can go for the lateral side as well.
Yes, sir. Please.
Is that okay?
Yes, sir.
Yeah.
Move on to the lateral side, sir.
We'll go to the lateral side. So can you come that side? So what I have divided is 10 minutes for the medial side and then 10 minutes for the lateral side, and then I would like to take a few questions how it is. Okay. So we'll shift to lateral side. Knife. So lateral side is also a very important thing. Previously, before all the Laprade papers, it was considered as a dark side of the knee because of varied anatomy, and they tell that there are around 28 structures which are dissected from the anatomical textbooks. But then the Laprade has simplified the approach, and he has given us the just 3 important structures which are needed practically for our reconstructions. So here I'm just elevating the skin flap. So we can take this kind of hockey stick incision. Generally my incision would be smaller, but this for the demonstration and the cadaver dissection, just opening it below the head of the fibula. Okay, so here we need to be careful. The first structure which we want to identify in the lateral approach is obviously the common peroneal nerve, because we don't want to surgically damage that. Okay. Yeah.
Retract.
Yeah. So the first structure would be to identify the common perennial nerve. So how to identify it? The direct head of the this is the biceps femoris. The long head gets inserted into the fibula. Okay. So this is the fibula. Okay. So this is the fibula. Then the long head is getting attached here. I'll just draw it for a fibular head. Okay. This is the fibular head, neck, and then so the common perennial would come like this, and it is about 2 centimeters below the fibular head. That's where it winds around the fibular neck. Okay, so this is the biceps long head, and we just want to dissect it. Scissors. Here. So we just want to dissect it around this region to expose the common perennial nerve. Okay. So this is the first thing which we want to expose. So we want to be careful that we don't hydrogenically injure, and also in cases of the biceps head avulsion from the tibia, the nerve can have a varied course. Sometimes the nerve can be lying over the fibular head. So we need to be careful, and then this is the important step. So here you can see, can identify the common perennial nerve. So once we open just below the long head of biceps femoris, just beneath it, we can expose this common perennial nerve. So this is important to explore when we are planning to do a PLC reconstruction. That's a Leprad anatomical reconstruction. If we are doing just Larson's, then we don't have to expose that. So this we want to expose in a Leprad reconstruction because we want to go posterior to the fibular head and also posterior to the tibia. So this is the region. Once we open this, so this is the region which we can go all the way up to the PCL in the midline. Okay. So for a Leprad reconstruction, we have 3 windows. That is, this is the first window. First window is between the common perennial nerve and the long head of biceps. The second window would be the long head of biceps and the IT band. So this is where our second window would be there. So here we can see that. Okay, the biceps. So this plane in the live patients, it will be just finger dissection would be very safe to do. Okay, so that we don't injure any of this. And this is where we find the lateral genicular branch of inferior genicular artery that can bleed sometimes. So we need to cauterize it. Otherwise, post-operatively, there will be a hematoma at this region. So this is the long head of biceps femoris, and we can go posterior at this region like a finger dissection, and then go to the posterior aspect of tibia. And our third window would be, I'll just not open this. For a Leprad PLC reconstruction, we need 3 windows to work. One is the below this long head of biceps, one is above. This is the second window. Third window will be opening it with a split there. So that will expose the LCL attachment in the just posterior to the femoral epicondyle. Okay. So this is the IT band. We need to split the IT band, and then we can see the LCL attachment. Now how to identify the LCL femoral attachment is Leprad has given the beautiful explanation of just opening the long head, the long head of biceps in a L-shaped manner. Okay, so once we open this L-shaped manner, there will be invariably a bursa which separates the long head of biceps and the LCL. Okay, so here you can actually, Yeah, so here you can see, can you see? So this is the LCL. So 100% of time we can identify the tibial, the fibular attachment of the LCL. That is by opening the long head of biceps like a trapdoor or a L-shaped opening. So we can see this LCL. So how to identify the femoral attachment? We can put a suture here and then give a tag, and then here we can see that we can feel the. Sorry, I didn't open it fully. Okay. Yeah. So can retract this. Can you please retract this? Yeah. No need for below, just above, so that you can see that. So this is the LCL. It is a cord-like structure. Unlike MCL, it is a flat band about 10 centimeters in the length. Whereas the LCL is nothing but, if you see the LCL on the common peroneal nerve, it looks similar. So it is a cord-like structure, which is about 6 centimeter in the length. It varies between 5 to 8 centimeter. Average is about 6 to 6.9 centimeter. That's what the anatomical dissection papers give. So when you pull the tag on it, then we can see the femoral attachment. Yeah, femoral attachment, and this is our lateral epicondyle. So the attachment of this LCL is just posterior and proximal. So all these tendons doesn't get attached to the epicondyle, but rather just posterior and proximal. So how to identify the popliteus tendon? So popliteus is akin to what we see in the shoulder. So popliteus is a intra-articular tendon, and in shoulder we have a biceps, long head of biceps as a intra-articular tendon. So the anatomical dissection and the quantitative measurement to identify intraoperatively is, I'm just open this IT band and I will just open the capsule bit and then expose the condyle so that we can easily identify the popliteus insertion into the anterior aspect of the popliteus sulcus. So here I have opened the small moments. Sorry. Okay. Yeah. So just exposing the femoral condyle. You can see the femoral condyle here. So I'm just opening the capsule. Okay. So here you can see the beautifully it is coming up. Yeah. So this is the popliteus tendon. This point is nothing but from the sorry, just extend the knee a little bit. Yeah. I'll just open it fully so that people can appreciate knife. Where did I put? Yeah, sorry. Yeah. Yeah. So this is the epicondyle. That is about what they tell. This is the epicondyle, and it's tight here. Okay. Yeah, just hold it like that. So you can see that this is the epicondyle, and our LCL will be attached here, and this is the popliteus tendon. So I'll expose it more. So I'm just cutting a bit of LCL there to expose the popliteus tendon. So this is about 18.5 mm. That is 1.8 centimeter just in front of the lateral epicondyle. Okay. So can you appreciate the popliteus tendon?
Yes, sir.
Yeah. So that popliteus tendon goes around in the popliteus sulcus. There is a small groove here in the lateral condyle that winds around and then goes posteriorly, and that is where we find the musculotendinous junction. And in the musculotendinous junction, there is a band of fibers which goes to the styloid process. Here is a styloid process. You can see the sharpness here of the styloid process, and that is what is called as popliteofibular ligament. So what Leprad has told is, so we have to do the reconstruction for the 3 ligaments for the PLC. That would be the LCL, the posteriorly the popliteofibular ligament, and the popliteus tendon. So here we have identified the structures, and where would be the tunnels would be like from the direction of tunnel would be like, so here we have identified the LCL. So this is the LCL. So that is attached to the lateral aspect of the fibular head, and the biceps femoris attached to the fibular head, and this is the LCL. So here would be the insertion point. So that is where we find the tunnel entry point would be. That is posterolateral to anteromedial would be our tunnel. Okay. So that would be our tunnel, and then we take the graph from here and then go to this region and then come out, go back to the tibia. The posterior surface of tibia can be accessed through this window. So here we can feel the fibular head, and then with the dissection we can go feel the posterolateral aspect of the tibia, and then we can put that tibial tunnel. So there will be 3 tunnels. One would be the femoral tunnel, one would be the fibular tunnel, and then the tibial tunnel. Tibial tunnel would exit anteriorly just in front of the Gerdy's tubercle. Okay, this would be the Gerdy's tubercle. So you can feel the prominence. So all the bony prominence are well felt. This would be the Gerdy's tubercle. So just in front of the Gerdy's tubercle, you will have the tibial tunnel. So, sorry, yeah. The Gerdy's tubercle, just in front of it, we'll have the tibial tunnel for the PLC reconstruction. The another important lateral ligament these days everybody is talking is the ALL ligament. So the ALL ligament would be just deep to this IT band, the band of tissue from the lateral front of the lateral epicondyle. Posterior to the lateral epicondyle, we have the LCL. So in front of the lateral epicondyle, the capsular thickening front of the lateral epicondyle to the point in between the Gerdy's tubercle and the fibular ligament. So that band of thickened capsular tissue would be the ALL. So ALL avulsion from the tibia is what is called as Segon's fracture, and that is where now everybody is trying to do the reconstruction of the ALL ligament. So the identification of ALL ligament, this is the lateral epicondyle. In front of the lateral epicondyle, the capsular tissue which gets attached has a thick band of tissue. Probably this is the band of tissue. So that lies beneath the this IT band. Okay. So this would be the ALL ligament. Okay. Is it appreciated? So hope all the structures are well appreciated here. This is about the lateral exposure for the LCL, the popliteus, and the popliteofibular ligament is nothing but the band of tissue from the popliteus tendon, the musculotendinous junction, to the posterior aspect of the styloid process. That would be the popliteofibular ligament. Okay, so probably this is the popliteofibular ligament. So all these structures needs to be reconstructed. Any questions? I think my time is up.
Wonderful cadaveric dissection, Dr. Ramakant. If there are any questions, yeah.
Are there any basic questions that I would like to answer?
Hello, Ramakant. This is Srinivas here. Wonderful
Yes,
dissection.
sir.
Thank you very much. Can you show us the femoral tunnel for the ALL reconstruction or LET? And can you show us the attachment of the ITB also to the distal femur, please? Kaplan's fibers.
Yeah. So ITB iliotibial band is, I opened it here. So I can see that the rent, I have opened it here. Okay. So the iliotibial band, as you know, it comes from the iliac crest to all the way up to the Gerdy's tubercle. So it is 100% we can feel that Gerdy's tubercle here So this is the IT band. It gets attached to the Gerdy's tubercle. And coming to your femoral attachment would be just in front of the lateral epicondyle. So here I marked this thing. So that is the lateral epicondyle. So just in front of the lateral epicondyle, that would be the attachment for the ALL. So probably the capsular thickening here, and then in the tibia it gets attached between the Gerdy's tubercle. Oh, sorry. So Gerdy's tubercle, that is this point. It's quite hard bone here. So that is the Gerdy's tubercle, and this is the fibular head. So that is in between that. That is where your attachment for the tibial site of the Gerdy's tubercle. So you can do ALL reconstruction with a tenodesis effect with a suture anchor, and then you take the gracilis tendon and then fix it here and then in front of the lateral epicondyle. The LCL is just posterior and proximal to the lateral epicondyle. The popliteus is 18 mm anterior in the anteriormost portion of the sulcus. Is that okay, sir?
Yes, thank you. The attachment of ITB to distal femur?
ITB attachment, there are actually various bands of attachment that they call it as a Kaplan fibers. Here you can see that one goes to the the portion of the patella here. There are like underlying, there are various bands just to give that stability around that region anatomically. So, and then it goes posteriorly to the deep membrane, that where that posterolateral corner where the condyle meets the shaft. So that is the region where you have few fibers of ITB going back there. So it is not a just a single structure just all the way just attached to here, but there are few bands of collagen tissue which goes to the patella also, and also to the femur at the posterolateral corner of the femur. So that's in short about the medial approach and the lateral approach to the knee. So these are the various anatomical considerations we have to identify intraoperatively to do our reconstructions.
Dr. Ramakant, this is Dr. Naved. Can you
sir.
please tell us where would you do your tunnel for the modified Lamire LET if you have to? And if the tunnels converge, the femoral tunnel of the ACL converge, how would you change that?
Yeah, modified Lamire actually they have inserted into that posterolateral region in just posterior to this region, and we take this band of ITB, take it beneath the LCL, and then our attachment would be just in the posterolateral corner where the condyle meets that region. So to avoiding the tunnels, the ACL tunnel would be always anterior directed. So here the ACL tunnel exit would be somewhere at this region, okay, at this region. Or sometimes if your angle transportal technique, it would be exiting here. If you are doing a transtibial which is older, it will be much higher and this thing. So invariably when you are doing the Lamire, we can identify the button because we have already done the ACL, or you can identify the button, or if you are not done the put the graph, we can keep the wire or something at this point, and we can see that it will be around 1.5 to 2 centimeter below. Only thing is the direction is like this, and here we are directing towards the medially. So invariably the tunnel collation is very negligible unless your exit point is somewhere here. So we always do the first ACL, right? So if the exit point is here, then we have to just go little proximal, just posterior to the LCL attachment. So the important here is we take this the band of ITB beneath the LCL and then get it inserted at this region.
Thank you, sir.
So that would be the insertion point.
Yeah. Thank you, Dr. Ramakant, for that wonderful exposition. A round
Thank
of
you.
applause for Dr. Ramakant.
Thank you, Neha and Dr. Mukesh Ladha for this great opportunity, and I thank our Dr. Siddharth and Dr. Tejas for for this demonstration. Thank you very much.
Yeah. Moving on, can I invite Dr. Srinivas to demonstrate clinical examination of the knee?
Sir, thank you. Sir.
Thank you.
Nice.
How long it took?
It's 20, 30 minutes. Only.
30
20,
minutes.
25 minutes. That was good, sir. Because that is why I told you, like, you first demonstrate so you'll be comfortable, like which structures where, so you can at least do that. So that was helpful actually on medial side, yeah. So because everybody wants to see this thing, sir, the structures actually. Huh?
10 years back, and now he complains of instability while running. He cannot do pivoting activities. And 10 years back, when he had a twisting injury, he was treated conservatively till now. So
Hello. Thank you, Dr. Neha and Dr. Larda, Darba Orthopedic Society and Arthroscopy Society of Nagpur for this opportunity. So I think clinically it's obvious that he has got some clinical instability. I'll just go through my system of examination of the knee just to give a complete a picture of examination and then we'll see the findings as we go along. First, can you stand here for me? So first, examine the patient. So go static and then dynamic. Standing position, you look at the patient from the front, look for the alignment, shoulder, levels of the shoulder, any deformities, any obvious deformities. He has got any swellings, any scars in the skin. So he's got problem with his left knee. Any wasting of the quadriceps, you can identify. Look at the position of the patella. Is the patella facing medially, laterally, or straight forward? Look at the foot. How is the foot pointing? Outside, inside, or neutral in relation to the patella? So is there any torsional issues with the leg? And from the side, look for any fixed flexion deformities, any hyperextension deformity of the knee. So stand. Maybe slight hyperextension on this side compared to the other side. Go to the back, look at the popliteal creases, levels of the popliteal creases compared to each other, any limb length issues, wasting of the calf. And then once static is finished, ask the patient to walk forward, look at the gait, walk and come back for us. So when he is walking, there is a slight varus on the left side compared to the right, maybe a little bit of varus thrust. So look for varus thrust, valgus thrust, look for the stance phase, swing phase, any classical gait abnormalities that you can see. So after you look at the gait, you can ask the patient to stand on one leg. If it is an obvious instability case, you probably don't do it at this stage. After you examine, make an assessment of how unstable the knee is, you can do it later. If it is a suspicion of meniscal injury, you can ask the patient to stand on one leg. This actually gives you an idea of how his core is. If his core is unstable or stable, if he's all wobbling, standing on one leg, it means that his core is not stable. And the other thing is to ask him to stand on one leg and bend forward like this, squat on one leg. This is also called a decline squat test. It is done for the jumper's knee or patella tendinitis, and also meniscal injuries. You can also ask the patient to squat fully down for meniscal assessment of the meniscus, and duck walk. Duck walking is also done for meniscal injuries. The next thing is to ask him to sit. So the knee is flexed to 90 degrees. If the deformity disappears in sitting position, it's probably coming from the femur and it's not from the tibia. If it is present in both sitting and standing, deformity is from the tibia. Sitting position is a good position to palpate the knee. So I start off, again you can check the quadriceps. There's a little bit of quadriceps wasting compared to this side. I start off palpation, starting from the tibial tuberosity, the patellar tendon, and either side of the patellar tendon, see if there's any fat pad impingement. Look for the medial joint line, is the soft spot between the femur and the tibia. Go all the way from anterior to posterior, palpating the medial joint line. And at the posterior part of the medial joint line is the MCL. Look for the femoral attachment of the MCL, always looking at the face of the patient if he is wincing, any pain. So MCL is intact. The posterior, the tibial attachments, any tenderness in the tibia. If there is tenderness, it could indicate bone marrow edema. Bone marrow edema. So what the test for bone marrow edema is to just tap on the bone. So it's the bone tap test. They will have pain on tapping of the bone. So the MCL is intact, and then we go to the lateral joint lines, starting palpation from the anterior to posterior. Feel for the LCL, feel for the ITB, and the proximal tibiofibular joint. You can tibiofibular joint. If there's any tenderness, the other way is to press on the joint with the palm of your hand. So any tenderness in the joint indicates instability. Again, sorry, on the medial side, you can also check for the pes anserinus bursa near the attachments of the hamstring tendons. So after that is done, ask the patient to extend the knee, straighten the knee. Yes. So it gives you a fair idea of how his quadriceps is working. Is there an extension lag? And also check on the tracking of the patella. So there's a patella alta or instability, you could see a J tracking of the patella. Okay. So, from sitting position to supine position, I generally go on to the side of the pathology. You can see that this knee is slightly hyperextending compared to this side. And this can be checked by the amount of elevation that is coming off from this side. Okay, you can actually quantify by measuring how much the heel is rising from the table on this side compared to this side. This is also slightly hyper. Thank you. So again, two things before we check instability. One is check for the effusion. The other is to check the patellofemoral joint. So for effusion, there are 3 grades of effusion. One is grade 1. The first grade is grade 1. So in that the fluid is minimal. So what we have to do is squeeze all the fluid from the suprapatellar pouch onto the lateral gutter. From the lateral gutter, we squeeze the fluid out into the medial gutter. So you will see the fluid bulging out on the medial side as you squeeze the fluid from the lateral gutter. So that's grade 1. Grade 2 is patellar tap. So you drain the fluid into the joint from the suprapatellar pouch and then press with the 3 fingers, press on the patella. You can tap the patella to the distal femur when you do that. In grade 3, there is a lot of fluid inside. Even the patellar tap will be negative. So it will be obvious there's a patient will be in pain with a big effusion in the knee joint. So, and the further examination of the patella, you divide the patella into 4 quadrants and check for how much the patella is sliding medially and laterally. Generally, less than 2 quadrants is normal. If it slides more than 2 quadrants of the patella, then there is an instability of the patella. So, yeah, thank you. After the patella slide, check for the patellar grinding test or the Clark's test for patellofemoral arthritis. You press on the patella, ask the patient to contract the quadriceps, and they will have, if there's patellofemoral arthritis, they will have pain in the patellofemoral joint, anterior pain. And the apprehension test for the patella instability. So you move the patella laterally and ideally at around 20 to 30 degrees of flexion, and the patient develops pain or apprehension or a feeling of instability or the patella subluxing out of the joint. So after this, I go for ACL, the instability testing. Instability is tested in 2 planes first and then rotation. So sagittal, coronal, and then rotatory instability. So in the sagittal plane, it's a good idea to check for the ACL. We have 2 ligaments in the sagittal plane, so ACL and the PCL. So for the ACL, you can either do this, put your leg on the couch to stabilize the femur, and then give an anterior tug on the proximal tibia. So that is Lachman. You can also do this with the hand. Relax. The patient should be relaxed. If he is painful, you will get negative results for these tests. So when you are doing this, you have stabilized the femur. When you are at it, you can also check for the MCL and the LCL because the knee is flexed about 20 degrees. Stabilize the femur and give a valgus stress for testing the superficial MCL, and varus stress to check for the LCL. Okay, and extend the knee and again give varus stress for the POL. So if it opens up in extension, then you have a posterior oblique ligament and the superficial MCL gone. Same thing you can do. Always check with the other side, especially the LCL, because you want to see how much it is lax compared to the other side. So sometimes you may be caught out. The other useful test for ACL I found is called the Lely's test. So you place your fist under the calf, press on the distal femur. So what it does is the distal femur pulls the proximal tibia down and your hand acts as a fulcrum. So the tibia, the heel is lifted off the couch. If the ACL is gone, what happens is, this does not happen. The heel does not come off the couch. Okay, so this is, ACL is intact. This side also appears to be intact. Blackman is for the posterolateral bundle of the ACL. Now this is the anterior draw test. You can do this, stabilize the foot, or you could sit on the foot to stabilize the foot, and then feel for the joint, the distal femur and the proximal tibia, and give an anterior translation force. So there is no translation of the tibia here. So ACL is intact. At the same time, I do a posterior draw as well to check for PCL. So PCL also appears to be intact. So ACL we have done. For PCL, we have the posterior draw test. Another test is a quadriceps active test, which is stabilizing the foot, asking the patient to extend the knee. So what happens is, in a PCL, the tibia sags posteriorly, and when he actively contracts the quadriceps, the tibia moves forward. We have actually published a test combining the posterior drawer and the quadriceps active. It's published in JASSM, but it's not validated. So what I do is push the tibia and ask the patient to extend the knee actively. So as he starts extending, I release the pressure. So this actually accentuates the movement of the translatory movement of the tibia. So for the posterolateral corner, you do an extension recurvatum test. You hold the leg with the great toe and lift it up. The knee hyperextends and goes into external rotation. And you can do a dial test. Dial test is at 30 degrees. You can do in supine position or in the prone position. So at 30 degrees flexion, you probably, in the supine position, you need an assistant to hold the legs together. What you do is externally rotate both the sides. If there's more than 10 degrees of difference between the sides, it means the posterolateral corner is gone. The other test is reverse pivot shift test for the lateral collateral. We'll first do the pivot shift for the first, and then we can do the reverse pivot shift. So the pivot shift is done with the leg internally rotated. Give a valgus stress. What happens is, in internal rotation and valgus stress, with the knee in the extended position, the lateral tibial plateau actually translates anteriorly when the ACL is ruptured and the anterolateral ligaments are gone. This is anterolateral rotatory instability. Okay? So, and when you flex it, the translated lateral tibial plateau reduces because the ITB pulls it back. Okay? So you will feel a clunk in reduction. You see? There you can see. So the pivot shift is positive in him. So he probably was actually inhibited when we are trying to do an anterior draw test. You can clearly see the movement here. And the pivot shift is positive. In flexion, it reduces. Whereas the reverse pivot shift is you externally rotate and flex the knee about 60 degrees. What happens is, in PCL and posterolateral corner injuries, the lateral tibial plateau actually subluxes posteriorly. So in external rotation and flexion, it subluxes posteriorly, and in flexion, it reduces. So we need to find out. This is, I can see a clunk here as well. Relax. Can you relax? Yeah, now you can see when the patient is relaxed, you can see the anterior drawer coming forward, okay? So that is posterolateral rotatory instability and anterolateral. Anteromedial rotatory instability is when the MCL is gone and the ACL is gone. So you externally rotate the leg and do an anterior drawer. Internally rotate, when you internally rotate, that actually disappears. This is exaggerated more than your anterior drawer if the MCL is also gone. I don't think there's much of, it's not exaggerated. So, and then you check for the neurovascular status of both the lower limbs, the ankle, the hip, the spine. That would complete your knee examination. Do you have any questions?
Any questions from the audience?
And movement, of course, you have to check the movement, full extension, and how much of flexion he has got. Okay, look, feel, move, and measure. So measurements, you can measure the length of the lower limb.
Thank you, sir. Thank you, sir, Dr. Srinivas, for excellent demonstration of a knee examination. I will invite the next speaker, Dr. Sanjay Parekh. He is going to speak on radiological anatomy of knee joint.
Good morning, seniors and my delegates and my colleagues. Thank you, IAS, for giving me this opportunity for presenting this slide on radiological anatomy of a normal knee. Since Srinivas sir has nicely demonstrated the clinical findings, and in OPD scenario also, after the clinical findings, the next thing we do is the radiological. So first we need to know the normal anatomy. That will give us an idea that how a abnormal knee structures look. So first thing we do is an X-ray of both the knee. We do it in AP, lateral, and a skyline view. These three views gives us almost 60% of the idea of the pathologies. So in a AP and lateral view, we mostly see the joint lines spaces, and any avulsion injuries can also be appreciated in a AP, lateral, and skyline view. Apart from that, the patellar and the trochlear anatomy can be seen in this skyline view, which is taken at 45 degree of knee flexion. Robert Laprade has given special emphasis to the valgus stress view. It gives us an idea of the ligament structures and constraints of the medial and lateral part of the knee. The valgus stress view, it gives us an idea of the medial constraints of the knee. So what Robert Laprade has stated in their cadaveric findings is that if the gap is of the both the knees comparable, and then it is normal. But if it's more than 3.2 difference is there in the valgus side, medial side of the knee in valgus stress, then it indicates an MCL tear. And if the gap is more than 9.8 mm, then we should think something more than MCL. Posterolateral, posteromedial injuries also has to be suspected. And these stress views are done in 20 degree of flexion. Similarly, for the varus stress view, he has stated that 2.7 mm of difference of the contralateral sides, it indicates an FCL tear. But if it is more than 4 mm, then there is associated PCL and posterolateral corner injuries. The importance of stress view is much more in a PCL tear, where the sensitivity is much more, and it has to be done in a proper way. There should not be any rotation of the tibia while giving this position. So what they have said that is 8 to 11 mm of posterior translation of the tibial is there, then we must suspect an PCL tear. And if it is more than 12 mm, then we must suspect PCL along with posterolateral corner injuries. And in certain high grade medial injury along with PCL also will give such translation. The workhorse of a knee examination evaluation is the MRI. MRI gives us an idea of the internal structures, soft tissue structures, and we should know exactly what sequences are required for knowing what kind of structures. So For an orthopedic point of view, basically we require two sequences. One is T2 PD, which is essential for internal derangement because the cartilage structures and soft tissue pathologies are much more can better visualized in a T2 SAG and PD SAG images. And T1 is not of much helpful for orthopedic point of view in consideration of the ligaments, but it is useful if you want to see some marrow pathologies like tumors and also for some edema. So systematic approach is ideal because if we don't do systematic, we will be missing certain structures. For an MRI, the basic idea is first we see the medial compartment, then lateral, then patellofemoral, then the midline structures. In this way, if you go, then we won't be missing the almost all the pathologies. So this is a basic schematic diagram how we appreciate a menisci in an MRI sequence. So A, B, C are the sections in which we see the menisci. When we see the menisci at section A, then it looks like an rectangle. I am talking of this sagittal view. And when we take the sagittal view at B section, B, then the menisci looks like a bow tie. And when the same thing we see at C side, the menisci looks like two triangle. The importance of this I will come to in the further slides. So this is a medial meniscus. How we'll see from the how we appreciate the medial meniscus. We go from peripheral towards the center. In the peripheral, the menisci looks like a bow tie or rectangle shape. Once we go centrally, we can see two triangles. So the important point in this is that for the medial meniscus, the posterior horn is always double the size of anterior horn. In situations where we see that the posterior horn and anterior horn of the medial meniscus are of same size, then there must be some tear of the posterior horn of medial meniscus. So that has to be kept in mind. When it comes to lateral meniscus, same sequence, we go from peripheral to the midline. In peripheral, we can see the first image, there is a part of fibula is seen. When fibular head is seen properly, then we see that we are at the most peripheral part, and the menisci, it appears like a rectangle. Then slowly we go inside. In the mid sections, we see a bow tie, and finally we see a two triangles. Here, both the triangles are of the same size, unlike the medial meniscus, where posterior was larger, twice the size of the anterior. Lateral meniscus, discoid meniscus is quite common. The two signs which we see in discoid meniscus is, if in the third image we see a bow tie sign, then it's a normal. But if you see a rectangle type structure in third image also, then it's a discoid meniscus. And second way of identifying is that if you see 3 consecutive bow tie signs in 3 mm sections, then we should suspect a bow tie sign also. So continuation of the anterior root of lateral meniscus with the ACL gives a striations at the insertion of the tibia. So some signals at the insertion of the tibia should not be confused with ACL tear, but rather it is a continuation of the anterior horn of lateral meniscus. Bone marrow edema pattern is the another thing which gives us an idea that where the pathology is and what is the cause of that pathology. In ACL injury, pivots type of injury takes place, and we can typically see bone marrow in the lateral condyle and mid part and posterior part of the lateral tibial condyle. In case of patellar dislocation, the bone contusion will be seen on the lateral femoral condyle, that too more anteriorly and superiorly. And same kissing type of bone lesions will be seen in patella lateral facet also. When it comes to sagittal sections in the midline, the two things we see, the cartilage status of the patella posteriorly and the trochlear cartilage. And along with that, we can see the position of the patella, whether it is patella baja or alta. And another thing, we should always look for Hoffa's fat pad and any signals in the Hoffa's fat that indicates a Hoffa's impingement syndrome. So ACL is the most common thing we look. The first thing we look in a MRI section, and the most important film is PD SAG, which is the most, which gives us a clearer idea of any ACL pathology. It's a fan-shaped structure coming from the femur to the tibia, and at the insertion of the tibia there might be signals, as I stated earlier, so it should not be confused with some intrasubstance tear. It is normal. And in axial section, we can see anteromedial and posterolateral bundles of the ACL. The mnemonic office is AMPL, so it will be easier to identify which bundle of the ACL is pathological in this axial section. PCL also we can see in the sections next immediate to the ACL, and in case of absent ACL there will be buckling of the PCL. In the last image you can see a buckled PCL, and the front image you can see it's a normal PCL. It has also two bundles we can see in the axial section. In coronal images, mostly we see of the medial side, we see the anterior horn of the medial meniscus, and posteriorly we can see the fibula. At the same segment we can see the root of the posterior, and any tear of the root can be seen in that section. And same goes for the lateral compartment in coronal section also. So IT band is the most important thing we can see from anterior to posterior, and once we go posteriorly, then we can see the root, the body of the root, and LCL and popliteus. The LCL is the FCL is a oblique ligament, so it won't be seen any single image, but in two images we can see when going from anterior to posterior. In axial section, we always look for the MPFL and LPFL in the axial section, and normally the LPFL is quite thicker than the MPFL, and it should not be confused with a tear. So the summary is, if the MRI multiple sequences are there, always our approach should be compartmental approach. In that way it is systematic. T1 is only for marrow pathologies and infection and tumors, and all the pathologies we see in the PD and T2 fat set images. Whenever we have doubt, we can correlate in all the three planes, and bone marrow edema and contusions will be always gives an idea about the cause of the pathology and what is the source of pathology. Thank you.
Thank you, Sanjay. We will have questions at the last. May I invite the next speaker, Dr. Neha, who is going to speak on how to begin arthroscopy, what is the OT setup, and what are the portals.
So good morning, everyone. I'm Dr. Neha. First of all, I would like to thank IAS for giving us this opportunity. Today, I'll be presenting on how to begin arthroscopy, OT setup, portal placement. So currently, the knee arthroscopy is one of the commonest procedures happening worldwide. So the indications for knee arthroscopy is diagnostic, meniscal and ligament repairs, loose body removal, synoectomy, etc. So basically the OT setup is the OT arthroscopy trolley, which contains monitor, camera and light source, then shaver system to shave off the synovium, fat pad, etc. And definitely the radio frequency machine, and definitely the stabilizer which helps to stabilize all these machines. The Mayo trolley contains optics like camera, scope and light cable, shaver blades, cannula and trocar, and lastly your extended finger probe. So instruments on the trolley should include various kinds of punches like duckbill punch, curved punches, cigar handle punches or lateral punches, and grasper. So the utmost important thing is in cold cases is first to confirm the side, and then after which examination under anesthesia is done, we check first the range of motion, whether there is any FFD, the knee is locked or not, and then mediolateral and anteroposterior stability, and also the patella mobility. So here I'm checking the anteroposterior stability of the knee. This is the anterior drawer test. After spinal anesthesia, the patient's ipsilateral hip, the positioning is very important. The patient's ipsilateral hip should be on the edge of the table, the foot should be on the end of the table, and the tourniquet is applied as high as possible. We apply a transparent tape at the lower end of the tourniquet so that there is no seepage of any cleansing solution beneath the tourniquet, which might lead to any chemical burns later on. Then the thigh support is applied on the lateral aspect of the thigh at an appropriate height, and this thigh support acts as a counter force when we are applying a valgus stress on the knee. The foot support is applied in such a way that the knee is at the 90° of flexion. It is important to drape the knee in water impermeable drapes to avoid any contamination with the saline which flows over the period of time. And the arthroscopy trolley is placed on the contralateral side, and on the ipsilateral side, 3 liter saline bottles are mounted. Skin markings is done as follows. First we mark the patella, then tibial tuberosity, and then the patella tendon, and then the joint line. Note that the lateral joint line is slightly on a higher side than the medial one. So now coming to portal making, the knee joint is a superficial joint. So portal making is comparatively easier in knee, and it's also safer. So commonly used portals are anterolateral, anteromedial, superolateral and postomedial. So the first and foremost portal we make is anterolateral portal. It is created by palpation, and it is 1 centimeter superior to the lateral joint line and lateral to the patella. So here we can see my thumb is at the soft spot on the lateral joint line, and a vertical stab incision with a 11 number knife is taken till the capsule. So unlike shoulder, the incision can be taken deep till capsule. The knee is flexed in 90 degree of flexion, and then with once the portal is made with a gradual rotatory movement, the trocar along with cannula is passed from anterolateral portal directing towards the intercondylar notch. And once we feel the loss of resistance, it means your trocar with cannula is inside the joint. So after this, the knee is extended. So after this, the knee is extended, and then the cannula with trocar is advanced through the patellofemoral joint in suprapatellar pouch. And to confirm if it's intraarticular, a side-to-side sweeping movement is done. And if the trocar is nicely moving in the suprapatellar pouch, that means you are intraarticular. So after confirmation, the trocar is withdrawn, keeping the cannula in situ. In cases, if you are suspecting any fluid collection, and if you like to take the sample, at this point you can take the sample, collect it in a kidney tray, and send it for the testing. So after this, the arthroscope is attached with the light source and is inserted in the cannula, and then the saline inflow is started. What if there is an error in making the portal? If it's too low, then it will cause damage to the meniscus, and there will be difficulty in maneuvering. If it's too high, you won't be able to see the posterior joint line structures. So generally for ACL reconstruction, it is advised to make anterolateral portal, which is close to patella and on a little higher side. So second portal is anteromedial portal. It is located generally 1 centimeter above the medial joint line, and it is outside in portal. So so if you want to do the position of this portal varies according to the pathology. So first the scope is directed in the medial joint line, medial joint, and after that with the help of finger palpation, the needle, you can see the indentation in the arthroscope, and then with the help of needle, it is inserted from outside in technique in the medial joint line, so that it enters just superior to the medial meniscus, like this. So another portal is a posterior medial portal. It is 1 centimeter above the posterior medial joint line. Knee is in 90 degree of flexion, and soft spot is between the tendon of semimembranosus, medial head of gastrocnemius, and medial collateral ligament. The maximum irrigation is started to balloon out the knee. The indications for posterior medial portal usually is for ramp repair and for PCL reconstruction. The posterolateral portal again is created by palpation. It is 1 centimeter above the posterolateral joint line. Soft spot is between lateral head of gastrog, LCL, and posterolateral part of tibial plateau. And again, in the indications for posterolateral portal are removal of loose body, repair of posterior part of the lateral meniscus, and synovectomy. The superolateral portal is just lateral to the quadriceps tendon. It is 2.5 centimeters superior to the superolateral corner of the patella, and it is used most of the times to evaluate the patella tracking and also patella congruity. In cases of MPFL reconstruction, we put the scope inside the superolateral portal, and we see the tension of the MPFL, how much we need to tense the MPFL. Accessory portal is a Gilchrist portal. It's a central transpatellar portal, and it is useful in ACL avulsion fixations. It is 1 centimeter distal to the lower pole of the patella. A few accessory portals which are sometimes used are far medial, far lateral portals, and in femoral tunnel making, ACL for ACL reconstruction, accessory medial portal is used. So to conclude, I would like to say that positioning and confirming the side is of utmost importance, and exact portal placement is important to avoid any struggle later on. And portals of the knee are comparatively, because they are superficial, they are comparatively safer. Thank you very much.
Thank you, Neha. Can we have the next speaker, Dr. Prakhar Jain, who is going to talk on video diagnostic round of arthroscopy.
Yeah, respected people on the dais, very good morning. I am Dr. Prakhar Jain. First of all, I would like to thank IAS and Dr. Neha ma'am, who has given me an opportunity to speak in front of you for the diagnostic scopy. So first thing first, what should be the position of the patient? It can be a two-position thing, leg holding as well as supine on the table. The most important thing while doing is that examination should be done under the anesthesia. Pivot test and drawer tests are compulsory, so we know the rotational instability, and if any procedure has to be added, we know after doing the anesthesia. Tourniquet should be inflated only after the anesthesia. It should be well padded and should be covered with the water repellent drapes. One more tip while doing the leg holding position, just make sure you place the patient most distal so that you get the adequate knee ROM. These are the portal placement as well described by Neha ma'am, so I won't be touching into it. So diagnostic scopy. We have to use the blade number 11. We have to point towards the femoral notch. Blade should point superiorly and vertically so it prevent any injury to the anterior horn of the lateral meniscus. The arthroscopic regions of the knee we should be examining are suprapatellar pouch, patellofemoral compartment, medial and lateral gutter, medial and lateral compartment, and the intercondylar notch. So as soon as we get, after palpating the medial lateral joint line, the soft spot, we should move 1 centimeter superiorly and 1 centimeter lateral to the patellar tendon, and we make a stab incision with the blade number 11. And we have to insert the scope. After inserting the scope, the first thing we will be seeing is suprapatellar pouch. So we have to examine from medial to lateral, superior to inferior. The pathologies that are suspected here are loose bodies and adhesions. After that, we have to just take the scope a little bit back. So we see for the patellofemoral compartment. Here we have to see for the patellofemoral tracking. For seeing the trochlea, we have to turn the lines downward, and for undersurface of patella, we have to turn the length upward because the light and scope goes up in 90-degree relationship. So pathologies that are suspected are patellofemoral tracking or osteochondral defect if there is any. As you can see on image 1, this is a normal patellofemoral tracking, and here on image 2, you can see the mal tracking of the patella over the femur. After that, we see for the medial gutter. Medial gutter is nothing but 50% of the medial synovial plica, which runs medially and distally to patella. It originates from the medial surface of the suprapatellar pouch and get inserted into the fat pad. Sometimes patellofemoral symptoms may be because of any pathology in the medial gutter. After that, we have to keep the knee fully extended. So we relax the soft tissue in the lateral part, so we get inserted into the lateral gutter. The structures that are seen on the lateral gutter are nothing but the posterior horn of the lateral meniscus. We see the popliteal hiatus, we see the popliteal tendon. Then after that, we see the posterior surface of the lateral femoral compartment. To get inside the medial compartment, we have to give a valgus test and external rotation. Sometimes we have to pie crust the MCL, superficial part of the MCL on the tibial side to open the joint much. While doing leg holding, we have to 30-degree knee flex and valgus test. On lateral post, we do at 90-degree of the flexion over the post. So after that, we make the anteromedial portal under the direct vision. We first do it with the needle, and then we insert the blade just to make sure that we should not be damaging the meniscus. After that, we have to examine the medial meniscus. We have to see the anterior, medial, and the posterior horn of the meniscus, and any visual thing we have to do with the extended arm of the surgeon, which is called as a probe. So over here you can see the complete includes the direct palpation of the over surface and as well as under surface of the meniscus. The pathologies which are suspected are osteochondral defect if there is any, and any buccal handle tear if we are suspecting. We have to see for all those things. So pathologies, I won't be touching into it. These are the radial tears of the horn. And after doing the partial meniscectomy, we are stabilizing the meniscus in some of the cases if needed, if that is in zone. So after that, we get inside the intercondylar notch. We see for the infrapatellar fat pad, ligamental mucosum. Sometimes we get confused the ACL with the ligament mucosum. So we have to just remember that thing that ACL is far posterior. So we have to remove ligamental mucosum in some of the cases. We see for both the attachment of the menisci, ACL, PCL, Humphreys ligament and Risberg's ligament. So after that intercondylar notch, we see for the ACL. So for seeing the ACL, we have to keep the knee flexed to 60 to 90 degree. We have to rotate the lens until we see the medial aspect of the lateral femoral condyle. For right knee, we have to do at 10 o'clock, or on left knee, we have to do at 2 o'clock position. After that, we see for the PCL. We have palpate the posterior cruciate ligament by probing the undersurface of the femoral attachment and pulling anteriorly. These are the popliteal tendon which we see in the popliteal hiatus, and these are the normal translation of the lateral meniscus which we see with the palpation. So to get into the lateral compartment, we have to do the figure of 4 thing so that it gives the varus opening kind of thing. So that opens the lateral compartment. We can see the holder structures very well. So this is a video. As soon as we enter the joint, we see we reach the suprapatellar pouch. We have to pull the scope back, so we see the patellofemoral tracking. Then we see for the gutters, which are medial gutters. These are the reflections of the capsular attachments, and we see for the lateral gutter also. After that, we see for the intercondylar notch. These are the beautiful bundles of ACL, anteromedial and posterolateral bundles of ACL. Then we have to make the anteromedial, which is a working portal. So we do the probing and see for any tensioning of the ACL and PCL. Now, with the help of a probe, we are seeing for any pathologies in the medial meniscus. Under surface and over surface, we have to see, and we have to get inside to see for any posterior root tear or anything if we are suspecting. And after that, we have to give figure of 4. So we enter into the lateral compartment. We again have to see the anterior, medial, and posterior part of the meniscus. Then we have to insert the probe. So any pathologies, if not seen by scope, with the help of the probe, we can identify that thing, and with the palpation, we can make sure we are not missing on anything. So this is the complete examination of knee. Thank you so much.
Thank you, Dr. Prakhar, for an excellent diagnostic round of arthroscopy. Now, I'd like to invite all the speakers of this session. Please come on the dais. Dr. Ramakant, Dr. Srinivas, Dr. Sanjay, Dr. Neha, and Dr. Prakhar. So, any questions for the sessions for the first speaker, first session? Dr. Srinivas. So in cases of acute scenarios, what are the parts of the examination you would like to include and like to skip?
In an acute patient, obviously the patient will be in pain. So whichever movement causes pain, I try to avoid. There's not much we will gain by examining in a painful patient. The muscles go into spasm. You may not be able to do, even in this patient we saw, ACL was difficult to detect because sometimes it is difficult. The muscle is tight and you can't find out. So range of movement, you try to assess as much as you can. And instability, again, I wouldn't stress too much when doing testing for instability. Just a little bit of jog, you may be able to find out what instabilities he's got based on the mechanism, the bruises, where he's got the bruises, and the type of movement you are getting when you are examining. So in a chronic knee, there's no inflammation, no swelling. You know that the knee is not painful. In that case, you can do a proper examination.
Right, sir. Dr. Sanjay, so you just spoke about the different stress views. So in your clinical practice, in a patient come with a ACL, MCL injury, what are the X-rays you would like advise?
Pardon, sir?
So you talk about this stress X-rays.
Yes, sir.
Right?
Yes.
So in the current view, we have the access to the MRI and other thing.
Okay.
So what is the relevance of the stress X-ray in today's practice? That I'm asking. So would you still advise the stress X-ray or rely on to the investigation and the clinical findings?
Sir, it's an added investigation along with MRI and clinical examination I add to my patient, because it is much more gives sometimes partial PCL tear and posterior injuries that can be missed in MRI. But stress view with MRI findings, it gives us an more authenticity to the findings.
Thank you, Sanjay.
Neha, you talked about the portals. So, what are the things that can go wrong for a beginner while making the portals?
That's what I said in the one slide, that sometimes the portal can be just very low or very high. As Prakhar said, while making the portal, the sharp edge of the 11 number blade should be on a upper side so that you don't damage the meniscus. So if it is too low and your sharp is on the distal side, then you might cut the lateral meniscus, because the first portal is blind portal. So that one thing, if it is too low, then it will damage the middle meniscus and there will be difficulty in maneuvering. If it's too high, then you won't be able to see the posterior joint line structures. So these things can be, and if I would like to say to the beginners, even if you make a wrong portal, that is okay. You can make another right portal. That is, rather than doing scuffing the cartilage with the wrong portal, it's not good. So you can redo the second portal, which is in the right spot.
Welcome, Dr. Ramakant. That was a wonderful exposition of cadaveric dissection.
Any questions for the panel?
Can I just make a comment?
Yes, please.
The diagnosis in knee is primarily clinical. So MRI can give you an idea of where the injuries are, but it doesn't tell you exactly how much of instability there is. So if you're not getting it in an acute situation, probably you can call the patient again. The inflammation has settled down. You can examine later and reassess, make a reassessment.
Yeah. Come ahead.
See, the name suggests anteromedial instabilities, ACL, and medial instability. So clinically, if you do an external rotation, you do external rotation for both. So in anteromedial instability, when you externally rotate, the lateral tibial plateau comes forward, whereas in posterolateral instability, you do external rotation, the posterior side goes backwards. So posterolateral instability is PCL and posterolateral corner. Yes, you can, yes. If the dial test is for PLC. So yes, if it is positive at 30 degrees, it's PLC. If it is positive 30 and 90 degrees, then there's PCL and PLC. So if you get a positive anterior drawer or Lachman and ACL laxity and posterolateral laxity, then there is ACL and PLC. So and MCL and ACL is anteromedial instability.
Yeah, I would like to add a comment there. So what happens is, see, when the knee is there here, both are external rotation. So when there is a anteromedial instability, the external rotation will have the more anterior prominence of the step off. Whereas when the PLC is there, this is intact and it is more posterior. So beyond the equator, it goes there. So that is the PLC. So in thin patients, it is easy to identify clinically, but then the obese patients will not be able to differentiate that. Anteromedial side, that's what I was telling. So when there is both are external rotation. The difference is anteromedial, you can feel that anterior step off, and this one goes beyond PLC.
One last question.
From examination point of view, sir, every textbook or every literature and even the examiners which ask questions to us during the exam, sir, there's a lot of disambiguity between the meniscal injuries test, which is the McMurray test, sir. So what is actually McMurray test, with every author giving every different explanation, and actually what to do in a clinical examination to test for the medial side as well as lateral sided meniscal injury, sir?
I think I should have told you more about meniscal injury actually. I don't do McMurray routinely because sensitivity and specificity are very low with McMurray. What you could do is a weight-bearing McMurray, also called EGIS test. So what you do is ask the patient to stand near a wall, externally rotate both the legs, and ask him to squat, bend the legs, bend the knees. So when he does that, this is for checking the medial meniscus. And if you want to check the lateral meniscus, you internally rotate, and then obviously you can't go all the way down because your knees will come together. So this is for the lateral meniscus. This is also called the weight-bearing McMurrays. This is more reliable than a McMurray test. Also do Thesali test. That is also a good test to do. So you ask the patient to stand on one leg, flex the knee, then rotate. Either the patient rotates himself or you could hold the arms to support the patient, internally and externally rotate. That is also a good test for meniscus. And as I have said, squat and duck walking, those are also good tests for meniscus. If the patient has got other ligament laxities, this test may be a little too much for them.
Okay.
Thank you all the
Yeah.
speakers. Now we go on to the next session.
I would like to call the chairpersons to felicitate our speakers. Dr. Ramakant. Dr. Srinivas Kamampati. Dr. Sanjay Barik. And Dr. Prakhar Jain. I would like to call upon Dr. Mukesh Ledda sir to felicitate our chairpersons, Dr. Sumit Chaudhary sir and Dr. Samir Vidmute sir. Okay. With this, we would like to move on to our next session, which is on meniscus. For this, I'd like to invite our chairpersons, Dr. Dhananjay Deshmukh sir from Amravati, Dr. Tejas Waghela sir from Akola, and Dr. Vasant Gawande sir from Shalintai Mege, Wana Dongri.
Hello. I would like to invite Dr. Amit Savji for presenting why to save a meniscus.
Good morning, everyone. Thank you, Indian Arthroscopy Society, for giving me this for presentation. The topic on the why to save the meniscus. I am Dr. Amit Savji. So, why save the meniscus? It helps to dissipate the force encountered on articular cartilage while walking. When knee is on load, the meniscus divide equally load on joints, so it's prevent the cartilage damage. So basic anatomy is very important to know the for this. So the meniscus is come from the Greek word meniscos, meaning is crescent, which is the C-shaped structures. Meniscus are roughly triangular in cross section, covering 1/2 to 2/3 of anterior surface of corresponding tibial plateau. It attached with the anterior and posterior horn to the underlying bones with the tibial plateau. So meniscus microvasculature is very important. It's really said by the Arthroscopy in their literatures, with showing that there is a 3 zones of meniscus. One is red zone, red-white zone, and white zones. Mainly the peripheral capillar plexus present over the red zone and red-white zone, where we can repair it, and the prognosis is very better. It originates from the synovium M capsules. So there is some anatomical vasculature and cell population of the meniscus, where red zone, red-white zone, and white zone. Mainly the fibroblastic-like cells present in a red zone and red-white zone, and there is a chondrocyte cells present in a red-white zones. So let's move toward the function of the meniscus. What is the main function of the meniscus? Is load transmission. It transmits the load across the tibiofemoral joint, increase the congruency, therefore decrease the resultant stress force on the articular cartilage. So middle meniscus share 50% of load, and lateral meniscus share 70% of load. 50% of load transmit in extension, and 85% load in flexion. When we do a partial meniscectomy, so we decrease the contact area of meniscus by 10%, but it increases the load over knee joint by 65%, which is very significant. So there are some secondary function of meniscus also, like stability, shock absorption, lubrication, proprioception, and nutrition to the joints. So tear pattern, mainly we divide the meniscus into 2 tear patterns, like traumatic tear and degenerative tears. So traumatic tears, the repair is give better outcome with better techniques. So in traumatic tears, like young athlete, active individual, it mainly often associated with the ACL injuries, and there is a vertical and longitudinal tear, it gives good outcome after proper repair. There are some degenerative tears like mainly old age, age more than 40 or 50 years, where the joint is already arthritis, there is a malalignment of your joint, there is a minimal healing capacity, mainly in uncontrolled diabetes patient where musculature is compromised, or complex tear are unable to repair. So the beautiful paper by King et al. Meniscus has capability of healing if tear has access to the synovial blood supply. So we'll move to meniscectomy. It is the most common modality of treatment in meniscus symptom in patient above age of 40 years. It is a quick, reliable, usually return to activity rapidly. In 1948, Fairbank published a effect of complete paper on complete meniscectomy. However, more than 50% of partial meniscectomy will present with the chondral change in early 6 months of post-operative, and more than 50% of develop osteoarthritis in 10 to 20 years in follow-up. Another paper by Colling et al. In Arthritis Care in 2020, it compared the MRI changes of meniscal debridement versus not debridement patients. At 18 months of follow-up, MRI changes in articular surface could appreciate 60% of chondral damage or articular surface damage. So, the amount of removal of meniscus is the most important factor for development of osteoarthritis. In this graph, this shows that the resection of meniscal tissue, how much we resect the meniscal tissue, the increase the joints contact stress and lead to the progression of osteoarthritis. If you remove the 100% of meniscus, there is a increased contact stress over the 700%. So another paper by McDermott, the consequence of meniscectomy. The meniscectomy result in increase the peak contact pressure on the articular surface lead to the osteoarthritis. The another paper by the Martin show that change in articular cartilage follow the arthroscopic partial meniscectomy. In this paper, he conclude that there is an adverse effect of articular cartilage may lead to the increase the severity and size of cartilage lesion. Post-operative cartilage wear predominantly affect the middle compartment, also affect the other compartment of the knees. So why the meniscus repair is important? Because it restores the anatomy, knee kinematic, it provides some stability also, and decrease or may prevent the onset of osteoarthritis. So there are some indication, depends on prognosis of the patient. So win-win position, like if you tear in red zone or red-white zone, the healing capacity is very good. So this tear is repair is give better prognosis. Another win-win position for the tear on lateral side show the more healing capacity. Only failure literature show only 6% of failure rate on lateral side and 22% failure on middle side. If there is a long extended tear like from anterior horn body or to posterior horn like bucket handle tear, poor prognosis with repair, but with meniscectomy there are poorer prognosis. So repair is better option in long extended tear also. So in tear pattern like longitudinal tear, radial tear and horizontal tear, repair is better options. There are some contraindication for if there is a degenerative tears is present or age is more than 40 or 50 years. There is a malalignment of the joints. Some BMI is more than 35 or uncontrolled diabetes in old patients. So in their 2016, the Fearley et al. Conclude that the meniscus repair provide better long-term outcome as compared to the meniscectomy. So return to sports after meniscus repair is possible. Yes, meniscus repair do work and return to sports is possible. There are, last decade there is a Nakayama et al. Published a paper in 2017. After the middle meniscus repair, there is a 77% return to sports is possible, and lateral meniscus 82% return to sports is possible. Another paper in Margini et al. Showed that 89% return to sports is possible. So meniscus repair does work in a sports person and return to sports is possible. So meniscus repair survival analysis, another paper by the Silbold, he showed that the maximum meniscus repair failed within 2 years of post follow. 20% are failure in 2 years. This patient are mainly the indication is wrong indication, poor technique or degenerative meniscus. But once you pass the 2 years of the follow-up, there is no further failure or there is stop of failure. This is a beautiful paper by Pujol. meniscus resection after repair. If you repair the meniscus and it failed, then we need to go for the secondary meniscectomy. So in this paper it is published that there is a 84% less meniscectomy required for as compared to primary meniscectomy, and a chondral lesion is 52% less as compared to the primary meniscectomy. So another paper by the Stern is that meniscus repair versus meniscus resection. Meniscus repair show 80% less osteoarthritic changes as compared to the partial meniscectomy, and about 96% to pre-injury activity as compared to the primary partial meniscectomy. This is a meta-analysis over meniscus repair versus meniscectomy. Repair better outcome than the meniscectomy in long terms. Repair better activity level than the meniscectomy in long term, and meniscus repair lower failure rate as compared to the partial meniscectomy. This is the two tear patterns, that is root tears and ramp lesion, where the no role of meniscectomy. If you do meniscectomy, it is a disaster for the knee. It will act like the complete meniscectomy. So this two we need always to go for the repair. Then I conclude lastly that why save the meniscus? Saving the meniscus tissue is prime importance. The meniscus distributes stress evenly, which can help prevent the cartilage damage and development of osteoarthritis. So it prevents the osteoarthritis or stop the progression of osteoarthritis. It restores normal biomechanics. Meniscus repair is a high rate of success in correct patient and correct technique. With correct technique, meniscus repair show better outcome as compared to the meniscectomy. Thank you.
Now I invite Dr. Siddharth Jain for his talk on video techniques in all inside repair.
Anyone want to ask question?
Good morning to all of you. Thanks IAS, Arthroscopy Society Nagpur and Osteocare for giving me this opportunity to talk on all inside meniscus repair. So I'll be speaking on how we can effectively repair the meniscus through all inside technique. So as Dr. Amit Sahuji has nicely pointed out that it's very essential to repair the meniscus. You should go to save every bit of meniscus you should save. So previously meniscus was considered as vestigial. It was easier to resect than the repair. But in the recently, the studies have stabilized that the importance of meniscus, because removal or the resection lead to cartilage overloading that may subsequently lead to degeneration. So functions of meniscus is the load transfer, shock absorption, stress reduction, stabilization, and the lubrication. Blood supply, we all know very well that the red zone, definitely you need to repair. Red-white zone, you go for the repair. White-white zone is still very controversial. But so every meniscus should be repaired. Definitely we should take an appropriate decision. So what to be do with them? We can go for the supervised neglect. We can do partial or total meniscectomy, or we can repair it. Still elusive to us is the meniscal replacement, meniscal scaffold, and the meniscal transplant.
Repair of the meniscal injury is multifactorial that depends upon the age, activity level, and the meniscal related factor. I have just made a mnemonic of that, that amaltas means the age, morphology of the tear, location of the tear, tissue quality, associated injuries, maybe ACL or the PCL, or the stability of the tear. These are the various kind of tears. The parrot beak tear, horizontal, you can see the vertical, longitudinal, fraying only, complex sort of tear, which may include the vertical, horizontal, and the radial component, or the bucket handle kind of tear. Indication for the repair, definitely in the acute we should go for the repair. Vertical, longitudinal tear give good results. Peripheral red zone, if it is more than 7 to 10 mm, unstable kind of tear. Non-deformed viable tissues, concomitant reconstructive surgeries like the ACL, articular cartilage procedure, that definitely gives good result because you have a lot of hematoma inside the joint and it will help in the repair or in the regeneration of the meniscal tissue. And the patient ready for that is very much important because normally we keep the patient for more than 6 weeks non-weight wear in general consensus. So patient should be ready for that. So various techniques, biomechanics of the repair, that the vertical suture are better than the horizontal one, and the resolvable suture are better than the mulberry knots. So all inside repair, it is basically of two type, capsular based and the meniscal based repair. Capsular based repair, there are various kind of devices and their evolution is there. I'll just quickly go. So as you can see, it's a long vertical tear or longitudinal tear. Then you have to freshen up the edges properly, and then with the half spatula you can insert all inside device. First you should insert the device into the capsular part and you can check whether it is holding nicely or not. Then definitely you go for the inner side of the meniscal tissue. And each 5 to 7 mm of the difference you should be able to insert at least one device so that you can grab good amount of tissue and your construct will be stable. And that is again very necessary that you should not only apply the all inside device only on the upper surface of the meniscus, because then the tissue will get lift. So better you alternative, you can apply the all inside device on a inner surface of or the under surface of the meniscus also. So in that you can see that kind of repair. So this is a longitudinal tear but with the horizontal repair. So that was the vertical repair actually. These vertical repair is better than the horizontal repair, but horizontal repair is more cost effective. You can grab longer distance you can actually cover with that. So in a horizontal kind of repair, you have to with a single needle or in a single bite, you have to grab the inner part and the outer part also. Okay, so like that you can repair it if the tear is small. But when the tear is large longitudinal tear, definitely you should go for the vertical sutures. So this is a complex sort of tear. So again, the same thing, you have to, first you need to debride the various fraying through the diamond rasp. Then you have to freshen the edges. And you have to, first, it's more like a fracture reduction only. First you have to reduce the meniscal tissue. You should plan where you have to put the sutures, plan accordingly, and then you decide in which how much distance I have to put how many devices. And it's always better that you should not put all the devices on the upper surface. Always put some one or two alternate all inside sutures on the inner surface or the under surface also, so that the tissue should remain flat. And sometimes there will be some overlapping may be there, but it's okay. But you should grab the tissue properly and you should repair every bite of meniscus. In this way, you can repair the complex sort of tear. Various devices are available. So second is the meniscal based repair, in which you put take all your two sutures on the meniscal side only. So with these devices, you can take the sutures. So although the capsular based techniques with the anchors are useful, are successful, but the meniscal based repair avoid the incorporation of the capsule and thereby avoid the risk of the surrounding soft tissue and neurovascular structures. Advantage of not covering or constraining the meniscus motion can be used to address the multiple tear type in both the medial and the lateral meniscus. Allow for the 360-degree reduction and the compression of the meniscal tear without having a place repair device above and below the meniscus. Better meniscus control and the tear reduction through tensioning and tying the suture limb that are completely constrained within the meniscus. So meniscal based repair is like this. You can take the bite on the the inner peripheral side and the inner side, and then by using multiple sutures, you can tie those tears. In this way, you can take the bites and you can tie that and you can repair. So tips is the medial meniscus visualization with the 20 to 30 degree of the flexion, maximum external rotation. Lateral meniscus, figure of 4, lifting the foot up and pressing the knee so that the lateral compartment will be more open. You can change the portal according to your ease. Opening of the medial meniscus can be increased by pie crusting. So on the tibial side, I prefer to do on tibial side, but you can, some people prefer to do on the femoral side also. So in this way, you can increase the your visualization or increase the space of your working. Thank you. The key to success is the know your enemy, know your resources, and know the correct pathway. Thank you.
May I call upon next speaker, Dr. Sanjay Barik, to deliver his talk on inside-out repair of meniscus. Dr. Sanjay Barik.
A humble request to speakers to kindly stick to time. We are running way behind schedule.
Till the presentation is start, can I question Dr. Siddharjan regarding the complex tear? Is there any role of stays suture there so that the implant doesn't pull out while taking the bite in that? A role of pull out suture there in complex tears.
Yes, sir. As I told you, it's more like a fracture reduction. Whatever you can do there to hold the two fragments of the meniscus together, you can do that.
It is always better to take a pull out suture so that the implant doesn't go to waste for the youngsters.
Good morning, delegates. So, after all inside repair technique by my friend Siddharth, I would reprise you about another technique that is called the inside out meniscus repair. It has been considered as the gold standard of meniscus repair. Why it is considered gold standard? In my further slides, I will let you know. So basically, it is passing of the needles and sutures from inside the joint to outside, and here we take safety incisions to protect the neurovascular structures. So indications are quite extended in inside out technique as compared to outside in or all inside because of the multiple angled cannulas. But the most important indication is in the bucket handle tear in the body of the meniscus, where it is used as a reduction tool. So two types of all inside devices are available in market. The left side, it's an all inside device where we require less assistance because the surgeon can itself pass the needles through handheld device. On the right side, we have different angle cannulas which the surgeon holds, but the needles has to be passed by some other assistant in which the sutures are attached. So the assistant uses a needle holder to pass those needles, and it has to be a trained assistant to do those things. So since we are dealing with the posterior side in this, and the blind spot is in the posterior side, we are going from intra-articular part to the soft tissue part where neurovascular structures are there. So it is always advisable to take a medial safety incision in case of medial meniscus tear. So here the medial safety incision, it's a 3 to 4 centimeter incision with 2/3 extending down the joint line and 1/3 above the joint line, and it's a plane between the medial head of gastrocnemius and the posteromedial capsule for the medial side, where a spoon or retractor is placed to divert the needles. In this case, it protects the popliteal arteries and vessels. Laterally, it is more important because the neurovascular structures are more closer to the knee at the lateral side. So here the plane is developed between the lateral head of gastrocnemius and posteromedial capsule deep, where a spoon, the commonly kitchen spoon we can use, we place there so as to divert the needles, and it prevents the injury to the saphenous nerve, common peroneal nerve and the popliteal vessels. So why it is called the gold standard? Because it is very precise in giving the sutures, because we have multiple angled cannulas, so it helps in giving both horizontal and vertical matter sutures in both superior and inferior surface. The size of the needle is very less, hence the damage to the tissues is very less because the size of the needles being smaller. And it is the same reason why multiple sutures can be given for a particular size of tears due to the small size of needles. Hence, density of sutures is more and more stable, and early mobilization can be possible in this type of repair system. And as I said, it is very handy in case of bucket handle tear because it is cost effective, and the first suture, if you use the inside out technique, then it helps in accurate reduction because the size of the needles are small, and the cannula for the inside out needle helps in reduction of the bucket handle tear. So what the paper suggests that if we compare the reoperation rates across all the types of all inside and inside out repair, the reoperation rates were least in case of inside out repair. And when it was combined with ACL reconstruction, the healing rates further increased, and the reoperation rates was least in case of inside out repair. So this is how a inside out for the lateral meniscus is there. So this is a posterior horn of lateral meniscus tear. As a part of vascular hypervascular response, we do shaver and rasp. Then since the meniscus was large, tear was large, and lateral safety incision was first placed, and plane was developed between the gastrocnemius head and posterior medial capsule. Superficially, the plane is between the iliotibial band and the IT band and the biceps femoris, which retracts the peroneus and the peroneus nerves posteriorly. So this is the superficial dissection, and on deep dissection we can see the white glistening structure. It is the capsule from where the needles will be coming out, and hence this is the window where we keep the spoon to divert the needles. So this is the inside picture. We can see that precisely the tear was in T1 zone, and we can place two needles, one in the capsular side and another in the femoral side of the tibia, and another assistant on the outside. You can see retrieves the sutures, and we can tie sutures outside. So due to its versatility of angulation and the needles are flexible, so we can use it in both the superior and the inferior surface, and multiple vertical matrices can be applied. So these vertical matrices sutures, it holds the circumferential fibers in a most rigid way and helps in a more stable fixation and early mobilization. So this is another case. It's a medial sided tear. We can see that it's a bucket handle tear of the medial meniscus. First, the two initial sutures here I am using for reduction suture, and I have used inside out technique. So we can use it in a hybrid fashion along with outside in and all inside technique, and it adds to the good reduction, and also it decreases the total cost of surgery also. We can see how the cannula is used to manipulate and reduce the joint, and with a needle holder, a assistant pushes the needles inside the joint, inside the meniscus, and another assistant on the opposite side, it retrieves the needles. Here I am using only two sutures for reduction. That's why we don't use a safety incision. Rather, we tie after an incision at the end of the surgery. Here we can see how the vertical matrices, and this is an oblique matrice. Try to put vertical matrices. If not possible, then give oblique, and then horizontal matrices at the last because of the decreasing trend of the stability, as said by my friend Siddharth. So this is the last incision we give, and we tie all the sutures outside after the reduction has been attained. So once the reduction has been attained, the further sutures can be applied by all inside, outside in, and all inside technique. In complex tears, we can use it in a ripstop fashion in various configuration. We can see vertical and horizontal matrice sutures can be applied in a single patient, and it gives a most rigid fixation because horizontal, it captures more amount of the tissue, and vertical, it captures more amount of circumferential fibers. So we get the best of both the worlds. So this is very handy and useful in such type of complex tears. So there are certain risks are there, but pitfalls can be addressed through certain techniques, like for popliteal artery and branches, careful dissection and use of spoon and gastrocnemius head retraction helps in addressing and protecting the popliteal. Same with the saphenous nerve. The dissection, the saphenous nerve, for the protection of the saphenous nerve, we should keep in mind the incision should not be too much medial. It should be at the posterior border of the MCL. Should not be much posterior. Same with the common peroneal nerve, IT band and gastrocnemius, it protects the common peroneal nerve, and dissection should be done properly, keeping in this two in mind. And final thing is that we should not tie those sutures in complete flexion because it will cause catching of the knee. So it should be tightened at just sort of extension. So summary is, these are fine, precise needles, so no less tissue damage, but it provides the most stable fixation because of its versatility to use in both vitreous and vertical fashion in both superior and inferior surface of the menisci. Trained assistant are must, they should know what to do so that it decreases the surgical time. Multiple direction cannulas are there, hence it should be in the armamentarium of a surgeon who is dealing with meniscus injuries. It can be used in a hybrid fashion. And secondly, it is very cost effective and useful as a reduction suture in bucket handle tear, and it should always be kept in your armamentarium. Thank you.
Dr. Mukesh Ladda to present a video technique on ramp repair.
I must congratulate Neha for taking all the pains for arranging such a good IAS1 Connect program. Thanks Ramakant and Srinivas sir for coming all the way. So ramp lesion, I think we have jumped into it since last 2-3 years. Ramp, everyone should look into it. So this is what the normal anatomy as viewing from the Gilchrist view. The first side, which we all must used, and make it a point that whenever you do a normal scopy, everyone should go into posteromedial area every time and just use your needle to lift up and see whether there is anything. And this is the view from the posteromedial portal. This is the meniscus. This is the capsular fold, that is femoral condyle. As you extend the knee, the meniscus moves in and the whole of the capsule touches. And when you flex the knee again, you can see that the capsule is attached to the lower half of the meniscus on the tibial side, not on the upper half of the meniscus. And in flexion extension, and so when you extend it, it becomes tight, and when you flex it, it becomes lax. Why this normal anatomy is important, I'll get to you in my further slides. So in almost out of 4, 1 patient will have, so out of almost 25% of ACL tears will have this ramp lesion. And does it affect the outcome of your ACL reconstruction, or does it have any impact on the stability of the knee? I'll let you know. So what is the biomechanics? So we all know that ACL is the primary restraint to anterior tibial translation, but there are some secondary restraint, out of which meniscus plays a very vital role in giving stability. So there are many literatures which mentions if you do a total or near total meniscectomy in an ACL reconstruction, that ACL reconstruction also fails because the secondary stabilizers in form of meniscus is not there. And this is where, in case of gross pivot shift, you should look for anterolateral instability or ALL ligament tear, posterior horn lateral meniscus root tear, and the third pathology you should look is for ramp lesion. So always do evaluation under anesthesia and assess the grading of pivot shift so that you don't miss these associated lesions, which are very difficult to pick up on MRI as well. Classification we all know. And if you see, the classification also involves only the lower half of the capsule, nothing in the upper half of the capsule. So it's all tibial based classification, we may call it. How to do a diagnosis? Though MRI can pick up, but many times it is missed on MRI as well because it's very close towards the capsule. Some signal changes are seen. So most specific will be always using a Gilchrist view to go into the posterior medial portal and identify it. What on MRI? So you should diagnosis for, you should first have clinical high-grade pivot shift. Then you should see for secondary signs of some marrow edema in the posteromedial aspect. And if sometimes you are very lucky, you will be able to see ramp on MRI, but mainly it is still an arthroscopy based diagnosis. So this is what it looks like, a ramp lesions in the posteromedial aspect where it's complete capsular detachment from the meniscus area. Now don't confuse sometimes with this partial ramp where it's only the upper half, it's not completely discontinued from the lower half of the tibia. So these are quite stable ramps. You don't have to do anything to these things. And on probing the meniscus, if you see the meniscus is not mobile or it's not moving for more than 2 millimeters, which is very difficult. But posteromedial meniscus is usually immobile compared to lateral meniscus. So any sort of slight mobility of more than 2 I think we should go and fix the ramps. And if you find that there is nothing, so another patient, you see there is intact ramp here. So don't confuse the meniscocapsular separation with the ramp. This has to be repaired. Can't leave this. And see, the ramp is where it folds on the lower half of the capsule, not in the meniscocapsular. Various techniques have been described in the literature. Most of them, they go and view from the posterior portal, they work from the posterior medial portal, they use all suture, lasso and all shoulder instruments and take a knot. Some take simple knots, some takes shoelace type of technique as popularized by our own Dr. Sheetal Gupta from Bhopal. So he is doing a lot of work on it, and you see he takes multiple fiber wires, take a bite and park it. Another method by Dr. Milind Pimprikar from Nasik, he used suture anchors to place it on the inferior aspect of the on the tibial plateau, and then he repairs it. This is another shoelace technique which is quite cost effective. You can use a simple number 2 fiber wire and you can repair all that. But in all these techniques, what I found that you have to take a bite from the superior aspect of the meniscus as well. It's a sort of indirect repair of the whole capsule up anteriorly into the upper part of the meniscus. And what traditionally has been taught to us, anterior horn should be repaired in 90 degrees of flexion. The posterior should be repaired in as much as extension so that you don't over tight the capsule. So if you are repairing the anterior horn in complete extension and you try to flex, patient will have severe pain because the capsule is tight. So posterior third should be repaired in 0 to 30 degree and the anterior most should be into nearly 90 degree of flexion. But all these repairs we have to do into 90 degree of flexion. So we may be over tightening the capsular part here. All inside is what the way I do most of my meniscus repairs, including the ramp lesions. So this is the view from the posteromedial portal, and you can see that there is a full thickness ramp from the middle to the posteromedial aspect. So how you repair it? As you extend, as I told you, meniscus moves in. So I just do a slight pry-casting, as much you need. Don't do complete. Rarely you need that. Go and use the reverse curve all inside devices. So there is upper curve and reverse curve. So reverse curve device are very good, where you take the bite in the inferior half of the meniscus and then you can use 12 degree or 24 degree curved needles. Here I'll prefer to use 24 degree. You just move it down. Don't go this way. You can go this way in the meniscus, meniscus, and then you move around. The whole of the in all inside device pounds towards inferior aspect, and then you can tight it. And if you feel like, you can do a horizontal stitch also, because healing is not going to be an issue in that part of the meniscus. You just need to keep it, holding it in a place. You can even use, as you see, my needle is pointing completely towards the tibia. So you may have to use a little high anteromedial portal, or you may come from the opposite side, and you can just fix it. And this is what it looks like once you repaired posterior. And again, the same patient, you can see the posteromedial view. You have repaired the most anatomical way, I feel. Maybe wrong, but I feel that I have repaired only the inferior aspect where it has been torn, and it is not an indirect repair. It's a direct repair using all inside meniscus device. Same another patient, can always go into the posteromedial, feel it, do certain pie crusting if you need, and you can see it's a complex one. You have a longitudinal tear in the posterior part of the meniscus as well as the ramp. So these are again difficult to go with your suture shuttle devices and all. So here you can tackle both this peripheral tear this one, as well as the ramp, again by going very high and inferior on the tibia and then catching hold of it and repairing it very well. Another patient with the same, again, the important is keep that 24-degree curved angle all inside devices in your armamentarium, and you can do as many cases with this. There is something called as zip lesions, which is I may say a sister concern or a brother concern of the meniscus on the posterolateral aspect. So always see that, because lateral meniscus is more mobile, and this is one of my patients who had ramp lesion on the posteromedial, or you may say the capsular region, as well as the zip lesion. So you may see that there is a posterolateral capsular injury, and these are also very mobile. So I use here suction test. Just put the suction in the lateral compartment on it. The meniscus collapse. That means that is a very unstable meniscus. So you need to put the anchors. I always prefer all inside as far as the posterolateral aspect is concerned, and see that the length of the needle should be somewhere around 14 to 16 mm only, so that you don't damage the neurovascular structures. And you can have a horizontal stitch, vertical stitch, depending on the financial aspect of the patient, but these are very handy, and you can finish the job without taking any additional morbidity in form of posteromedial or posterolateral incisions, and you can have excellent result. These are zip lesion. So we all know that ramp lesions, biomechanical studies have shown that they increase knee laxity, but that their repair may restore is still under investigation. But you have to probe it and see if it is mobile, posteromedial, go and repair it. My preferred technique is all inside. Thank you.
The next talk would be by Dr. Prashant Bhavani on video techniques in root repair.
Good morning, everyone. I will discuss about the meniscus root repair, a video technique. So definition, the meniscus root tear is considered when there is a bony avulsion of the roots of the meniscus, and when there is a complete radial tear within 1 centimeter of the attachment. So epidemiology, the meniscal tear accounts for about 10 to 21% of all meniscal tears, and medial meniscus root tears occurs mainly commonly in older and female patients, in obese patients, and it is age-related degeneration. Whereas lateral meniscus root tears occurs mainly commonly in younger male patient, and it is due to acute trauma, and it is associated with multiple ligament injuries. And studies have shown that it is 10.3 times more commonly associated with the ACL tear. And what happens when there is a root tears? So as we all know that there are longitudinal circumferential collagen fibers which are more important. They converts the compression force across the joint to circumferential hoop stresses. So here the roots anchors the meniscus and helps in this conversion of the forces. That is how the roots are very important. If there is a tear, it leads to altered joint kinematics and also increases the contact pressure, which ultimately leads to the cartilage degeneration and in turn leads to osteoarthritis of the knee. So it is, when there is a root tear, it is biomechanically considered as a total meniscectomy. So we should know the proper anatomy of the footprint of the roots to anatomically reconstruct the root tears. So you can see on the picture, the medial posterior root attachment is 11.5 mm posterior to the apex of the medial tibial eminence, whereas the lateral posterior root attachment is 5.3 mm posterior to the apex of the lateral tibial eminence. Coming to the anterior roots, the medial anterior root attachment, it is 27 mm posterior to the tibial tuberosity, and it is 18.2 mm anterior to the center point of the tibial ACL footprint. Lateral anterior root attachment, it is 14.4 mm anterior to the lateral tibial eminence, and it is 5 mm anterior to the tibial ACL footprint. It is very important to know about the footprint anatomy. Coming to the classification, which is given by Leprard et al., it is divided into 5 types. Type 1 is a partial stable tear, and type 2 is when there is a complete radial tear within 1 centimeter, which is again divided into 2A, 2B, and 2C. 2A is when there is a tear between the 0 and 3 mm. 2B is when there is a tear in 3 to 6 mm, and 2C is 6 to 9 mm. And the third type when it is associated with the bucket handle tear, and the fourth type is when there is an oblique tear, and the fifth type is bony avulsion. So what are the instruments we need while doing a root repairs? So this is the meniscal scorpion, or you can use the first pass mini to take a bites through the torn roots, and these are the fiber wires, and you can also use the fiber tapes, and ring curette to decorticate the articular cartilage at the footprint to achieve a cancellous bone bed, and bead pin and 4.5 mm cannulated drill bit. And this is the meniscal jig. You can see the anterior part has a concave surface which helps in easy introduction into the joint, and it has got a blunt tip which also prevents the tibial articular cartilage. If there is no meniscal jig, we can use the tibial ACL jig also. So I'll discuss briefly about the surgical steps. Portals, what is different while repairing a root tears is we should be very close. The routine anteromedial and anterolateral portals should be made very close to the patellar tendon and at the level of the joint above the meniscus, because if you make far medial or far lateral, it is very difficult to reach to the footprints. And what you have to do while doing a diagnostic round, we should always probe the root meniscal roots, because most of the time we may miss the root tears. So always root tears, you repair the root tears before the ACL reconstruction. And if you come across a tight joint, you can do MCL pie casting to increase the joint space and assess the reducibility with the grasper, and decorticate with the ring curette, and take minimum 2 bites, and pass the suture tape, make the tibial tunnels with the ACL jig or the meniscal jig, and shuttle the sutures through the tibial tunnels and fix those sutures onto the anterior tibial cortex. So coming to the case, we had a case, a 20-year-old female active individual came to us with a pain and instability, which was 2 months old, and there was a history of twisting injury due to slip. And on examination, Lachman was positive, anterior droid test was positive, and lateral joint line tenderness was present, and McMurray positive. So we got X-ray, which was normal, and we did an MRI, and there was a increased signal intensity in the posterior horn of the lateral meniscus, and on coronal sections we saw there was a lateral meniscus extrusion. So this is on sagittal view, there was a complete ACL tear. So we took the patient. So after creating the portals, we saw that there was a complete ACL tear. And there was a radial tear which is very near to the root. It was a lateral meniscus root tear. And we did a partial meniscectomy, the other flap, the flap which is away from the root, and we assessed for the reducibility of the root. With the help of first pass mini, we took a bite on the flap which is away from the attachment. We planned to repair this radial tear side to side. So we took a bite on the flap away from the tear, and this is the flap which is near to the attachment. And fiber tape is shuttled. And the third bite again we took to reduce the meniscus through the flap which is away from the attachment. And another suture tape is passed and a cinch is made. And with the help of ACL jig, we had prepared the tibial tunnels, which is not shown in this video. And after preparing the tunnels, we inserted a shuttling suture through the tibial tunnel, and we took out the loop through the anteromedial portal, and we shuttled both the suture tapes through the tibial tunnel. So this was the shuttling suture. We shuttled through the tibial tunnels and we fixed on the anterior cortex with the endo button. So this was the final picture of the ACL reconstruction, and this is a video of stable repaired meniscus which was stable. And this was the post-op X-ray. We can see the tibial tunnels. The tunnel for the ACL meniscal root is lateral to the ACL tunnel. And this was the second case, 49-year-old, had a history of RTA. Patient came to us with a pain at the instability. Anterior rotator Lashman test and lateral joint line tenderness was present. McMurray positive. X-ray was normal, and MRI showed tear in the posterior horn of the lateral meniscus, which was vertical, and there was a complete ACL tear. This is the intraoperative picture. There was a root tear of the lateral meniscus, and there was a complete ACL tear. So this is another video. So there was a complete ACL tear and posterior root lateral meniscus tear. We did a debridement of the area at the footprint, and with the help of the ring curate, we decorticated to create a cancellous bed and assess the reducibility of the root to its bed. And with the help of ACL jig, we created a tunnel through the bed with the help of 4.5 cannulated drill bit, and we took a bite from the torn side. We use the 2 suture tape here, and with the help of bead pin, where the number 2 ethibond was threaded, it was used for shuttling the 2 suture tapes through the tibial tunnel, and they were taken out through the tibial tunnels and fixed with the endo button over the antitibial cortex. And next we proceeded with the ACL reconstruction, which I will not discuss. So this was the post-op X-ray. Post-op rehabilitation. Patient remains non-weight bearing for 6 weeks, and passive ROM allowed during first 2 weeks only up to 45 to 90 degrees. After 2 weeks, range of motion was allowed as tolerated. Progressive advancement to full weight bearing begins only after 6 weeks, and deep leg press and squats more than 70 degree of knee flexion was avoided for at least 4 months. Take home message: meniscal root tears are not uncommon. It accounts for 10 to 21%, and biomechanically it is considered as a total meniscectomy. Always probe the meniscal roots. You may miss the meniscal roots if you don't probe it. And knowledge of the footprint anatomy is must for the anatomical reconstruction. Transtibial pull-out fixation is the gold standard, and meniscal root repair gives better clinical outcome. So you should go for a root repair rather than meniscectomy or conservative treatment. Thank you.
Next talk on radial tear, not a nightmare, by Dr. Ramakansa.
Morning once again. First, I would like to thank Dr. Mukesh Ladda and Neha for this opportunity to share some of our experience from these complex radial tears. I'm from Ganga Hospital, Coimbatore. So in this talk, I'll be covering the type classification, how to identify the repair techniques, and the salvage of the root. So radial tear is a perpendicular orientation. It divides the meniscus into 2 halves. It can be seen in the traumatic or in the degenerative process. And the classification is very simple: 1 to 3. 1 is just white zone, red-white, and then red complete is type 3. 4 and 5 are depending on the amount of the separation, that is less than 3 mm or more than 3 mm for the sake of convenience and for the technique, 4 and 5. So there are other classifications also: 50% of thickness, type A, or a simple split more than 50%, or there can be a flap or L-shaped tear like a B2, or there will be a complete tear with the separation, or it can be associated with a bucket handle tear. So some of the complex radial tears can be like L-shaped tear. One side it is peripheral longitudinal with the vertical split, or the T-shaped tears. So the MRI identification is similar to the root tear identification from the truncation sign, cleft sign, marginal, and the ghost sign. The truncation sign, when the section goes through the tear like this, it shows the truncated sign. The cleft sign is when it's perpendicular, the section is perpendicular, we can see like a bow tie or a cleft sign, or it is oblique, then we can see in 3 different sections this cleft sign, or a ghost sign when there is a in the posterior horn we can see that as a ghost sign. So the type 1 is simple, just trim off the white zone, and the incomplete radial tear is made into deep C shape. And type 2 tears with 50% or more than 50%, we'll have 3 techniques to do. All the 3 techniques can be tied. So the first technique is just with the knee scorpion, side to side, we can take bites and then put the knots. So side to side repair. So this is all suture, there is no implant, all inside and all suture. The other technique is when it's near the body, we can do this inside out technique with 2 inside out needles and tying the knots over the capsule. Or the all inside devices, when it is there in the posterior horn, we can use the all inside devices like osteo stitch from the Osteocare can also be used. So some of the case examples, so this is the radial tear, it's a kind of a complex tear with a T-shaped tear. So first what was done was side to side bites were taken, and then as we tighten it, invariably this overlap happens. But we know that the overlap will not heal, since it is not the raw surface like in the fracture fixation. So we can trim the lower part, and then we can use the combination of techniques like side to side, and then the all inside device can be used to approximate the edges. So this gives the approximation, and then we slowly, when we pull the threads, we can see that C-shape configuration reappears. So, but we should not excise too much of tissue, otherwise it will get cut through. So that was the one of the repair, or we can use it in a crisscross fashion that will give more stability as well. So in the like a first case, similarly the side to side stitches were taken in the similar fashion, and the knots were tied. We can see the good approximation of the tissue, and then to provide more stable fixation, we can also try to form the crisscross pattern with the all inside device. So using the all inside device for the posterior horn, this not only does the side to side approximation, but also the approximation to the capsule. Okay, then slowly we tightened it, and then we can see that crisscross fashion of approximation. This gives a robust good repair. So, and then the edges are trimmed. So when there is near the body or in the posterior horn with more than around 3 mm separation for type 3 or type 4 tears, we can do this ripstop suture, hashtag, cross tag, or rebar bag or tie grip kind of fixation. We can use the combination of techniques like inside out or the side to side technique. So this is a case which had the partial discoid with the radial tear in the body, and we can see the popliteus tendon here. So that was around that popliteus tendon, so making it inherently unstable because we don't have the capsular attachment there. So for this case, the partial discoid for the anterior and the body was excised to form a C-shape kind of lateral meniscus, and then in this case the inside out was used, the 2 inside out stitches was taken, and then the vertical stitch was taken. So actually what they recommend is, first if we take the vertical stitch and then the horizontal stitch, the cutout of the horizontal stitch is better, but in this case luckily I didn't have the cutout of the horizontal stitch. So and then the two vertical stitches through the inside out technique was taken, and then it was approximated. So this forms the hashtag configuration. This gives a robust, stable kind of repair. So radial tears are notorious for failures. So when we give a good repair in the hashtag, it heals really well, and then we can save the meniscus. Okay, so when there is more than 3 mm, of when there is a less than 3 mm and then we want a good approximation, first the reduction stitch can be applied to the capsule, and then the hashtag configuration can be done. When there is more than 3 mm separation, then the capsular release will help in good approximation because we need to get the approximation well. So this is another case. This was a type 4 Laprade, that is radial oblique tear. So you can see that radial oblique tear, but it was a long duration. It was more than for 8 months. So first what I tried was to do a side to side approximation. Each time I pull it, it used to get cut through. So twice or thrice I did it, and then it got cut through. So it means that, see, as I tighten it for the approximation, it gets cut through. So this was not able to salvage, and each time the meniscus quality was poor. And so the medial fragment was excised, and it was an on-table decision to do a root reconstruction. So like a root tear, transtibial tunnel was drilled to the footprint. The shuttle threads were taken into the medial aspect of the meniscus. The gracilis graft was harvested, and then the gracilis was used for a root reconstruction. So this radial oblique tear, it was very flimsy fragment, and then it was not holding the sutures, and then each time it was getting cut through. So the root reconstruction was done in this fashion. This is a gracilis graft. It substitutes for the loss of the meniscal tissue, and it acts like a collagen and filler, and then the hoop stress will be restored by this manner. And then this was tied, and anteriorly in the tibia, the interference screw was used to fix it. So this was the interference screw. Anteriorly, the gracilis graft was fixed. So this is the salvage technique. Initially we didn't expect it, but it was an on-table decision to do a root reconstruction. So when we see this kind of flimsy fragment, especially who presents little late, and this was a degenerative tear. And the cartilage was, there was a cartilage changes was there. It was grade 2 to grade 3, like around 50% of cartilage was there, and patient was saying, and alignment was normal. It was around 2 degree of constitutional varus was there, so there was no need for a HTU in this patient. So the take-home message is radial tears cuts the meniscus into medial half and the lateral half. It is circumferential fibers are cut, so needs a robot fixation. Repair depends on the tear morphology. Simple tears, we can use all the 3 combinations of side to side, all inside device or inside out can be done. Higher grade tears, like when there is a separation of 3 mm or more than 3 mm, hashtag will provide the stable fixation. And for poor tissue quality of the radial fragment, root reconstruction with gracilis is the salvage procedure. Thank you. I would like to welcome you all for a Ganga foot and ankle instructional course. This will be a basic course, and live surgeries, we are planning for around 10 live surgeries, and basic instructional course lectures which will cover topics in trauma, in foot and ankle, sports medicine, minimally invasive surgeries, and deformities. Thank you.
Next talk is by Dr. Manoj Pavkar on enhancing meniscus healing.
So very good morning to all of you. First of all, I'd like to thank IAS for giving me this opportunity, especially Dr. Neha. So after these excellent techniques which we have learned for various meniscal pathologies, so my talk will be on enhancing meniscal healing. And we very often come across this situation. We have done a meniscal repair, that patient is coming back to us repeatedly. We say that it is healing, there is no pain, then he goes to another and MR has been done, and we see that the meniscus has not healed very well. So in fact, are we, after this technique, we are really so good that we are able to give 100% results? So in reality, it is not. We try to brag our results. So almost around 20%, that is 4 out of 5 patients will be unhappy patients after the meniscal repair. They will not have a good healing, especially if they are isolated one, and especially on the medial side. That is the amount of 20% failure rate, irrespective of whatever the technique which you are using. So we all know about this avascular zone, vascular zones, and we have certainly moved away from the meniscectomy which we used to do with the meniscal repair nowadays. And what has totally changed our understanding of meniscal healing is the amount of healing whenever it is treated with the concomitant ACL reconstructions. So what is there another factor which has helped in meniscal healing in those situations has started our thinking about various factors of meniscal healing. This is another important slide we usually try to neglect for meniscal problem. Nicotine, it certainly inhibits this cell proliferation, chondrocyte metabolism, and it affects the healing potential of this meniscus. We all know that bone to bone healing is quite easy to do, then bone to tendon, then tendon to tendon gets more difficult, and most challenging for orthopedic field is the meniscus to meniscus healing. It's like a fracture or non-union. You just give a good mechanical stability and try to augment it with the biologics. That's the next level of thinking. So we need to have various other avenues for us to have a good meniscus healing, and we need to adapt those newer things apart from the whatever techniques which we are used. So there are 2 generations of techniques. One are the first generation which we already know, that's just simply meniscal rasping, important step, then trephination of the meniscus, then rasping this parameniscal synovium, the microfracture in the intercondylar. These are the very standard, and we all know these techniques, we should try to use it. Then there are second generation techniques which has been developed nowadays, like the fibrin clots. We all know we can make it and use it, the PRPs, the BMAC, the bone marrow aspirates, and then the newer these stem cells or this adipose tissue microfragmented. These are another additional thing which is happening. And the currently even the biomaterial, the synthetic, the allografts, they are also helpful in meniscal healing. So, but we never know that all these things do have a meniscogenic property. We know about the osteogenic or chondrogenic properties. Because of the architecture marvel, it is meniscus is made up of a lot of different kind of fibers which are oriented. We need to have a good result as to have these growth factors so as to stimulate the healing in those meniscus. The very basic meniscal rasping already we have seen in many videos, especially Siddharth has shown very well that meniscal rasping of that tissue is very important. What it does, it promotes the neovascularization, it increases the growth factors. And even this trephination, it could form the channels from which the avascular zone get into the vascular zone. So you have to improve this scar tissue, and healing biological enhancement is very important. Another very simple technique which we all know is the trephination of meniscus. You just needle it, especially for the very small meniscal tear which we cannot repair it. We just needle this around the joint lining and into the substance of meniscus. What it does, it creates a scar tissue, forms a small blood clot, and it increases the healing potential. Another very easy technique, very important to do, and at least this should be done whenever you find any this meniscal, the complex tears. Is easy and very straightforward. Anybody can do it. It's very cost effective. This bone marrow venting, these bone marrow elements getting attached, this clot formation, and this helps in meniscal healing is very important. And it has certainly showed if there is isolated meniscal tear with this bone marrow venting, with these microfractures, the chances of healing are as equal as their associated concomitant ACL reconstruction which has been done. Then we all know about this fibrin clot. We have been sometimes using it in the cases we feel that there are some irreparable repair or there is a avascular zone, white. We know that though we have repaired it, sometimes we will not be able to appreciate whether that will heal or not. So you need to prepare it with the venous blood. You need to get this inside properly. There are problems with this thing. This is very loose, very fragile. While passing, sometimes it get dislodged, it get dissolved, it may not sit properly on that the proper tear. There are certainly technical difficulties, but this is just one of the promising thing which we could do with using some kind of this passport cannulas. We can just railroad this fibrin clot if you have prepared it. Also that bone marrow aspirate which you can take, and that also can give a good fibrin clot or a venous blood, simply anesthetist can drawing it. So this is another simple technique. This sometimes will be very useful in healing. This is a good study which has been presented in Indian this journal, and it has shown a very good potential healing. Then the controversy regarding PRP injection, we all know that it is still doubtful in this meniscal healing. A lot of meta-analysis has been done and it has shown no difference in changes, not a game changer. I usually don't advocate it. Then there are these newer things, this certainly bone marrow aspirate concentrates, these clots, they certainly have got few osteogenic, chondrogenic properties, though there will be some donor side morbidity, but they do have a, this promising result. Then these stem cells, adipose cells, these you need to harvest in like a 2-stage procedure, but these are again just under research. They do have like 2-stage, you need to do it, though they are very less painful, but they certainly have a very good yield. And we will need further good research, especially of these two products, whether they are really useful or not. And finally, the newer things like a step beyond repair, we have just come across with like in the cuff tears, the various patches which are available, like you just simply can put a facial sheet to cover this nanofibrous woven material can be applied. And certainly this CMI, the collagen meniscal implant, it has shown certainly a good positive result in this meniscal healing. So this is a final video which I like to say, just like this, this complex, this meniscal tear. We all know about the various simple standard techniques. This is the kind of patch which has been now available, not in India I think at the moment, but this patch, just like the rotator cuff patch, we can make. And this we need to introduce along with your repair. So already, like the previous speaker has shown, a very complex radial tear. The standard whatever our techniques which we use, we need to do the accordingly. Just reduce this initial fixation is very important. Anatomical good alignment along with the circumferential compression, that becomes a primary. Then introduction of this biosynthetic material. They could be natural, they could be synthetic, the various collagen, this simple facial shears, they can be introduced along with this thing. You need to just give a good stability of these newer materials inside this thing. And they do have, like these are again under research studies, they again have not proven any benefit or still, though they are promising, but certainly like there will be some more time for them to like become very easily viable and to have a good final long-term results with this kind of materials. But this certainly gives a good, like in a non-Indian we say bone graft or something like that. For the meniscal healing, this could be additional adjuncts which we could come across and could be very useful in near future. So we are definitely moved to the better result, the best results with all these good repair techniques and the healing potential. But certainly this ABC of meniscal repair, like apart from the biological augmentation, you should have a good anatomical reduction, good circumferential progression. That only gives you the best of the results for the meniscal to heal. Thank you very much for your kind attention.
Next talk is on meniscectomy by Dr. Abhinav Jogani.
A very good afternoon to everyone. I think pretty much my talk has 90% been covered in the previous two, because I'll try and be quick. I'll just go through whatever I have prepared for the talk. A big thank you to IAS, ASN, Neha ma'am for giving me the opportunity to present my work, present the talk. Meniscectomy, when is it needed? Certainly in 1897 came with a theory that menisci are functionless muscle remnants and their complete removal would cause normal kinematics without any consequences. And the approach, well, why look through a hole when you can open the door? Rampant, excessive, open total meniscectomies were done through the 19th centuries up to the early 20th centuries. To the extent that McMurray in 1942 published that insufficient removal of meniscus is the cause of failure of meniscectomies. So it was done rampantly. But as Hippocrates has said, everything in excess is opposed to nature. So Fairbanks in 1948 published a study of 107 patients with a 21-year follow-up, where he showed more than 80% of severe osteoarthritis with a relative risk of 14. So this study changed our approach to dealing with the meniscus tears. The knee joint biomechanics is a homeostatic system with an intrinsic equilibrium. The function is in direct relation to the amount of residual meniscal tissue that is there in the knee joint. So removing a meniscus partially or totally has implications on knee kinematics and load distribution. So removal of a 30% of meniscus causes increase in contact pressures up to about 350%. And just going through the vascular anatomy, which has already been discussed by Arthroscopy, has described the red-white and the white-white zones. We all know that the peripheral red-red tears are more likely to heal. Moving on to the function, as already been discussed, shock absorber, it acts in increasing the surface area and decreasing the stress. So if there is a meniscus tear, it decreases the contact area and it may lead to an early joint degeneration. So repair or resect. Meniscectomy is a critical point for the destiny of the knee and the patient's quality of life. ESCA came up with a meniscus concession in 2020 where they said preserve the meniscus wherever possible. They defined various extended indications of repair. But meniscus repair are still a new toy in the surgeon's hands. Good functional outcomes, but reoperation rates as high as 21 to 24% have already been reported. They have a prolonged rehab which delays a return to sports. They are expensive and of course they are technically demanding. But on the other hand, meniscectomy affects the hoop stresses. So early onset degeneration is there due to an increased cartilage breakdown. It is cheaper, it is technically less demanding, and it causes shorter rehab with an early return to play. So repair or resect, ultimately the question is what to do. So first and foremost, we need to decide the indication for surgery. If there is a meniscus tear, a patient with a persistent pain, mechanical symptoms, and who fails conservative management, you have to go in for a surgery. And then you have to determine an individualized treatment plan based upon the patient characteristics, tear characteristics, and concurrent factors. Now let's see each of them individually. The patient, when they are of an older age, the meniscus has a lesser cellularity and a poor healing potential. The cartilage status, if there is a significant pre-existing OA, it is a contraindication to resection. But traumatic meniscal tears, which cause meniscal symptoms, can still be resected. Obesity is known to be causing an increased stress on the cartilage and failures of meniscectomies. So meniscectomies are contraindicated in hyperobese patients. And if a patient is unwilling for a prolonged rehab, then you can always offer a good partial meniscectomy to those patients. Moving on to the tear characteristics, the location, avascular white-white zone, chronic tears with signs of delamination and degenerative in etiology can always be given an option of meniscectomy. Then we have to assess the morphology of the tear. So unstable longitudinal tears more than 20 mm in diameter, which are displaced into the joint and irreducible, or which include chronic bucket handle tears, can be resected. Moving on to horizontal tears are early degenerative tears, and in these cases the shear forces are responsible for making a successful repair very unlikely. So you can resect them back to a stable peripheral margin as far as possible. Moving on to flap tears, they are a challenge to identify. You need to carefully probe the inferior surface to identify whether there is any flipped fragment of the meniscus, and you need to reduce into the joint and then debride. Advanced complex degenerative tears have multiple planes of disruption. They have an associated cartilage damage in older patients, and you can do an initial debridement of severely damaged tissue to assess and try and repair whatever you can repair in those complex tears. Radial tears are, they have perpendicular to the circumferential fibers, as has been very nicely explained by Ramakant sir. If there is less than 60% involvement of the meniscus, then the fibers are not, circumferential fibers are not affected and you can resect. But if the involvement is more than 90%, if there is a loss of function, then you have to go in and repair the radial tears. Moving on to root tears, they also defunction the meniscus pretty much like your radial tears. Return of function can be done only and only with a repair. The decision finally is taken based on the age and the cartilage integrity. So young patient with an intact cartilage, you can always give a trial of repair. If there is an older patient with cartilage degeneration, you could offer them a resection of the meniscus. Concomitant factors. So if an ACL deficient knee is there, it is an absolute contraindication to repair because it will cause abnormal kinematics which will not help the repair to heal. On the other hand, resection of the meniscus in an ACL deficiency is associated with poor outcomes and an increased risk of osteoarthritis. So concomitant ACL reconstruction is known to be increasing the healing due to a release of growth factors and helps in having better results of a meniscal repair. So basically, if you have to go in and do a meniscectomy, the principles have to be followed. Evaluate the anatomy of the entire tear to visualize and plan the resection. The goal is always remove a damaged meniscal tissue and leave a stable peripheral rim. Contour and smoothen the normal meniscus around the department to ensure there are no flaps or corners, and you can use a motorized shaver or basket forceps, whatever you feel is appropriate. So finally, take home message, we have moved the pendulum from meniscal tear equal to meniscectomy to save the meniscus at all costs. Knowledge and understanding of anatomical structures, vascularity, biomechanics and tear pattern is critical. Dedicated instrumentation and actions to obtain a better visualization to avoid inadequate meniscus removal or iatrogenic damages is very essential, and the goal is to remove a damaged meniscal tissue, leaving a stable peripheral rim. So finally, let's try and answer the question in a nutshell. You've got a patient who's got a meniscal tear. First, assess the patient. If the patient has an age above 30 years, traumatic tear with mechanical meniscal symptoms, a chronic ACL deficient knee, and he is not willing for a rehab, go in when you do a meniscectomy. Coming back, assess the tear. If the tear is a degenerative and a chronic tear more than 8 to 12 weeks, if the size is about 20 mm, if the location is in the white zone, then assess the morphology of the tear. Morphology, horizontal tear, flap tear, radial tear, some parts of a multiplanar tear, and a degenerative locked bucket handle tear. These are my references. Finally, I would like to quote Laprade, meniscectomy will diminish significantly when regeneration, repair and transplantation reaches the highest level, but now is not the time.
Thank you, Dr. Abhinav. Since you have finished your talk with a question, I would recommend you to stay on the stage because we have a certain change of plan. We request all the other speakers as well to come on the dais, and any questions from the August gathering is all welcome. Maybe I'll just start with one question for Dr. Siddharth Jain and Dr. Mukesh Ladda, since you all spoke of all inside devices. Just for the sake of the audience, what are your tips and tricks to prevent wastage of these all suture anchors, because they are so expensive? So how would you use them so that you don't lead to pull out or cut through?
So for that, don't use them in acute tears because the capsule is too flimsy. It will cut out very fast. If you are going in for some reason within say 2 weeks to ACL reconstruction, find the tears. We'll see how flimsy is the capsule. If it's not, then use it. Secondly, see that you follow the instructions given by the particular company. Make it proper at 12 degree, 10 mm, 20 mm, whatever you feel. Use the half spoon so that you don't get entangled in the the fat area. See that when you enter into the joint, tip of the needle is towards the spoon. Secondly, when you pierce, be very gentle. Don't pierce. Very gentle. The stopper is there. That too much. Stopper will also damage some capsular tissue. See the capsular tissue comes. Go gently. Do and you are using. They have certain specific click sounds or some button which is completely deployed. When you are coming out, very gently pull your hand. Just twisting movement. Just don't, so that you don't dip. Once you take the another bite in the meniscus, don't pull the reduction at all. Use your probe. Reduce the meniscus towards the capsule. With the probe, keep it reduced so that it does.
Anything else that you would like to add, Dr. Siddharth?
It's has told everything, so I don't have anything to
Yeah.
add.
Now, all excellent points by Dr. Mukesh. Just one thing that I do is, this is all since we all have wasted some anchors initially in our career, and we sometimes waste now as well, especially ramp, which has a flimsy capsular tissue where you can just do a posterior medial stitch. So instead of we are all used to using all handheld instruments like this. I use that white like a pen. So I dart it there and I use that. And since the time I have shifted to this, my wastage of anchors has reduced. Yeah. Yeah. Yeah.
So it is not recommended.
Yes. So sir, you use the spoon and then you go there, you pierce it, and then with your orange or whatever, the large handle, and then you go to the white one and then you pierce. I mean, this is how I have.
Yeah, I have
Yes.
one point to add.
Sure.
Like as Dr. Mukesh Ladda told that using the probe is a very important step. So once you have used the probe and then tightened the, the meniscus, one more step is like these cutters usually come with the, the knot can be still tightened a little bit. So this also helps, before cutting the, the plunger, pushing the plunger for cutting, before cutting, we can use this as a pusher as well. So that will, give good grip on the meniscus, and then that prevents that cheese cutting effect also.
Sure.
Can add the suction suture also there to pull the
That's
meniscus.
initial for bucket handle large and displaced.
Dr. Ramakant, I had a question for you as well. I've just written down some stuff, so I will just ask first. So what is your take on the unhappy triad, the new unhappy triad, since you spoke on radial tears? So what would be your sequence of repair for a Elmort unhappy triad?
That is with the MCL, you mean?
So that's the lateral meniscus oblique root tear with a ramp medial meniscus and an ACL.
Okay. So first we do the medial meniscus and then the lateral meniscus. If it is with the ACL, then first we always do the ACL tunnel first and then do the repairs for the both medial and the lateral.
And do you have any experience of using the transosseous repair through the ACL tunnel itself for the lateral meniscus? Have you tried that? Anyone of y'all?
No, I take a separate tunnel.
It should be a separate tunnel because if you take through the ACL tunnel, you may take that in a very short female where the width is too small, but then on anatomy, there are chances that it will re-tear.
Too much anterior.
And if you have both side tears, I'll do femoral tunnel first, do the lateral meniscus because you have to go in figure of 4, and then for meniscus posterior it's just 30 degree. I do the other.
That's very important point. Femoral tunnel first and then the meniscus repair.
Yeah. I had one more question for root repair for Dr. Bhavani. So in your talk you showed us that you use these cinches. Now, I am a little worried of using 2 tapes with cinches with these large bulbous knots which would actually not put the root onto the footprint. Because you have these 2 tapes, right? And you have these bulbous knots, and now you're going through the tunnel. When you're going through the tunnel, you have the meniscus is lifted off. So, are you worried for that, or you feel that that is good enough for you? Like, because Laprade is now talking of not using cinches and just using like a pull-out suture. And I've been doing that. But so I just wanted to ask. Anyone can answer as well, but Dr. Bhavani.
If there is a bulbous part of the meniscus, meniscectomy.
So I'm talking about the tape. The tape becomes so bulbous that it does not, because our whole idea is that we want it to be fixed onto your prepared footprint.
The knot becomes bulbous.
So instead of the cinch or the loop, simple stitches. So, I mean,
It's a fresh one. You're not getting cut through. You can. I feel a little beyond.
So to get it onto the bed, what you can do instead of just simple stitches like in a root fix anchor, which you can use a sliding knot like the shoulder surgery we do know. So that sliding knot, it sits on the bed and it compresses also because there is a root fix anchor is there. Instead of pull out, there is a root fix anchor, and then from that you can do a sliding knot. In just last IAS1, I did the live surgery for the root fixation. So the sliding knot is another option, but then you have to use the cannula so that you don't fat pad and all.
Sliding knots gives a good compression onto the bed.
So over the now, maybe we might be shifting to, do you think that we might be shifting to an anchorage fixation with an anchor rather than a transosseous, considering that all these biomechanical things are going?
Simultaneous HTO, ACL, PCL, then root fix anchor is a good option because we don't want to have a tunnel collation, especially HTO if you want to do, and then your screws will come in a way. If you want to have a suture pull out, then it can get cut. So the root fix anchor, it just fixes the root just about in the subchondral region itself. So you will create a tunnel, but then you don't have to worry about your screw trajectory damaging the pull-out stitch.
Okay. Thank you.
Another.
Yeah, sir.
Yeah.
Please
Just
go
one
ahead.
comment regarding root actually. There's one good paper by Dr. Sheetal Gupta. He's added 3 more to the apparent classification. Also, on that, we have also added one more, that root tears are associated, most of them are associated with bone marrow in posterior tibial plateau. Yeah, so we have seen a couple of patients with fracture of the rim of the posterior tibial plateau as well. So that becomes a real problem where the bed of the meniscus. There's an amputation, reached a triad, amputated meniscus, root ramp lesion. Whole thing he got inside the buried inside the.
So as Dr. Mukesh uses all inside technique for the ramp lesion. So it is called bankers of the shoulder. So any techniques, whether you involve the capsule in the first suture or whether you go through the meniscus, as you are using the 24-degree curve device there.
That is most easy one because you can go below. If you are using vertical stitch, go first in the capsular part, just below the meniscus, then take the meniscus. If you are using a horizontal stitch, go through the meniscus, that you get correct trajectory. Change the portal if you wish like, go a little high, so use your needle first. Press the trajectory and then take the.
So it means the capsule first and then the meniscus. That is the important point. Capsule first and then meniscus.
So thank you everyone.
30-degree of flexion because the capsule will come close.
Yeah. And we have to elevate that like bankers also from the posterior tibial capsule.
Not necessarily because it's quite flexible, not a chronic one.
Okay.
So thank you everyone. Please be on the stage. I would like to invite chairpersons to felicitate our speakers for today. Dr. Amit Saoji. Dr. Siddharth Jain. Dr. Mukesh Ladda. Dr. Prashant Bhavani. Dr. Manoj Pahukar. And Dr. Abhinav Zogani. I would like to call upon Dr. Satyajit Jagtap sir to felicitate our chairpersons for today's session. Dr. Dhananjay Deshmukh. Dr. Tejas Waghela sir. And Dr. Vasan Gawande. Now we'll start with our panel discussion. For that, I would like to invite faculties Dr. Satyajit Jagtap sir for panel discussion, Dr. Ramakant and Dr. Srinivas sir and Dr. Mukesh Ladda. Yes. For our first case, I would like to invite Dr. Vikram Saprai for the presentation.
Okay, so coming to the panel discussion for the meniscus injuries. So that's the case. This was a female 37-year-old patient. She had a 6 weeks old road traffic accident, and her main complaints were pain and instability. On examination, there was a lateral joint line tenderness. Anterior Lachman was positive, pivot was positive. PCL, PLC tests were normal. Varus valgus stress tests were also normal, and she had a normal alignment. I'll directly go to MRI. So these were the MRI images. I'll show you the better focused images. So more close up. So more of a lateral meniscus oblique radial type of tear near the root. She had ACL also. You can see oblique radial tear here. The radial tear closer to root that we saw today, few of the cases. So starting from Mukesh, how would we plan for this case? What do you anticipate? What all instruments and implants would you like to keep?
So definitely ACL reconstruction with meniscus repair here.
Yeah.
So all inside type of devices like knee scorpion or something to take side to side stitches with a backup of all inside meniscus device to further augment my repair.
Okay. Okay. Dr. Ramakant, anything else you would like to add?
Same thing, I would do the combination of techniques side to side as I showed in my this thing.
Yeah.
So first would be like again we'll do the ACL femoral tunnel and then go and proceed for the radial repair.
Right. So just I'll show the diagnostic picture here. So this was the tear. There was a radial tear closer to the root. The smaller fragment or the medial fragment around 1 to 1.5 centimeter. It was torn posteriorly also, so there was no posterior attachment also. So it's more of a free fragment only attached to the root there, and a major fragment there with some displacement, and it was easily reducible. So Jagtap sir, how would you go ahead with this?
Sir, as discussed, we will do a femoral tunnel first and then go for the radial tear by side to side repair.
Side to side. Yeah. Okay. So, anything different you would do, sir? So since this is very closer to the root, would you?
Yeah, if you look at the lateral fragment, the posterior one, that looking like a lateral meniscus oblique radial tear.
Yes.
So these ones, the lateral fragment is stable because it's attached to the meniscofemoral ligament. So
lateral fragment, yes.
Yes. So I think I use a knee scorpion actually. Lateral compartment is relatively roomy.
Okay.
So you can either do a all inside suture or use a knee scorpion to.
Would you prefer using a transosseous also, taking a bites and since it is very closer to the root? Anyone?
It's quietly firm. That's the other way of doing. People may make a tibial tunnel and attach it, but I think it's not needed in this case because you have a good chunk of meniscal tissue in the center also. So
okay.
And it's only 6 weeks.
Okay.
So cut through is not an issue. Second, associated with ACL, posterior to popliteus. they have very high chance of healing. So I don't think there is a need to do a transosseous for even healing purpose.
Okay. So
that will also make the repair more rigid than it is required. Transosseous.
Okay.
The mobility of the lateral meniscus may.
So my only
get
concern
hampered.
was since the medial fragment, it was a smaller one, and there was no posterior capsular attachment. It was free.
Yeah, that's what I want to tell. Actually, it looks like oblique, and there is a L-shaped component to the posterior capsule.
Yes.
So
On the small
before
fragment,
doing
on the medial fragment.
yeah, so before doing the side to side, and the gap is also more. When you try to do a side to side, then there can be a cut through.
Correct.
So the first step would be to approximate the capsule to the meniscus from the opposite side portal, and then approximate that, and then do the side to side. Then it will hold on better.
Would it be easy from the same side?
Yeah, like looking from you're putting the scope on the
Because that fragment is very unstable. Like when it will be, it's like a flap.
Another technical tip here, you take a side to side bite, use a sliding knot, don't tight it, just oppose it, leave it. Use all inside device to do the meniscocapsular repair, and then you further tight it.
Okay.
So it will not do cut through also, and you will have a good repair.
Okay. So for this, as we have discussed, I did a femoral tunnel preparation for this ACL first. Once the femoral tunnel, I placed a transosseous tunnel here, then took a portal, I used a scorpion. I first took two side-to-side sutures. From the smaller, the medial fragment, I took the end of the suture, and from the larger fragment, or the medial fragment, I passed a loop of the fiber wire, and through that loop, I shuttle the other suture, the other end of the suture. So that's the loop coming out, and from here I shuttled it. So I got a one side-to-side suture here, placed one more there, so placed one more, the loop on the other side, and now the couple of side-to-side stitches. Then I placed one on the capsular side for the medial smaller fragment, and then shuttled this from inferior, and then took a bite on the smaller fragment. So here you can see the, and then we place a knot here, placing the knot more posteriorly. Not going posteriorly. So this part was repaired to the capsule. And then did a ACL tibial tunnel and a tunnel for root. Then shuttled all the sutures. Once this was the final repair, and there are two side to side, one capsular stitch. And pass the graft, and that was the final picture. Anything different we could do? That's side to side, not placing a tunnel, making a tunnel. Yeah. My main concern was since it was not attached to the posterior capsule. Yeah. Yeah.
If it is under too much of tension,
Yeah.
the tunnel would be a good idea.
Yeah.
To hold it down.
It's what? So if you
as you can
cinch it
see,
more-
the very nicely done, but the whole of the meniscus is now sitting down, which is I think slightly overdone.
Yeah. Yeah, but since it was very close to the root, so I thought it's better to do this. Otherwise, in a minimum, we might have to take 3 stitches for the radial kind of tear to reduce it and fix it. But I think with this, it was I placed one less stitch. Only a couple of stitches were placed, and one anteroposterior. Thank you.
For the next case, I would like to invite Dr. Naved Ahmed.
Good afternoon, everyone. On behalf of ASN, I welcome you all to this IAS1 Connect program. So let's go through this case. It's a 18 years old male with a history of insignificant trauma, pain and clicking since 6 months. Tender over the lateral joint line, no obvious deformity, no laxity, McMurray is positive for the lateral meniscus. So, what do you see on that MRI? Yeah, so it's a straightforward discoid meniscus with a signal in that. So, I would like to ask you, hypothetically, if you don't see that signal, it's just a discoid meniscus, would you try any kind of conservative treatment on this patient?
Yes, I would. Initial treatment is conservative because he's been living with that meniscus for long. He's currently symptomatic. Then he could go for a copy assessment of the meniscus.
Anyone else?
Not 6 months. So I won't offer him any, right, because the pain, and if it's a painless click, I'm on for a while. That means there is some, either the intrasubstance meniscal tears or some meniscocapsular tears have occurred that's causing clicking and pain. So 6 months, if he would have come me day one, I would have offered him conservative. But 6 months, no.
Yeah, so the idea is that if you have pain along with a discoid meniscus on the MRI, that is the time you can offer surgery. But if you don't have pain, you can still try conservative treatment. So I'll just go through the diagnostic round. So it's the right knee, you're looking from the anterolateral portal, that's the medial side, and that looks reasonably okay. The ACL and PCL were intact, and now we will see the lateral side. So that's your discoid meniscus, that's a tear, that's a vertical tear posteriorly in the body and the posterior horn. Yeah, so how do we go ahead? What are the tips and tricks and steps of doing a discoid meniscus?
It seems to be a tear, but invariably these tears, as the horizontal flap above, flap below, that will be able to cupping. The best way to do it is do the cupping for the inner zone and then repair the peripheral tear as well as the flap tear.
Right. So how do we decide as to how much of saucerization or the meniscal tissue we should be removing? How deep should we be going?
Depending on the width of your probe. That much of. Keep at least 5 to 7 millimeters. Now that is what the thickness, the length of your probe angle. So I keep it there and I roughly keep it in mind that at least I have to preserve that much minimum. Beyond that.
Okay. So this is what I do. I take a punch and in the center I start making a cut through that tissue till the time that I feel that this much of tissue I have to preserve. And so when I know that this is my limit, then I go into the posterior part and the anterior part and start making it circumferential. And you have to keep assessing in between how much you have removed. Very important not to remove much of the tissue. Now, this punch is not able to take care of the anterior part. So you have to have your left-sided and right-sided cigar biters, something like this, with which you can take care of the anterior part. The anterior part is very difficult to visualize as well. So sometimes you have to change your portals as well. So as I said, you again continuously go on seeing how much you have resected. Do you want to resect more? What is the thickness? And then once you are sure that this is the amount of meniscus you want to preserve, then you do your fine adjustments, trying to balance the meniscal edges. And then you start repairing. So again, standard procedures for enhancing the healing potential. And the first thing that I want to do is I want to look at the anterior part, how much it is. So I take a outside in kind of repair for this, so that I pull the meniscus anteriorly, so that I can visualize the meniscus as a C shape properly, and then I start my repair. Now once that suture is in, I can pull on the meniscus and I can see the whole meniscus nicely. So that's an inside out needle in the anterolateral part of the meniscus, and that's a oblique sort of pull. So I can see the meniscus properly, and then that's a knee scorpion going in. I want to do a all inside kind of repair. I go through the whole of the meniscus, including the posterior part as well. Make sure that I'm seeing my needle when it gets out with the suture, and then tying a knot over there. So if you see, when I'm tying the knot, that meniscus is coming out. So it means that it's unstable over there. So before cutting that suture, what I do is I put in a all inside kind of device which will fix my meniscus posteriorly to the capsule. Because the problem of clicking comes when that meniscus on flexion comes into the joint. So I don't want that to happen. I want that meniscus nicely fixed posteriorly.
Just the posterior root is attached.
Yeah, posterior root is attached. And so that's kind of final repair with one or two inside out sutures more done posteriorly. So this is the kind of repair that I have, and I check on flexion and extension if that meniscus is coming into the joint, clicking or not, and that is how I complete my discoid meniscus repair.
Do you fix it to the popliteus tendon there?
No, usually you don't require it, but if it is necessary, we can, but otherwise I don't.
Meniscus healing augmentations, because they are bound to re-tear more.
Just a bone marrow stimulation, synovial membrane abrasion. That's all I do. I don't go into that fibrin clot and all.
And any specific area where to do bone marrow stimulation, only in the intercondylar notch or in the lateral gutter?
So I just do it in the intercondylar notch, and the synovial membrane abrasion is on both sides, the lateral as well as the medial, much as we can do.
Generally, I try to avoid the popliteus tendon because it is a mobile structure, and in the native anatomy, the capsule and the popliteus tendon are separated by the hiatus. So when you try to fix it to that, the repair can fail, or the patient may have a posterolateral corner chronic vague pain might be there.
Right. So you should avoid it if possible, but if it is required, not in this case, but in complex tears in that area, if you have to, you will engage into the popliteus tendon.
You can't
avoid it as much as possible. Okay. So, Neha?
So this ends the panel discussion. For felicitation of our faculties, I would like to call upon our panelists. Our first faculty, Dr. Vikram Sapre. And Dr. Naved Ahmed. And I would like to felicitate our panelist, Dr. Satyajit Jagtap sir, by Dr. Srinivas. So we'll start with our next session, which is on session 3, cruciate ligaments. For that, I would like to call upon Naved Ahmed, sir. And Dr. Sameed Vidmute, sir.
So we'll start with the session number 3. So I invite Dr. Vikram Sapre. He is going to speak on video technique BTB harvest.
Good afternoon, everyone. So, coming to BTB graft harvest, come directly to the surgical technique. I prefer position in hanging down position. So, that's the standard position that we keep. Here we can place the knee in extension as well as flexion. That is generally required when you are doing a BTB harvest. So, this is our position. We prefer taking an oblique incision. Our incision starts around 1 centimeter below the inferior pole of patella to around 2 centimeters medial to the tibial tuberosity. Then you go for a subacute dissection. Once your subacute dissection is done, you incise the paratenon and separate it completely. From inferior to till superior, you can dissect the paratenon. Keep it both on the medial and the lateral side. Then once you have identified both the margins of medial and lateral margins of patellar tendon, then you start measuring. Generally it's around 3 centimeters. So our aim is to harvest middle 1 centimeter of graft. You mark it from superior to inferior and incise in along the fibers of patellar tendon. So for that you have to give 90-degree of flexion to join all the dots and complete the patellar tendon along the fibers. You cut. Once you have cut, you pass a tape so that you can retract it on both the sides. This is very easy to retract on both the sides. Once you have done that, then we need to harvest the tibial plug. For the tibial plug, you start marking the tibial plug with the sharp knife. Generally, what we prefer is around 20 millimeter of tibial plug and width of around 10 mm. Additionally, we prefer a tibial tongue here. So, proximal to the attachment of the tendon, we harvest around 10 to 15 millimeter.
Step.
Here. So, you start harvesting the tendon with the saw. Once you have marked with the knife, you have taken the medial part of the plug. To the left side, you take the lateral part of the plug. So this bone plug to which the tendon is attached is around 20 millimeter, and proximal to it, the tibial tongue that we will be harvesting will be around 15 to 20 millimeter. So roughly around a 40 millimeter length of the graft is available to us. So this will help us if there is any mismatch in the tunnel length, in the graft length. So you cut slightly more higher up also. Then your distal horizontal cut, which you have marked with the knife, so that is around a 10 millimeter you will take. So you feel for the give way of the cortex, don't go beyond that. Before that, we need to make drill holes for our suture passage. So this is a 2 millimeter of K-wire. So before harvesting the bone plug, we will make 2 drill holes of 2 millimeter, marking with the pen, and then you make these 2 drill holes so that we can pass the sutures later on. It becomes difficult at times when you try to make these drill holes after you harvest the graft. So it's better always to harvest this. Then you make a distal cut Once you have made the distal cut, the proximal cut, which horizontal one, which you have to take, I usually prefer it with osteotome. It's a very soft bone out there. And use a very thin osteotome. This is a very thin osteotome by Synthes. So it's a very thin. The blade size is nearly, thickness is equivalent to a saw blade. And just use the osteotome only to flip the bone plug. So now you have got hold it, you have got the tibial bone plug. So once you have got the tibial bone plug, you isolate completely the tendinous portion with the fat pad and place the knee in extension. Once you have placed the knee in extension, complete inside the graft till the bone, and now you are ready for the patella tendon bone cut. You give traction on the tendon and slightly adjust your retractors, and we are harvesting this graft through a mobile window of skin. So you have to retract it, place an extension and pull the graft down distally. Mark the medial and lateral borders of your bone plug with the knife, with the sharp knife, and the distal margin. Once you have marked medial and lateral margins and the proximal margin, then you can use the saw. And before that also, in this, as we have done for the tibial bone plug, you have to place 2 millimeter holes, couple of holes for passing the sutures. I generally prefer only 2 holes. Few people prefer making 3 holes also. Here. So now we are ready to place the medial incision, medial bone cut. Then you make the drill holes. Fast forward this. You're ready for the, always use the micro saw. It's very handy. You can hold it like a pencil grip. You can hold it with both of your hands, left or right. It's a very lightweight. And once, then you mark the inferior cut with the osteotome. Just a couple of hits, and then it will make an impression out there. Once that impression is made, then you place the cut with the saw. Once you have made all the cuts with the saw, you just have to flip it, and it comes out very easily. So that's your graft that is available. And the advantage of BTB is it gives a good bone on both the sides, as well as you can measure the length of the graft preoperatively on MRI. So once you have harvested the graft completely, now you place the sutures. I prefer to place circumferential sutures through the holes. So this is your tibial bone plug. You have got an additional tongue over that, so which will help you adjust the tunnel mismatch. And distally. So here I have put fiber wire on the femoral side, and tibial side is the ethibond. That's the final graft. So ideal BTB graft, bone plug is around 20 to 25 millimeter. I prefer 9 to 10 millimeter of diameter. Make the end of the graft like a bullet. Tendon width of around 10 to 12 millimeter. Tibial bone plug with the tendon is around 20 to 25, and the tongue is around 15 to 20 millimeter with a diameter of around 10 to 11 millimeter. Tibial tongue, which we have taken, which help us reduce the graft tunnel mismatch. Thank you.
Thank you, Dr. Vikram, for excellent demonstration of BTB harvest. Now we move on to the next graft harvest. I invite Dr. Ashay Kekatpure. He is going to show us how to harvest hamstring and the peroneus tendon.
Good afternoon, everyone. Thank you, Dr. Neha and the IAS1 community for inviting me for this seminar. Peroneus and hamstring graft harvest, the basic workhorse of every arthroscopy surgeon, and a requirement for any kind of a soft tissue reconstruction procedure. So before we launch into that, just a basic surgical anatomical idea. We are going to first handle the peroneus graft. Yeah. So the longus and the brevis enclosed in the lateral retinaculum. So the brevis is up front in front of you. Okay, you're not going to see the entire structure per se, but try to identify the one in front of you is going to be the brevis. Okay, it is slightly more muscular at the distal part, and the longus is just behind it. So seeing that in live surgery. कर्सर दे रे बाबा मला. So just over the lateral malleolus, 2 centimeter, you feel that you need not go too distal. There is a debate about whether to stitch the both peronoid together distally or not while you are harvesting the longus or not. I make sure that I identify both of them, the longus and the brevis, separately. I stitch the distal end of the longus to the brevis. Simple thinking and logic. We need to preserve the proximal motor of the longus which we are harvesting in terms of that graft. Okay, so you identify, you separate them, you put a distal stitch, so I put a absorbable stitch, tie the distal end together, and then prepare the distal portion of the peroneus longus there and there. Use a sharp dissection to cut the distal part, distal stump of the peroneus longus. You can use fiber wire, ethibond, prepare it in the Krakow stitch fashion. Here, fortunately, there are not as much dissection required for the proximal part of the peroneus longus. And then you can pass your closed tendon stripper across. One important stitch when you are doing that, ask your assistant to put his hand on the proximal part of the head of fibula, so that accidentally you should not injure the common peroneal nerve. Okay, you can ask them to gently push it. So this will limit your tendon stripper for any untoward advancing towards the fibular head. That's it. You get a good graft. Close to 30 centimeters, which is good enough for usage of any type of ACL reconstruction. Coming to the hamstrings, just a quick look to the surgical anatomy. So this is a video from Dr. Laprat. So the hamstrings, pes anseronis bursa, and the tendons are 6 centimeters away from the joint line. So this is the inferior aspect of the MCL. The one which are showing with this marker is the gracialis. So if you are doing all inside a conventional ACL reconstruction, you have to harvest the gracialis and the semity together. You can identify them separately. Initially, you can take out the fascia, prepare the graft then and there, identify them separately, and harvest. So this is how I do it. This is a small technical tip. You can inject some amount of saline in the bursa, so that gives you some more hydrodissection to easier identification of the tendon. You can ask the assistant to identify the hamstrings for the slight roll of those hamstrings. So this helps in easier identification of the tendon. I'm just rolling on the pes anserinus. I take a oblique incision now. I don't completely remove the fascia. Identify the tendon. You can use your mixture. To deliver the tendon out of the wound. This is the gracialis and the semity. You have to pass a loop around them separately in case you plan to dissect them out. Dissect it from the tibial tuberosity. Clear out the vinculi. This is the bounce. You have to assess for the tendon bounce. At least 3 centimeters of the tendon should be easily retractable outside the wound. If it is less than that, then there are more attachments posteriorly towards the gastroc, and which you need to separate out. And then you can prepare the tendon just outside the wound. Use your tendon stripper. Try to go towards the ischial tuberosity. That's it. Good graft is somewhere around 24 to 26 centimeters, and you can use it easily for any of the reconstructive procedures. Thank you.
Thank you, Dr. Ashay. And I would like to invite Dr. Tejas Waghela going to show us a technique for central quadriceps tendon harvest.
Thank you, Indian Arthroscopy Society, Dr. Neha, for inviting me here, and the office bearers of ASN and BOS. So, I'm going to be talking on central quadriceps tendon harvest. I call the central quadriceps tendon as the Allu Arjun of grafts. Allu Arjun can dance, do comedy, action. So even quadriceps tendon is very versatile. You can use it as a full thickness graft. You can use it full thickness without the bone plugs, and you can use it partial thickness as well. It nearly intact ACL in loads and stiffness, and there are a lot of biomechanical studies to prove that. In fact, IASONE calls central quadriceps tendon as the golden age tendon for ACL. And why does it call it? Because it has less morbidity, it has less post-operative ankle pain, it does not cause difficulty in kneeling, there are lesser chances of patellar fracture, and of course tendon ruptures are less. We all know the possible disadvantages of hamstrings. Over the years, we all use it. In fact, it is still the commonest tendon used, including me. However, there can be damage to neurovascular structures, there can be hematomas, there can be truncations, loss of flexion strength. And what is most important is there is a significant amount of failure rate increase with the use of ipsilateral hamstrings. So what are my indications for using a CQT? Revision ACL cases, hyperlaxity, obesity, concomitant multi-ligament reconstructions, and of course when I'm using a lateral extra-articular procedure, including pivoting athletes. Quick refresher, this is what you're going to be seeing in my video. That's the first layer where you see this bursa. You will always see this bursa going from lateral to medial, and you need to slit it out to identify. Sometimes you can see the second layer when you're using the superficial quadriceps tendon. You can see these amalgamation where the vastus lateralis goes laterally, the VMO, it goes medially, and the VMO goes laterally, and they have this crisscross pattern. You will see this if you only lift the superficial one. And if you are seeing the vastus intermedia, that means you're too deep. Now, this is a beautiful dissection by Laprade again. You can see there is this vessel which is going and feeding into the tendon. You have to see to it that you cauterize this. This will be seen consistently when you're doing your cords harvest. You cauterize this, otherwise there will be a hematoma. I have done it and I have found it. If you go too deep, you can get these kind of deformities like a hump. So be wary of that. So coming to the nitty gritty, that's how I will harvest it. So that's me taking an incision, going layer by layer, separating the fat, separating the bursa. Paratenon needs to be cut. Then you identify the vastus, the two vasti, and that's the tendon here. I use a pre-marked 10 mm scale, and then I mark the length of the tear, as well as I also mark the patella border where I need to remove it. I use a 10 number blade which has a depth of 7 mm, so you don't go too deep and cut the capsule. And if you are quite neat with it, you'll be able to keep the capsule intact, and the water won't come out. And then you take your running stitches. I use an all soft tissue graft. I have never used a bone plug, and it has sufficed me well even in revision scenarios. And once you have taken these, this will be my tibial side of fixation during ACL. I truncate it. As you can see, the capsule is intact. It has not been bridged. And then you close this in a watertight way. This again is very, very important. And if you have a good assistant, then it doesn't cause delay. But here I had a bit of delay. And then you take a running stitch from distal to proximal. I take the paratenon and the tendon together. However, you can do it in a layer fashion, but I have found this to be good enough in my cases. And I take a running stitch with a Vicryl. I just go around, I don't lock it. Then I use a ultra braid or a braided high strength suture on the femoral side, and I use this to add the ethi bond on it. This is the original technique described by Fulkerson way back in 1999, and I use the same technique where I use 4 Krakow stitches, and basically the Krakow stitches go from here, another in the middle, and I tie them onto the endo button. Tie 3 stitches inside, then again circumferent it and tie 2 more alternate half hitches on the other 2 sides. This will give you a very robust repair of the endo button onto the soft tissue, and you will be able to do your ACL in the conventional way. How about a partial thickness? I have used partial thickness predominantly in patellofemoral instability, but since we are talking of cord tendon, let's look at that. Here you have to see to it that you have this, you tend to have this septum which is around 2.5 centimeters proximal to the insertion of patella. So you identify that thin layer, which is the first and the second, and if you are neat enough, again, you won't be breaching the second layer. Then raise the flap onto the patella and lift it on to the femoral side, and there you can see that it goes. And then you make your tunnel from the layer 2. So that's the arthroscopic image where you can see that it is all frayed and absent, and the patella is laterally subluxed. This is a standard case for MPFL reconstruction, and cords tendon harvest can be a good thing for them as well. There I am in the second layer. reaching it on the adductor tubercle, finding the Schottle's point, also leads to a decreased tilt, and post repair you can see that it's extra articular. We have not breached the capsule. However, if you breach the capsule, nothing to worry, you can just tie it with number 1 Vicryl. And intraoperatively we could get a good pliable 1/4 mobility of the patella, which is not too stiff, it is not too tight, not too loose. So to conclude, central cordyceps tendon is a versatile graft. As I said, it is the Allu Arjun of grafts. Adequate hemostasis and a watertight closure is essential. Hematomas are very common, and believe me, if you are going into the recti, which is actually muscular, there will be a lot of blood, and that will be decreasing your rehab potential. Be wary of the anatomical variations during harvest. The suspensory fixation is very well possible with a soft tissue CQT graft only. And as per current recommendations in 2025, prefer CQT in obese, hyperlax, and probably athletic patients where you're going to be doing a lateral extraarticular procedure as well. Thank you.
Thank you, Dr. Tejas. That was interesting. I now invite Dr. Samir Dwidmute for his talk on ideal ACL reconstruction.
So good afternoon all, and I'm going to speak on the single bundle ACL reconstruction, so video technique. So now we have already have seen the different graft options which are available with us, which can be used. So I will be mainly focusing on the tunnel placement in patients with for the ACL reconstructions. We'll start. So ACL surgery is one of the commonest surgery, and with the rising number of ACL, we also see the number of ACL failures which are going on. And the most common cause for the revision ACL surgery failure is the malpositioned tunnels and the injury. So during this presentation, we are just going to oversee these different points which are there. Patient positioning already been detailed. And start with the diagnostic arthroscopy. We have to see whether the confirm the diagnosis of the ACL reconstruction. Whatever stump which is available, you should try to preserve it. They will give some amount of proprioception, as well as the vascularity will be provided by the stump which is there. Yes, during the initial phases you can remove it, but as much as try to possible to preserve it. When the notch is preserved, then the main important thing is to identify the femoral footprint. So if you see the malpositioning of the tunnel, the femoral malpositioning is more common, and that affects your ACL outcome. So understanding the anatomy of the femoral footprint is important. You should be able to identify the resident ridge and the bifurcate ridge. So placement of the ACL has to be ideal, that is within the ACL footprint on the femur, but it should be more toward the higher side, directed towards the direct fibers, not the indirect fibers, and it should not be very low. You should go as deep as possible and as high as possible. So this is the orthoscopic view in which you can see where we are looking to aim for your femoral tunnel. So in the orthoscopic view, you will be seeing this femoral footprint. It is best visualized from the medial side. If you are using two portals on the medial side, you can use the accessory portal for marking your site, and you can use the accessory middle portal for visualization. So here you can mark the femoral entry point with all that always need to be confirmed from the medial portal, and once that is done, then you can proceed with the drilling with the 4.5 mm drilling. Usually when you are trying to do the anatomic ACL reconstruction, the tunnel size would be around 34 to 38 millimeter. If it's a very small tunnel, it is better to use an adjustable loop rather than using a fixed loop. So always try to keep a adjustable loop along with you. Because if the tunnel is very small, 30 or 32, it is very difficult to use a fixed loop, because with the 15 mm loop, it is very difficult to flip the button. So once that is done, then you can proceed with the socket preparation with the help of the larger drill bit, depending upon the size of the graft which you are having. And depending upon the size of the graft, you can also use the offset trimmer which are there. So always confirm whether there is a lateral blowout or not. If there is a blowout, you need to be prepared for it. The exit of this femoral exit point from the lateral part of the thigh is important. See that it should be here is exiting anteriorly, then it should be that your tunnel is malpositioned. It should be exiting laterally, but not more posteriorly. Can be confirmed radiologically. You can use intraoperative radiology, or you can outside in jigs are also available, which will help you in positioning the femoral tunnel at the exact point where you want to put. For the tibial side, it's more forgiving, and the main aim is to put it into the center of the ACL footprint. Landmarks which are used are the posterior border of the anterior root of the lateral meniscus. Then you can use the PCL, the medial tibial eminence. So whatever the tunnel which you are plating, it should be on the lateral slope, down slope of the medial tibial eminence. If you go more really, there is a chances that you can damage the articular cartilage. So now in this case, we are aiming for this particular point, the wire should exit. Also, when the wire is exit, you just try to extend the knee to see whether whatever the graft you are going to put or not. You can just advance the wire a little bit. If it is touching your intercondyle notch, then you have to replace your wire. And if in this particular case, you can see some of the fibers of the ACL which are intact. So try to preserve them as much as possible, because whatever the fibers you are preserving, it will help you in augmenting the ACL preparation, ACL healing. Especially it is important when there is a single bundle ACL bundle is intact, only the AM bundle is fiber, AL bundle is injured. In that case, you need to be very particular. You can always hold that wire with the hemostat, that will prevent the accidental migration. And also you can debulk the meniscus with the help of a shaver, because unnecessary we don't want to stop the intercondyle notch, so that can result into restriction of the extension. You pass a wire into the shuttling wire into the femoral tunnel first, retrieve that wire to the tibial tunnel, and then you can pull the graft inside it. Always use some kind of marker depending upon the length of the graft. Like in this case, you can see a vicryl stitch being placed, which will say that what is the exit point or what is the length of the tunnel. Once that it should be more than whatever if the tunnel is 38, then this vicryl you can put it at 5 mm more. Once that graft is passed, then you can flip the button by doing the other suture. Also, while doing the flipping, it should be important that the button should be completely out of the lateral cortex. If it is not, there is a chance that it may get dislodged or it may get blocked into the tunnel. You should do always the flipping, and always remove the sutures simultaneously. And before starting the tensioning, it has happened with previously. If you don't remove it, try to remove it after we have fixed in the tibial fixation, the tunnel may get flipped, or it may on an X-ray it will be seen elevated from the bone. While doing the screw position, tightening the tibial fixation, always ensure that you are giving a posterior drawer. And in patients who are having a hyperextension, it will be advisable that you can fix the knee. Instead of flexing into the 20 degrees of flexion, you can do it in full extension. It can be done. So anterior placement, tibial is usually a little bit anterior, so don't go more posterior. And different hazardous things which can happen if you malplace the tunnel. So take home message is proper knowledge of the anatomy is important. Femoral tunnel is more difficult, not forgiving. So you should try to put the graft into the femoral tunnel. And tensioning of the graft for the optimal tibial fixation is important. And always study your postoperative radiograph, that will help you avoid a malpositioned tunnel and your surgical outcome. Thank you.
Thank you, Dr. Samir. That was very lucid indeed. I now invite Dr. Rohan Bansal to give his talk on all inside ACL reconstruction.
Morning, friends. I would like to first of all thank Dr. Neha ma'am for giving me this opportunity. We have already learned about an anatomical ACL reconstruction. So there are certain difficulties which anyone can encounter with a normal anatomical ACL reconstruction. We try to see for one of them and try to correct it. So what are the challenges in the ACL reconstruction? The Indian females have very small grafts, very thin grafts. So the amount of graft available may be very less. In the pediatric patients in whom the stature is small, and obviously in multi-ligament injuries, which every graft will be important for us for reconstructing the different ligaments. In all inside ACL reconstruction, the advantage is it's only one graft, and it has an advantage of suspensive fixation on both the sides. Tight ropes being present on both the femoral and the tibial side. How do we do a all inside ACL reconstruction? A standard diagnostic arthroscopy using an anterolateral and anteromedial portals are created. An arthroscopic examination is performed through the anterolateral portal. Any associated meniscal lesions, if present, are treated before. Then coming to the graft harvest, which is the most important thing, and the preparation of the graft in all inside ACL reconstruction. In this, we harvest a semi-T graft using a close-ended tendon stripper. A quadruple ACL graft of the semi-T of approximately 6.5 centimeters length is prepared. Make for 2 centimeters on the tibial side, 2 centimeters on the femoral side, and 2.5 centimeters for the intraarticular length. The ACL tight ropes are attached to both the sides, and then finally the ACL all inside graft is prepared. So this is the way we will be preparing the graft. We will be using 2 adjustable loop endo buttons on both the sides. The graft will be put through both the loops of the button. The 2 ends of the graft will be attached to each other using a stitch. So once the graft are stitched to each other, then the maximum tension is put on the graft, and the 2 ends of the graft are sutured. So all the 4 limbs of the graft are sutured on either ends using a fiber wire. After tensioning the graft to the maximum level which can be attained, and taking out any of the kinks which are or any of the flexibility which is present in the graft, we try to correct it. Once the graft is prepared, coming to the femoral tunnel preparation, the starting point of the femoral tunnel is marked with a 45 degrees microfracture owl, and the starting point is then gradually made. A bead pin is passed, which is gradually elongated with the help of a reamer, gradual size reamer depending on the size of the graft. This procedure remains the same as a normal anatomical ACL reconstruction. The sizing of the femoral tunnel is made so as to overrim the femoral tunnel accordingly. Normally, the amount of graft which is should be put in the femur should be at least 2 centimeters. So we overrim the femoral tunnel to at least 25 millimeters, at 0.5 centimeters, so as to approximately tension the graft whenever required. Coming to the tibial tunnel preparation, which is the most important in an all-inside ACL reconstruction. The arthroscopic viewing from the anterolateral portal, a tibial aiming device is placed anterior to the posterior border of the anterior horn lateral meniscus. We use a flip cutter for drilling using an all-inside zig. Once the flip cutter comes inside the joint, it is made to go past beyond inside the joint, and then the flip cutter is flipped. Once the flip cutter gets flipped, it is drawn back till the level of the joint level, and then a 2 centimeter socket is prepared from inside out in the flip cutter, depending on the size of the graft which was initially calculated while preparing the graft. Once the tibial tunnel is prepared, the flip cutter is again put back into the joint, flipped back and taken out after putting a guide wire in the tibial tunnel. Then both the ethibonds, one ethibond passed from the tibial tunnel and the other passed from the femoral tunnel, are taken out to the anteromedial portal and made sure that both of them come out to the same direction by using a ice tongs or a suture retriever. Then the graft passage is done. Putting the graft from the anteromedial portal, the femoral side graft is put first and it's taken out into the femoral tunnel, tightened, and then the graft is taken out in the tibial tunnel, tightened on the tibial side in 30 degrees of knee flexion. Once the graft is passed on both the sides, further tightening can be done on either sides by using the adjustable loop. There is one more way of doing this. If suppose we are having difficulties, this could be technically demanding by putting an endo button first, we can use a no button tightrope initially, which can be tightened over the table side using one of the one of the freehand endo buttons or T button. One of the post-op radiographs showing an endo button on both the sides. So what are the advantage of doing an all inside ACL reconstruction? Especially in the Indian females with smaller grafts, the pediatric patients. Since only one graft is required, so we have grafts for multi-ligament reconstruction as well. It's a bone preserving surgery. There is an ease of revision surgery if required. There is ability to retention the graft on both the sides, ability to be used in small diameter on attenuated graft, and ability to perform the surgery in a skeletally immature patients also. There are certain disadvantages, special equipment like a flip cutter being required, and arthroscopy skill needed, and it has a learning curve. So there are certain pearls to make sure that we do not find any difficulty while doing an all inside. So preparation of a short ACL graft of not more than 6.5 centimeters in length and trimming both ends of the graft to a smooth cylinder helps to make the graft passage easier into both the tunnels. Slightly over-reaming the femoral and tibial tunnel by 0.5 millimeters may give us space to retension the graft as well as retighten the graft once the graft is put on both the sides. Removing the soft tissue on the tibial socket before graft passage is very important because otherwise the endo button will not sit on the tibial side very well. And retrieving both the shuttle sutures through the anteromedial portal before passing the ACL graft is very important to prevent any soft tissue interposition. There are certain pitfalls. If the graft is too long, it will bottom out in the tibial socket and we will not be able to retension the graft. And then we need to abandon the procedure, maybe convert it to a normal ACL reconstruction. We cannot over tighten the internal brace and do not entangle the suture and the tightrope limbs, otherwise the graft will not pass properly. The rehabilitation is as usual. Thank you.
Thanks, Dr. Rohan. I'm sure you must have converted a few to all inside ACLs now.
Thank you.
A few of our delegates. I now invite Dr. Ramakant, our eminent faculty, to speak on ACL fixation methods, adjustable loop versus fixed loop.
Good afternoon. Once again, thank Dr. Mukesh Ladda and Neha for this opportunity. So all the talks were the arthroscopic talks. So I'll just cover a bit on the basic talk and outside what happens. So the concepts of fixed loop and the adjustable loop. So with the evolution of the femoral fixation started with transfixation pins and then the suspensory fixation and then the other modes of fixations are there. So in this talk, I'll just cover about fixed and adjustable loop. So the fixed loop is a first generation suspensory fixation. It is an extra-articular device, has the polyurethane ribbon, and it has two sutures. There's a lead suture and the flip suture. So the lead suture will pull along the graft and then the flip suture will help to flip the fixed button, the titanium button, and the polyurethane rib has the graft inside that. But we need to have different implant sizes like 14 mm, 15 mm. So we need to have it in our armamentarium for the different sizes of the loop. We can pick and choose depending on the size of the total condylar width. So the fixed loop comes with different sizes based on the size of the polyurethane rubber, that is 14 or 15 or 20 or 25 mm. So for the calculation of the fixed loop, this is little tricky. Intraoperatively, we have to calculate on our mind how to how much of the socket has to be drilled. So we know that 8 mm of graft, but how much is the length of the socket we need to drill. So this is the socket length. So this is a socket length which we have to calculate how much to be drilled. So for that we need to know the total condylar width. So that is the total condylar width. The length has to be known. So that we'll know it through the measurement. And the fixed loop, we know that fixed loop, what is the fixed loop? That is what we are going to take. And that 7 mm of socket which needs to be drilled. So the length of socket to be drilled will be the total width minus the loop what we are going to take, that is 15 mm or 20 mm. That plus 7 mm is needed for the button to flip. And so, for example, if it is total condylar width is 35, then 27. So we'll see what happens in this. Okay. So we are going to measure the total condylar width. So jig is placed, and this is the pin which it's a single step. So this, instead of bead pin, we have that 4 mm the tip, the wire, the 4 mm tip wire. So that drills the tunnel for the pilot hole for the femoral socket. So once we drill it across, and then we can measure it in a single step. So this was 38 mm was the total condylar width. That is from the outside the lateral cortex to the inner aspect of the notch. So that 4 mm, 4.5 or 4 mm drill bit will give that the total condylar width. So this total condylar, so this is a total condylar width, and then this is a 7 mm dead space. We have to drill the socket so that the button gets flipped outside the cortex. So in this case, we need to drill around 38 mm was the total condylar width, and we took, if we take 15 mm the fixed loop, then we have to add that 7 mm so that 30 mm is the socket which is needed. So here we can see that the polyurethane ribbon takes that graft inside, and then the lead sutures are taken. So it's just for the showing that how the lead suture and the flip suture can be converted, but the button has to go vertical, so we have to pull the lead suture, mainly the white, or we can choose whichever we want, and then flip the button. So the flipping the button will give the toggle sensation outside the cortex. So we'll feel the, alternatively when we pull the toggling, we can feel it, and that gives the tactile sensation that button is flipped. But the disadvantage of the fixed loop are the inaccurate measurements, so it will be difficult for us to pull the graft, and then the bungee cord effects, and then the many implants like 14, 15, depending on the total condylar width, we have to choose to keep them all ready in the armamentarium. But the single graft, the graft length may not be sufficient, the tibial side might be short, and then we are creating the dead space of 7 mm there for a button to flip. So that can harbor synovial fluid and can lead to the tunnel widening. There is another company which gives that extendo button. If inadvertently we break the outer cortex, then the additional button can be used to sit. We have to open laterally and then place this. This is a second to overcome the fixed loop disadvantages. The adjustable loop has come. This is a second generation. The adjustable loop makes we can adjust the total length. We don't have to have multiple implants in our armamentarium. Just single adjustable loop will be sufficient. So the first is to, again, the same technique, that 4 mm guide pin will drill it across to know the total condylar width or the condylar length first, and then we'll do the two markings here. So the first marking will be the total condylar width, that will be in the loop. We mark it in the adjustable threads. So that will be the total condylar width. Here it's being marked, but that is from the tip of the button to the graft, and then the second is a socket length we want to drill. So here we have the control how much of graft we want to put it into the socket. So minimum of 17 to 20 mm. If total condylar width is more, we can put that socket length as the second marking in the graft, and that much can be drilled. So generally minimum 17 to 18 mm is drilled. So here we can see that so that we can adjust how much hour we want to put the graft into the femoral socket. And then the first is, while pulling it, the first mark tells that button is flipped. So once the button is flipped, we try to pull back and then see whether the button comes out or not, and then we can pull the graft in. So this is the adjustable loop. Whereas in the fixed loop, we have to pull both together. So the advantages are we can tension the graft even after fixing the tibial side, minimize the graft movement, and semitendinosis. Single graft can be used in this because we are adjusting the socket length and other things, and there is no dead space, so there is no chance of tunnel widening, and single implant is needed, and all inside is possible with this adjustable loop. And other advantages are if somebody wants to use the tape augmentation, that can be done, but now it is slowly going away. And the adjustable loop is also available for the BTB graft. So there are various literatures who have tried to compare the fixed and adjustable loop. Few studies have told that mechanical strength of the fixed loop is better, and based on the biomechanical studies, due to less cyclical displacement. There are other systemic reviews which we have compared both biomechanical and the clinical studies. The clinical studies has shown that it's a similar clinical outcomes and graft rupture rates. So we have also published one literature to know what is the difference in the tunnel widening for the fixed and the adjustable loop. So we have published this in 2018, and based on our studies for various parameters like clinical scores and tunnel widening, there was no statistical difference. So our conclusion was adjustable loop did not decrease the amount of tunnel widening when compared to the fixed loop, and there was no significant difference in the clinical outcome. So to conclude, ACL reconstruction methods has been evolving. The loop lengthening are the concerns for the adjustable loop, but the clinical results are same, and tunnel widening is similar in both the devices. Thank you.
Thank you, Dr. Ramakant, for excellent lecture. And I invite Dr. Satyajit Jagtap. Sir is going to speak on mucoid degeneration in ACL.
Thank you. I'm talking about degeneration in the anterior cruciate ligament. What is basically a mucoid degeneration? It is first described almost 25 years back by Kumar et al. Usually a condition in middle age group, and one of the most underdiagnosed and undertreated condition in orthopedics. Basically, it involves degeneration of collagen fibers and deposition of new glycosaminoglycan GAGs. The pathophysiology revolves around various theories, and when there are a lot of theories, you know that you don't know much about it. One of the theory is the synovial theory, another is a traumatic theory where trauma leads to the ACL fibroblast depositing GAGs in its own substance, or a degenerative theory because it is seen in the middle age group, or an ectopic very interesting theory. Again, multiple macro trauma, that is one of the theories. And if I may suggest another mechanical aspect to this, because one author has suggested increased tibial slope as a cause of ACL degeneration, and abnormal notch as well as a cause of the degeneration. All in all, you can say that it is a multifactorial cause for this degeneration in the anterior cruciate ligament. To add to that confusion, we have other terminologies like the ganglion cyst or the mucoid cyst, which are usually seen at the ends of the insertion of the ACL or tibial or the femoral surface. They can coexist with mucoid degeneration in as much as 35% of the cases, while the signs, symptoms are almost the same like ACL mucoid degeneration and diagnosed by MRI. Better part is that you can decompress those cysts using ultrasound guided technique, or even you can do arthroscopic decompression of the cyst without harming the anterior cruciate ligament. By and large, imaging modality, you can say that MRI is the gold standard. Normal looking ACL, a mucoid degenerated, which resembles just like the celery stalk because of the GAGs interspersed in between the normal ACL collagen fibers. The treatment option, first conservative mode of treatment in the form of NSAIDs and medications, physiotherapy. But when the pain persists and terminal movement, extension and flexion, they do not recover, then go for operative intervention. The role of ultrasound guided aspiration is okay for mucoid cysts, but it is not possible because of the interstitial nature of this ACL mucoid degeneration. Arthroscopic debulking or decompression is a described modality of treatment which does not affect the ACL integrity much. Another method is the total resection of the anterior cruciate ligament followed by the reconstruction. Now the management dilemma revolves around whether you should do a debulking resection or a reconstruction of the anterior cruciate ligament, taking down the complete ACL tissue. Judicious debulking involving stripping of the degenerated part and preserving the native ACL is a accepted treatment without a notchplasty. Definitely there is some amount of post-operative clinical laxity, but the patient may not show a symptomatic instability in the initial stages. There is another paper which has said that these mucoid degeneration may be a segmental lesion in the posterior lateral bundle in almost 17% of cases, where you can go ahead with selective debulking of the ACL. A recent paper by Rajkumar Amravati has shown a very systematic way in which you can do debulking of the ACL in a step-by-step manner. So what are the issues with debulking of this ACL tissue? What literature has to say is that it is very difficult to identify this degenerated part using arthroscopy. You have to take the help of MRI preoperatively. The chances of where to stop, either there is understripping or overstripping of this degenerated tissue leading to laxity of the anterior cruciate ligament. So especially in younger age group, if you are not sure how much you are debriding, then you may end up with laxity. So you have to do proper counseling of these patients so that you can do reconstruction there and then at the same time. Various papers by Lintz and Dijor has shown that even if there is no laxity at the time of surgery, the laxity may increase over a period of time, and so much so that Latchman test is significantly positive, and so is the pivot shift in majority of the patients. Lintz has shown that he has anterior laxity in maximum number of patients. Another study by another surgeon has shown that the remaining fibers may not have adequate strength to prevent tibial translation and rotation. So, because of inevitable ACL resection, early ACL reconstruction, especially in young active individuals, is the treatment of choice. A paper by David Rajan has shown single stage ACL reconstruction and resection be very effective and without any recurrence. The functional outcome by other people have also shown that it is very good to go ahead with ACL reconstruction, especially in younger age group. This is a case of a 40-year female with insidious onset pain without trauma, not responding treatment, painful limitation of movement, vague tenderness, where I showed that there is mucoid degeneration with cyst formation. So we have to go ahead with complete resection and reconstruction, which is the treatment of choice for me. As you see in this video, the ACL looks nearly normal but tense, shining without the normal synovial covering and the blood vessels. On probing, you can see the mucoid tissue that is coming out can be easily missed if you look at the overt anatomy. And as you go on debriding, you can see a lot of mucoid tissue that is inside the ACL, and I feel personally that it is very difficult to conserve this type of ACL. So we go ahead to complete debridement, resection of the ACL and reconstruction of the tissue. Final outcome was after ACL reconstruction was good, post-operatively mucoid degeneration was confirmed, standard rehab protocol, and after almost 2 years of follow-up, the patient is pain-free and have a stable knee. Second patient, 48-year dentist, knee pain, had some trivial trauma, but again not responding to treatment. Her ACL reconstruction was done after complete removal of the degenerated tissue. We managed to do a post-operative MRI to see that the ACL, whether there is any degeneration now, but it is now normally functioning, and is having a good result. So to sum up, there should be a very high index of suspicion as well while you are dealing, especially if the MRI is reporting partial tears of the ACL. MRI is definitely a gold standard, but I would say that ACL management, decompression may be in older age group, but as far as younger age group, ACL reconstruction is preferable and a predictable way how it should come out. Notchplasty is optional. Arthroscopy will always show you a normal looking bulky ACL, missing synovial envelope and blood vessels, so called degloved ACL, no ligamentum mucosum. So in your OPD practice, if you happen to see a fat female fertile for around 40 years of age, the mnemonics that you must have learned in gallstone surgeries. So I think with non-traumatic knee pain, you should think about nothing else than mucoid degeneration of the end. Thank you.
Thank you, Dr. Jagtap. I now call upon our another eminent faculty, Dr. Srinivas, to give his keynote lecture on reasons for ACL reconstruction failure and their prevention.
Thank you very much, Osteocare, Vidarbha Orthopedic Association, Arthroscopy Association, Nagpur, for this opportunity. My topic is reasons for ACL failure, ACL reconstruction failure and its prevention. It's a big topic. I hope I do justice to the topic in my talk. Let's start with the definition of failure of ACL reconstruction. Noyes and Barber-Westin defined it as a complete graft tear of more than 6 millimeters of anterior tibial displacement as compared to a healthy knee. Positive pivot shift test graded +2 or +3 compared to the healthy knee with or without knee pain or inflammation. Subjective sensation of instability or functional limitations for daily life and or sports activities. 10 to 15% of ACL reconstructions end up in revision. There are good reviews on this topic. I would recommend going through these articles. Failure can present in 3 forms: instability, stiffness, and pain. Instability could be early onset, less than 6 months, or late onset, more than 6 months. Causes of instability are given here. We'll go through one by one. Abnormal mechanical loads by another trauma is seen in 10 to 43% of the cases. This is one of the most common causes of recent studies. Earlier studies found technical errors as common. Now that we have improved the technique reasonably, the error is less. Chronic repetitive strain and inappropriate rehabilitation or early loading are other causes. During the first year after the ACL reconstruction, the strength and resistance of the graft are only 30 to 50% of the original ACL. Technical errors are the next common cause, from 22 up to 79%. Most important is the placement of the femoral tunnel. The ideal concept, as was touched in earlier talks, should be followed for proper placement of the femoral tunnel. If it is placed anterior to recommended position, there will be graft impingement and rotational laxity, restriction of flexion and stiffness in extension. If placed posteriorly, there is breach of posterior femoral cortex called the posterior blowout, consequent lack of femoral graft fixation failure. If more distal, there will be restricted flexion, and more proximally, the extension is restricted. If the tunnel is over-reamed in femur or tibia, it could violate the cortex or loosen the graft in the tunnel. A femoral tunnel drilling angle of 45 degrees coronal and 45 degrees sagittal has the lowest peak stress on the graft. On the tibial side, if positioned too anterior, it leads to loss of extension, graft impingement to roof, early graft failure, and injury to
root of meniscus. Solution is to do a roof notchplasty. To posterior placement leads to PCL impingement, loss of rotational control, injury to posterior root of the lateral meniscus, and loss of flexion. Medial placement causes medial plateau, articular cartilage injury, graft impingement with the medial femoral condyle and the PCL. Lateral placement causes injury to the anterior root of the lateral meniscus, lateral wall impingement. This can be managed by lateral wall notchplasty. Vertical femoral tunnel occurs when transtibial tunnel drilling is done. This is less done nowadays, but there are proponents who have changed technique slightly, still recommended. Double bundle technique is decreasingly done now due to complex technique, difficult tunnels, uncertainty over the tension, bone bridge issues, difficult revision. Next up is misdiagnosed associated injuries. These include MCL, PCL, PLC, ramp, lateral posterior tibial plateau impaction injuries, and large lateral notch sign. In combined reconstructions with MCL, the order is to drill tunnels for the ACL, fix ACL, femoral tunnel, fix MCL, and fix the ACL tibial tunnel at the end. Fixing MCL theoretically could rotate the tibia. Most often missed is the PCL injury. 10 to 15% of chronic ACLs. Reconstruction is better, and HTO preferred in the chronic cases with malalignment of the limb. With PCL, the PCL is done first. They can be done as a single stage or in 2 stages. Unstable ramp lesions, we have seen they require repair. They could cause failure. Other missed meniscal injuries include root tears, radial tears, and flap tears. The posterior lateral tibial plateau impaction and lateral notch sign, these are seen more in the literature now. Both could cause poor results if not noticed, and the solution LET may be useful in these cases. For extra-articular procedures, the major indications are explosive pivot shift, elite athletes, and hyperlaxity. We will discuss more in detail about this in another talk. Graft fixation issues could be with the method, tension, and the isometry. Bone tendon bone heals with bone to bone and hence more secure. Ideal intraoperative tension is yet to be defined. One study found 80 newtons for hamstrings polyester graft. For reconstruction using semitendinosus gracilis or patella tendon grafts, there is no consensus. To assess tension, feel the graft with the probe after fixing. It should be close to the tension of a normal AC. Most failures are due to technical errors. Autografts integrate faster to bone, while allografts risk disease transmission or immune reactions. There is no significant difference between autografts and allografts at 1 year follow-up. Rehab should be individualized based on the biologic behavior and integration of the graft, either auto or allograft. Artificial ligaments like Dacron and Gore-Tex have been discarded. Newer materials like BioBrace and augmentation are increasingly being done, but fiber tape augmentation yet to be seen. Auto or allograft undergoes ligamentization, which is biologic process of graft necrosis, revascularization, cellular repopulation, deposition of collagen fibers, and remodeling. Delay in revascularization can be due to excessive tension, inadequate immobilization, infection or immune reactions, and delays in cooperation of the graft. Care and rehab is required during ligamentization, especially for allografts. Infection is rare in this surgery with 0.5% rate of occurrence. Prevention of infection is by asepsis during surgery, vancomycin soakage of the ligament after preparation, care with handling of the graft during the procedure. Stiffness occurs in 5 to 24% of the cases. Primary arthrofibrosis, by definition, does not have identifiable cause. It occurs possibly due to exaggerated endothelial proliferation and disorganized deposition of the protein matrix caused by an activation and proliferation of fibroblasts. Secondary arthrofibrosis occurs due to some identifiable causes. including inappropriate rehab, which happen by immobilizing for too long, repeated effusions, pain and aggressive therapy. Key is to manage the pain properly and achieve full extension and 90-degree flexion by 4 weeks. Technique related issues include tunnel issues, cyclops, graft issues and notchplasty. Proper notchplasty is done, adequate assessment of impingement should be carried out. Avoid surgery less than 4 weeks if possible. Do it when pain-free with no inflammatory signs, with good range of movement, and watch out for MCL ruptures. Preventing infection is important, and the steps you have seen before. CRPS management could include early mobilization and physiotherapy. Hematoma aspiration includes, reduces the quadriceps inhibition. Avoid casts and immobilizing for too long. Refractory stiffness is treated by arthroscopic arthrolysis. Aim for full extension, patella mobilization, progressive weight bearing, and muscle strengthenings. Avoid patellar tendon graft in patients with severe patellofemoral chondropathy, patellar malalignment issues, professions requiring frequent kneeling position, narrow patellar tendon, patients with previous patellar tendinopathy. Bone bruises and meniscal tears can cause pain. They should be treated appropriately. Avoid improper rehab and premature sports introduction. Use target-bound approach and follow criteria-based return to sports. There are many variables in the decision making, surgical management, rehabilitation of ACL reconstruction. So prevention involves careful choice of these steps and factors. Factors may be related to patient, environment, injury, surgery, and using prevention programs. Some factors are modifiable while others are not modifiable. The activity related include the vocation, the culture, and the type of sport involved, linear, pivoting, or contact sport. Biology include effect on age, hormones, sex, and obesity. A femoral tunnel outside in may be useful in obese patients. Local or general biomechanical factors are important. Motivation levels and physiology of a sedentary person, a weekend warrior, and an elite athlete vary significantly. Pre-injury can be either traumatic or non-traumatic. Other injuries include meniscus, cartilage, ligaments, ramp, fractures, faction injuries to lateral femoral condyle and lateral posterior tibial plateau. There are many technique-related factors. Important ones include the posterior tibial slope correction, ramp repair, tunnel convergence, individualized ACLR, femoral button deployment issues. Tunnel convergence on the femur can occur with tubular lateral collateral ligament and the popliteal tunnels. With the ALL tunnel collision was avoided by aiming the ALL tunnel 40 degrees anteriorly and perpendicular to the anatomical axis of the femur. More horizontal orientation of ACL with the AMP technique is a risk factor for tunnel conflicts. This image shows location of meniscal root tunnels in relation to ACL tunnels on tibia. Some surgeons have included the lateral root tunnel with ACL. We have discussed that before. Concept of individualized ACLR is about providing optimal results by matching the athlete factors with available choices and requirements. These include the type of sport played, the degree of instability, age of athlete, options available, surgeon's experience, and the size of footprint, the notch size. Surgeon options include restoring anatomical footprint to form 50 to 80%. The type of graft used requires using a graft that suits most with the expected consequences. Doing anterolateral ligament reconstructions or LET, single or double bundle ACL reconstruction depending on the size of the tibial footprint, use of internal bracing. Ensure proper deployment of endobutton. Even experienced surgeons can get caught out with this. Soft tissue interposition and improper flipping can occur in up to 25% cases. Routine C-arm conformation has been advocated, especially in early career. One technique is to ensure visualizing proper button deployment by using scope in the tunnel through medial portal.
So you visualize the deployment of the button, then tighten the graft. Suture tape augmentation and synthetics are increasingly being done. Surgeon factors include choice of patient, skill set, and volume of cases. Important complications seen stiffness, infection, and cyclops. Environmental factors also play a role, and these include playing surface, weather, rules of the game, and avoid adverse factors. In addition to the above, risk factors for first-time ACL injury also apply to failed revisions or failed reconstructions. Risk factors for injury predisposes the athlete to the injury. Exposure to external risk factors makes him susceptible to injury. Finally, the inciting event creates the injury. Risk factors for injury are related to age, sex, body composition, general morphology. These include things like increased pelvic tilt, increased femoral anteversion, and subtalar pronation. Joint morphology includes bony geometry, notch to ligament ratio, narrow or wide notch, and tibial slope. Other factors include skill level and psychological factors. External risk factors which make the athlete or person susceptible include sports factors, equipment factors, environment, and protective gear. An injury occurs due to an interplay of playing situation, player or opponent behavior, gross and local biomechanics. Programs have been developed to prevent injuries to ACL. The FIFA 11+ program has reduced the ACL injuries by 4.25 times. A meta-analysis on this subject has found the biomechanics, proprioception, sport-specific training to be focus of these programs. Athletes must be assessed for risk of ACL injury, and strategies to tackle these at high risk include neuromuscular training, muscle strengthening, core stability, plyometrics, flexibility and biomechanical training, sport-specific training, and gender-specific training. There's increasing use of technology in ACL injury. The recent publication which will be coming out. And strategies include motion analysis systems, wearable devices, artificial intelligence, machine learning, video analysis software, digital platforms and data integration systems, and smart surfaces, robotic training systems. So to summarize, failure of ACL may be obvious or a complex interplay of variables. Presentations include pain, stability, and stiffness. Start search from the most common causes. Perfect your technique to avoid failure. Identify athletes at risk. Eliminate modifiable risk factors and preventable causes. A tailored approach for athletes, individualized ACLR, environment and sport-specific tips, tailored rehabilitation, prevention programs help reduce failure rate. Thank you very much.
Thank you, sir, for your comprehensive understanding of ACL failures. I would like to now request all the speakers of the last session to come onto the dais, please. Anyone has any questions? You're requested to come to the mic.
One to Ashay. Tying the remnant of distal peroneus longus to brevis, does it significantly affect the outcomes in long run, or is just one of the procedures which you are using, seeing your seniors doing and you are just following it? That's so, or does it really affect?
Okay, I have been trained by a very good hand surgeon. Okay, and to answer that question two ways, there are some studies which are published where they talk about not preserving or rather tying the distal remnant of the peroneus longus to the peroneus brevis. Whereas there are enough number of studies which says that the proximal motor, how your peroneus longus distal tendon is going to work, it has some role to play, right, in terms of eversion of that foot. So that motor is integrated. And there are studies which are coming up. We are doing a post-operative ultrasound of the peroneus longus and a regrowth or regeneration of that tendon, but there should be some kind of a scaffold which should be remaining or to attach to. Okay, so that peroneus brevis, it becomes bigger. In orthopedics, a logical statement, form follows function. So if there is an attached motor, definitely the peroneus brevis will take over, or rather in some part will become as, or I can say robust as peroneus longus in long term.
Tejas, regarding CQT, we see a lot of patients who come like for revision or whatever, they have significant quadriceps wasting pre-op. Does your CQT harvest will enhance that in weakness, or what is your experience after harvesting the amount of girth, the quadriceps wasting they have more compared to other grafts?
That's a very interesting question. Actually, what happens is the tendinous portion of the quads does not tend to atrophy significantly. Now, this is what the medical research tells us. I cannot quote papers for it. I mean, I don't remember the names exactly, but I can tell you that they have categorically said that, especially from, again, the commonest, the guy was Strauss, yeah. So Strauss mentions that, in fact, the tendinous portion remains quite robuscous, and you can remove it even in atrophied tendons, in atrophied quads.
Does that recover fast? I mean,
The
to say
recovery is not faster. Definitely, from practical stand of view, I have seen that there is some extensor lag initially for these patients, and they have to work really more. However, arthroscopically, it doesn't look very pristine the way hamstrings do, but clinically, my quads tendon have very good stability.
Rohan, we all started doing ACL with suture disc fixation on the tibia side. So how it differ from all inside?
All inside which I showed was the tunnel was drilled from inside out.
I know technically, but practically we were using suspensory on both sides since long.
You also know disc on the tibial side, that was never that tight enough. Adjustable loop you can have to that
So
limit
that's
of
the another
21.
question. Are we over tightening with that?
We have to tighten the graph in 30 degrees on knee. And once we see a diagnostic in 90 degrees, we shouldn't over tighten the graph has already been tightening 30. You should do a scoping 30 degrees knee flexion.
So, with regards to that, I wanted to ask Dr. Ramakant, what is your take on suspensory fixation on both the sides, like suture disc on tibial and adjustable loop on femoral side?
Yeah, we can do it. I mean, it has been proven that since many people, including Anand Joshi, would be doing it on disc itself. We can do it, but just these are the latest advancements with flip cutter and all those things evolved over, the techniques have evolved, but the results are going to be the same.
Keep something for the debate, yeah?
I think they have the E button for the tibial side, which is double. Is a looped.
Just one question, last question. Jagtap sir, I just wanted to ask you, because you were talking about debulking, like what is your experience in these last few years? Because I don't debulk them. I actually remove everything and I do an ACL reconstruction.
I have done debulking in initial stages in 2 patients only, and then they were not very completely happy. They had some nagging pain, and so why reconstruct in traumatic injuries?
Because they come with instability complaint. Here they don't come with instability complaint.
we
So
are-
other factors are fine. We don't know the exact etiology of what is going wrong. So your post ACL graft can also go into mucoid reconstruction.
Yeah,
So that's
that is a that is definitely a possibility. But at least what we have now is that we have removed the ACL, and you have to reconstruct the ACL. As simple as that.
But that is not an indication for ACL reconstruction. The symptomatic is unstable patient.
It is a ACL deficient knee, na?
But
It
they
would
are
be
older
ACL
patient, low demand patient. They are usually
No,
above
around
40, 45.
in younger age group. That's what I told in the talk, that it
The
younger demanding age group.
mucoid tissue itself is very inflammatory. And removing it is like a surgical debridement. This is the only time when you have to remove everything. So there is no concept of remnant preservation here. I will use a radio frequency ablator. I will burn down the tibial footprint. I will burn down the femoral footprint, and I'll do a ACL. This is the only time when I'll do this. So you have to do an ACL reconstruction when you're removing the whole ligament. You leaving it and the patient having instability, especially in kind of practice that you and me do, which is private practice. Our patient will turn down to someone who बोलेगा कि अरे तूने ACL क्यों नहीं करवाया?
Mukesh, you're asking this, so do you don't do the ACL reconstruction? And what if the whole of the ACL is mucoid?
And I didn't found that they still came. But point what Tejas has to say is also valid. So we need to inform them in advance that you may have instability, and if it's that, then only I'll do reconstruction.
Functionality part is very essential if you're talking about mucoid patients. We are onto something very interesting. We are doing a gait analysis of mucoid patients. And similar to a single bundle or a reconstruction of the ACL, what we have found is that they tentatively put less weight on the affected side. What happens in the long term? Why do you observe loss of girth of the thigh and the calf in long term in chronic ACL injury patients? So ACL injury per se, I want you all to, this is a very fantastic study published by Bernard Soneri-Cotet. He has proven that ACL is not isolated problem of the knee joint. It's a decreased central representation of that lower extremity into your brain. Okay, so, and moreover, we are replacing a mechanically different tendon, or rather, to a mechanically different properties. So that's where mucoid degeneration, come to that point, requires a ACL reconstruction if it is a functional demanding patient.
There are surgeons who do not do an ACL reconstruction. I think the reason could be in trauma, there is a traumatic injury to the ACL. It's not just the ACL, there is an envelope of tissue which gets lax, loosened, then that leads to instability. Whereas in mucoid degeneration, no, it's just the ACL which is affected. So that is probably the thought process behind why surgeons don't do ACL reconstruction following excision of mucoid. Even full excision of ACL, some surgeons do not.
Like taking a chance, because even after ACL injury, there are some those who don't opt for surgery, and they are doing fine. That is, maybe they are ACL copers or something like that. It is better in this era to just go for reconstruction. It's a predictable outcome.
Thank you very much, all the faculties. I would like to felicitate our faculties. I would like to call chairpersons Dr. Naved and Dr. Samir. Dr. Ashay Kekatpure. And Dr. Rohan Bansal. Now we'll move on to a small lamp lighting ceremony, and then we'll break for to call upon VOS President Dr. Satyajit Jagtap sir and Secretary Dr. Samir Dwidmute sir, and Arthroscopy Society of Nagpur President Dr. Mukesh Ladha and Dr. Secretary Dr. Naved Ahmed sir, and our national faculties Dr. Srinivas sir and Dr. Ramakant sir.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डिता ब्रह्माच्युतशङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणा
I will break for the. We'll break for. Start with the.
We'll break for the lunch now. There is a ACL registry video. Everybody just have a look at it.
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroscopy Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment the IAS for setting up the Indian ligament registry.
We'll take a debate. For that, I would like to call upon our chairpersons, Dr. Dheeraj Gupta and Dr. Dhananjay Deshmukh. The debate will be conventional ACL reconstruction versus all inside.
Check.
Let's start our post-lunch session. Conventional ACLR versus all inside ACLR. May I invite Dr. Ashik Ekatpure and Dr. Naved Ahmed?
Okay, so how should we proceed? Just a routine presentation or we should have a question answer session? Okay. So, good afternoon for the post-lunch session. Interesting one. Dr. Neha, I'm thankful to the IAS1 Society for interesting with this difficult debate of comparing conventional anterior cruciate ligament reconstruction and all inside, which is an emerging technique in ACL reconstruction. So before we go ahead, couple of things. I have got no disclosures. That is a major part of this debate. Okay, and conventional ACL reconstruction. Let me put you. I put both sides on the femoral side and the tibial side suspensory fixation, and through tibial tunnel. Okay, so I'll be talking more about a conventional reconstruction technique, including a suspensory fixation on the tibial side. So this is a picture which every one of us should remember. If we understand what is first principle analysis of things, then can I have a pointer? So whenever you are doing a all inside fixation, there is a suspensory fixation over here, then endopet on this side, and the suspensory fixation, then a tissue or a thread to stabilize the ligament across the suspensory fixation, then the graft, then another thread across another suspensory fixation stabilizing it, and there is a fixation device on the tibial side. So according to Murphy's law, whatever can go wrong anywhere in entire sequence of events. So what exactly, let us go to the very basics of it. What is ACL reconstruction? A surgical procedure to restore the stability of the knee after a ACL repair. Two approaches, and why we need to do the analysis. It needs to restore the knee stability. If we are adding so many movable parts into a reconstructed ACL, are we doing any justice to the reconstruction that we are doing? And to minimize the complications and maximize the recovery. So this was a fantastic paper which was published in American Journal of Sports Medicine, Biomechanical Evaluation after ACL reconstruction and critical factors in ACL reconstruction planning. Both of them pointed out the importance of maintaining the decreasing the chances of link failure at the entire link or the chain of events. So fundamental principles, the reconstruct ACL must replicate the native ACL function. Full length tunnels created, they create better graft path mimicking the native anatomy. Interference screw provides better or ensure robust fixation as compared to the all inside ACL. Shorter graft length may compromise tension, and suspensory fixation can lead to micromotion and tunnel widening. And there is a phenomenon called as graft tunnel movement, which is more in all inside ACL as compared to aperture fixation, which is there in screw fixations. These are my references. Then we come to the physics of fixation. The stress distribution. The conventional ACL full tunnel distributes mechanical stresses in a uniform way as compared to across a larger surface area, reducing localized stress points and thus decreasing the graft failure. Whereas all inside ACL suspensory devices concentrate the stress at fixation points, increasing the chances of loosening or failure in overtime. Load bearing efficiency, it replicates, in near about replicates the native ligament load bearing capacity more effectively than full graft length. Invasiveness. So definitely, all inside ACL has its merits of decreased invasiveness as compared to the conventional ACL. It has got smaller sockets, but it compromises the bone graft integration. Coming to the fixation reliability, stable fixation is required for a good functional outcome. Interference screw and full tunnels provide durability. It is time tested. Decades of research is into it, and it provides adequate amount of fixation for the graft as compared to the suspensory fixation, which may loosen. There is a bungee effect, there is a wind viper effect, there is a tunnel widening, which has been reported into all inside ACL fixation. Now, coming to the most important perspective, which is in Indian scenario, the cost analysis. With conventional ACL, with a fixed loop and a suspensory or a interference screw, it is 25 to 30% less expensive as compared to a all inside ACL fixation, and the rehabilitation time and the cost is comparable to any of the all inside ACL reconstruction. So long term outcomes, the primary goal is to ensure durability and functional overtime. There is a decades of clinical data which is available that conventional ACL works well, works fantastically well, and it will keep on working. all inside ACL is a rising trend, and we need to ask ourselves this question: do we need to be trendy, or we do need to provide reproducible results in all hands whenever we are operating our patients? Addressing some misconceptions about all inside ACL, claiming that it's minimally invasive. Conventional ACL invasiveness is justified by superior graft integration and robust outcomes. The all inside ACL claims of faster recovery, it is comparable in timelines with proper rehabilitation. All inside claims of advanced technology is based on biomechanical first principle, solid data which is available throughout the years. As I already mentioned out, the physics and economy, they support conventional ACL reconstruction on all terms. So, on conclusion, conventional ACL reconstruction adheres to fundamental surgical principles, stronger fixation, durable outcomes, and cost effectiveness. And it remains the gold standard of ACL reconstruction. This reminds me of a very good ad which was there in. So, this lady claims with all the benefits are available, to koi ye kyun na le? Ye le, wo kyun na le? Okay, thank you.
Thank you, Dr. Ashay. Now we'll invite Dr. Navid to talk on or to counter the arguments and support. He will be supporting all inside ACL reconstruction.
So do we have a rebuttal after this? Yeah, okay. So, fantastic talk, Ashay. But from the first slide that he started, he was talking about the negatives of all inside. So he didn't mention the positives of conventional. So I think there are not more than a few. That could be one of the reasons. So what is all inside ACLR? Just for all of you to know that we don't use a tibial screw in that. We use suspensory fixation with adjustable loop endo buttons at both ends. So you create sockets rather than tunnels. So the bone removed is less. The sockets are smaller than the tunnels which you create in a conventional ACLR. And the best part is that you can cinch the graft at both the ends. When you are putting a screw in a conventional ACLR, it is known that you create a laxity of about 1 or 2 mm. But that you can correct with your all-inside technique, where you can cinch your graft at both the ends. So why all-inside ACLR? Because you create sockets rather than tunnels. So there is less bone removal. There is less of windshield wiper and bungee cord phenomena because you are fitting your graft snugly into the socket, and it's not a tunnel where you have loose space over there. Semitendinosis is more than enough mostly, so it's less morbid because small grafts lengths are acceptable. And there is less functional deficit because only the semi-T is used usually. And so there is less post-operative pain, which has been eluded in multiple studies, and the complications of screws are completely avoided. So talking about literature, I think Dr. Ramakant nicely alluded to his own study of suspensory fixation previous in his talk, where he said that suspensory fixation is better than fixed loops. And in this article from 2015 Arthroscopy, they said that it is at least at par with the interference screw fixation. With regards to retrograde drilling, there is this article from knee in 2016 which says that retrograde drilling with a flip cutter of the tibia resulted in less bone edema and subsequently less pain. So these are the few elements of all inside which are different from the conventional, and we are just talking about evidence for that. And then there is comparative studies with standard or conventional ACLRs in 2013 in arthroscopy, where they said that all inside ACL reconstruction resulted in less post-operative pain and similar clinical outcomes compared to a full tunnel technique. Similarly, the early and mid-term outcome studies support all inside ACL reconstructions, and they say that the graft link technique demonstrated good medium-term, subjective and objective outcomes. Then, as I said, that post-operative pain is definitely less with most of the studies showing us that, and there is improved cosmesis and there is decreased bone removal. And the concept of tibial tunnel widening, so this study negates that also. This is a study from KSST which says that the button and screw constructs result in significantly greater tibial tunnel widening when compared to the all-inside constructs. So we have ample evidence suggesting that all-inside is as good as the conventional or maybe better. In fact, we have histological evidence to support. So this is an animal study from Arthroscopy 2016, which says that there is histological evidence for superior healing of suspensory fixation methods in animals compared to the interference screw. So, and I have had a personal experience of more than 1,000 all-inside ACLRs. I'm very happy with that. If you see the history of ACL reconstruction, so until the 19th century, there was conservative treatment for that. From 1980s, till 1980s, people were just repairing and using silk as a scaffold. And then people started using fascia lata, hamstring, patellar tendon, but these were all open kind of surgeries. Then there was the over the top by Macintosh. In the 1980s, you started getting the arthroscope in picture, and then there was arthroscopic ACL reconstruction. And then we have had multiple implants, multiple suture materials, the concept of double bundles, the transportal or the anatomical technique, and then the all inside. So there is an evolution, and you have to accept that evolution, even if you don't like it. Resistance is always been there. So in fact, Galileo, one of the biggest philosophers and scientists, he was imprisoned by the Roman Catholic Church for saying that the planet moves around the sun. You know, so resistance is always there, but we are in the age of artificial intelligence or AI, and we are accepting that. So as arthroscopy surgeons, we should accept AI ACLR. It's not artificial intelligence, but all inside ACLR. Thank you.
Fantastic, fantastic rebuttal points. Let me point out, and I will go from the last two slides on back. It was Kepler's model and Copernicus who first pointed out that the planet rotates, or rather around the sun, and Galileo reconfirmed their findings. So good that you will reconfirm the ACLR, all inside ACLR. The point of fixation, or rather the mention is that more recently has done a randomized control trial. 2023 he has published, and there is a higher failure rate in terms of all inside ACL reconstruction in high demand patients. So good, all inside ACL has its place in low demand physial immature patients where there is a multiple ligament injury involved and you are short of grafts. Definitely there is a role of all inside, but if you need a robust fixation, then conventional ACL definitely how can I say, proves your point. There was a 2017 article published in Arthroscopy by Nick Verma. What is the choice of graft which they use in American football players? 70% of the arthroscopy surgeons, they use bone patella tendon bone graft with both side aperture screw fixation with interference screw in titanium. That was the graft. There was a graft of choice in all those patients. So definitely with emerging technologies, we need to adapt, but a long-term study, a randomized control trial, definitely that is required to for sure say that this works better than this. At this time, how can I say, the horses are still out and no one has reached the post yet.
Okay, can we have the slides, please? So in the start of his talk, he mentioned that he was himself doing suspensory fixation on both sides. So you're already on our side, okay? You're partially on the all inside stuff, yeah, okay? So see, all inside is very evidence based, okay? So there might be articles supporting conventional, definitely, but there are articles which support all inside ACL reconstruction. So the graft which we prepare has been nicely studied by Lubowitz, who started this procedure. And you have this buried knot technique where it is proven that it is better and it can withhold the stresses. Similarly, the translateral technique has been alluded to by Adrian Wilson about how to make your tunnel on the femoral side. So this is all evidence-based. And why would you want to remove more bone when you can remove less bone and give less pain to the patient? You can screw away with the complications of the screws like infection, divergence, screw breakage. And in the end, if someone wants to have a fixed loop, what you can do is at the end, you can tie the suspensory fixation sutures and convert it into a fixed loop. So I don't think there's any reason to, say that conventional is better than all inside. Yeah, you can't. Oh, done.
It's comparable. It's comparable. I think I need to just use your slide only for my talk. Can I use? एक मिनट, I need to. ये पुराना वाला slide लगा.
So let's take it. Let's take a vote. How many of us do all inside and how many of us do conventional method?
No.
I would call that as hybrid because the element of removing less bone is not there.
Hardly 1 centimeter bone removal. You are claiming.
You see, if I remove 1 centimeter bone of you, so you will not be very happy.
You are, so what I mean to say, all your previous ACL which you were doing conventionally were not happy?
So they are happy. It's not like I don't do conventional now. I do them, but the kind of ease that I have and the specifically the way I can tension the graft again and the complications of the screws which I've had, they're all gone now. So I'm very happy with what I do. It's very easy for me now.
So it's one-sided affair.
See, I mean, you can rather than saying that complete, how can I say, all inside, the hybrid technique that takes out the chances of the graft not being tensioned enough in cases of a fixed loop graft if you're using on the femoral side. But we have got the option of adjustable loop on the femoral side now. So that definitely can help.
Moderators will.
So you are just halfway to me. You just have to reach one more half.
We also need to understand the economical quotient which is there, and especially in a developing country like India, where most of our people, they come from poorer or laborer background. The conventional system and fixed loop on one side and suspensory fixation on the other side, that definitely helps. Or titanium screw on the other side.
I would like to ask Ashay, would you do all inside in any of the cases? Would you do, I mean, do you have any criteria where you, in case you would prefer to do all inside?
So you are asking for specific indications, right?
Yeah.
So in a pediatric patient,
okay,
in a low demand patient with good insurance, no, jokes apart, in a pediatric patient, all inside definitely has its place because a smaller graft is required. And in a multi-ligament scenario, it may have a chance when the grafts are scarce. I mean, you need more amount of grafts.
Just, Can I raise one comment, one point? We know that ACL injuries are associated with bone injuries also, bone marrow edema. Subsequently, these edema can have osteoporosis, reduced purchase. Do we have evidence on how this will affect the screw fixation?
Do we have? Okay.
So we're talking of soft bones over here. So when you have a soft bone feeling when you're drilling, it is much better to have an all inside because the screws will not hold where they are.
Specifically about bone marrow edema causing compromise of fixation. Is there any study? Agreed. But can it affect the path of the tunnel?
It's a fantastic question. I think there is a food for thought over here. But we usually tend to wait in terms of acute ACL injuries and space it out till that at least 3 to 4 weeks so as to settle it and have a better purchase.
So bone edema does not go down in 1 month. Okay, it takes 8 to 9 months minimum. You need to have a verdict. We will be talking like this. So?
Yeah, I will go with my own method. Okay. That is aperture fixation on tibial side and adjustable loop or fixed loop on femoral side.
I think there is division between moderators as well. I do all inside in most of my cases. Okay, thank you.
We would like to invite Dr. Dheeraj Gupta and Dr. Rohar Bansal to moderate the next session. Cruciate avulsion fixation by Dr. Naved Ahmed. Okay. Dr. Mukesh Ladda, recent advances in synthetic graft ACL.
This is more of a personal experience with some literature backup. Experience of say maybe 9 months to 10 months only. So what are the graft options we were just discussing? What we have is autograft, which we all use. We all have some benefits, some disadvantages of all the autografts which are available. Allografts, they have their own problems which are less available for us to use, and their problems are much more than our autograft. And then the synthetic ligament, scale, large, jewel, etc. are there in the market. So 3 graft options are available. Right now what we use is autograft in almost all our primary and revision cases. Allografts has just started picking up in India because now we have tissue banks available in India, but it has its own. And this is the last one, is the last option we have. So what is the need for requirement of a synthetic graft, or what it should be, how the graft should be? Synthetic graft should be biocompatible. The mechanical strength should be as good as like your native or little more than your native ACL. It should have some tissue ingrowth properties in your synthetic graft, and most importantly it should withstand the aggressive synovial fluid environment, so that it should not react with synovial fluid and keep repetitive synovitis and inflammation. These are the basic requirements of a synthetic graft. A nice article which says that much of this has been achieved in recent article 2013. What are the types of artificial or synthetic grafts which are available? They are based on non-resorbable polymers, like the one which is available in the market called as Jewel, and the Lars which was there. Non-resorbable, that is internal brace, what we call as polytapes, and bio-based synthetic membrane which have some mesh round, and these are the 3 types of synthetic grafts which are there. You see the literature, company, material, degradation time, architecture, and other advantages, that you can see that these are all non-resorbable. The one which are resorbable is of no use to us, but the important finding is that what I want to show, that this have been working since long. To go through the history of artificial ACL, it's not the new one, it's since very long, and they have high tensile strength and other things also. So what actually is this article says, anterior cruciate ligament, a review of literature, that natural ligament ultimate tensile strain and stiffness, this carbon fibers, these various types of ligaments artificial which were available, this carbon fiber failed early because the tensile strength was very low, but rest they worked to some extent, some causes some reactions, some didn't cause any tissue ingrowth, and some even abraded the original graft and all, and that's why it went into bad repute. Another thing what the synthetic graft, they say to avoid donor site morbidity. We all know we have some of the other side of morbidity. Whatever graft, autograft you take hamstring, you take BTB, you take central quadriceps, some of the other donor site morbidity is there. But I don't think it's too big to directly jump onto this synthetic graft. This is what is mentioned in the literature. So summarizing the information on the topic on this article is, there's a strong interest in collagen for purpose of ACL regeneration. Many publications describe in vitro, but only small percentage have arrived to a clinical trial. So most of the studies right now are into in vitro, and the interest of hybrid graft is growing due to greater capacity of mimicking the morphology, the mechanical properties, and tissue ingrowth. So for synthetic grafts, what should be the future thinking? They are saying they are focusing on enhanced mechanical and biological properties, so that they are going away now, putting some bioactive coatings so that you have more osteointegration into the graft, but evidence is still lacking for biological and long-term results. We don't have that. So current graft options, what is available to us is needed, is same. Now this is another one which has came one step up because it has less complications compared to your allografts. So these were the 2 which was commonly used, the Lars one and the Jewel which is there. The only difference between the two that they are woven and they have some pores in between for the tissue to grow. This has been proven by the people who are doing it since ages, not by me. So where I have started using is, so this dual ACL or synthetic which is available in India, it's basically an isometric ACL reconstruction. You can only reconstruct anteromedial bundle with it. You can't reconstruct posterolateral bundle as mentioned by the inventor, surgeon or PhD. So this is one of the case where a partial ACL tear and you can see the posterolateral bundle was intact and the AM bundle was torn. So I have used as a stand-alone dual ACL, didn't put any hybrid graft or anything. So it's only 6 mm diameter. So I had a lot of argument with those guys. They say you can use standalone even in complete non-absent ACL. I told them, boss, there is something, even the 8 mm, below 8 mm we fail. So this will also go. This is one of the indication where you want to do an isolated AM bundle reconstruction. You can use it standalone without anything. No issue. This was another patient who had complete avulsion from the femoral side. And if you are a believer that ACL repair works, some may just work as a repair. But here, then I just augmented it. I preserved all the remnant ligament and just augmented that whole of the stuff. You can see it's almost complete intact. I augmented it with simple, standalone ACL. Didn't do any remnant preserving or adding anything, but just added one strength so that it helps to grow. So the inventor or whoever is from Dr. Baha, whom we are talking since 1 year, they have shown some relook copies where the tissue grows on it, and so I have no experience about it. So that is one. Let's come to mucoid ACL. We had a lot of huge discussion. I think I have used this in this was only 30-year-old patient where I have partially debrided and just used another dual ACL. So these three are the one where I have used it as a standalone. And the highest follow-up is of this patient since almost now 9 months, and none of the patient have any synovitis. They recovered fully, no post-op effusions or post-op synovitis or any rejection in any of the patients. These are three indications. The another one is this one, which was quite interesting. This was a young 19-year-old girl with ACL and ACL injury. Both semity and gracialis came only to be 7, even in 7-fold, only 7. So to increase the graft diameter, I wrapped the graft through the dual ACL because it's a tubular structure. You can just weave the graft inside that sheath. As you can see, I am weaving it inside the sheath. They have multiple openings. You can just pull the graft, what it looks like, the graft inside the sheath, and then you can use it if you want to increase the diameter without, because she was 19, I don't want to take any peroneus and all. I don't know how it will behave after 20 years to the ankle. So I have took semity gracialis. You need to have, the rest of the principles are same, exact tunnel positions and all. So use, if you want to use them as a hybrid in case of patient who have chronic ACL, who have very severe pivot shift, and there are no remnants available. So don't use them as standalone in chronic. I did one in PCL with the thought process. This was very young female. I showed it earlier also. She was 34-year-old female who had some tibia fracture. She had some root tear, neglected, and even the chronic PCL was there. So even though there was a grade 4 arthritis, but she was only 34, I added PCL. We all know in PCL we do have grade 1 sag after our routine PCL reconstruction. So with that thought process, I have added this, and this is only one case which I have did, and I found it, there is no sag even after 9 months. Patient is quite stable and doing his activities. You can use them in extra-articular reconstruction, as here is the case of complete patellar tendon rupture after post-knee replacement, 3 months post-TKR because of fall. So the tissue quality is very bad, you can't do anything here. So you can use them in extra-articular things of reconstructing the patellar tendon, weaving it through the tibial tuberosity and just weaving it around and stitching it over the remnant soft tissue like this. and that works well in extra-articular. You can even use them for MCL reconstruction. If it's an isolated, this was 2 months old chronic MCL insufficiency, insufficiency only in 30 degrees, only superficial was gone. So I've just used them standalone along with my ACL reconstruction. So these are the current indications where I have used it. Failures and success is always there. So this says that particularly those over 35 who are not professional athletes can use them. This is the recent article in 2025 just, and they say the scoring systems are same. Benefits such as faster recovery and fewer complications, but its mechanical properties may limit its use in younger and professional athletes. The graft failure rate was low, it's only 3.8%, and there is no reported evidence of any infection so far. Thank you.
Thank you, Mukesh, for excellent talk. We'll now invite Dr. Navid, who will talk on cruciate avulsion fracture fixation.
Good afternoon again. So this is a very vast topic, so I have restricted it to the tibial sided avulsions, and that too specifically more to the PCL. So let's go through this. So ACL tibial spine avulsions common in children and adolescents because of the weak and incompletely ossified tibial eminence as compared to the strong ACL. It happens when you have a forceful hyperextension of the knee or a direct blow over the femur in flexed knee. We all know the Mayer and McKeever classification. The management for type 1 is conservative, type 2 is conservative or surgical, and type 3 and 4 is surgical. Conservative, you aspirate the tense, if it's tense, the hemarthrosis, and you reduce it in full hyperextension and cast for 3 to 4 weeks. Surgical, you can do it either arthroscopic or open. There are various implant options like staples, screws, anchors, sutures, tapes, adjustable loops. Now these are two fantastic ways of fixing the ACL tibial avulsions. One is by our ex-president, and which they use 2 anchors over there, and one is by the president himself, who uses a single anchor nowadays on the anterior surface of the tibia. So let's go to the PCL, tibial avulsion injuries. These are dashboard injuries common in India with concomitant intra-articular injuries of up to 28%. They can be fixed arthroscopic or open. But this article by Dr. Dinshaw, which states that there is a 50% resurgery rate in patients treated open who had associated intra-articular pathologies. So I prefer to do them arthroscopic. Why? Because it is minimally invasive. You can address all the other injuries like the meniscus root or the cartilage. It is cosmetic and there is less stiffness in my hands. Arthroscopic fixation options, you have many implant options available. I usually use this, which is called the arthroscopic PCL tibial avulsion suture bridge repair. The steps of the surgery include evaluation under anesthesia, a diagnostic arthroscopy, placing 2 posteromedial portents, one superior and one inferior, identify the fracture fragment and the fracture crater, create a pouch posterior to the PCL and anterior to the capsule, create 2 tunnels, inferolateral and inferomedial to the fracture crater, pass a fiber wire around PCL ligament to osseous junction, tie half hitches to create a braid, relay the sutures through tunnels to the anterior tibia, and then reduce the fracture and tie sutures over the anterior tibial bone bridge. So this is a case of a 35 years old IT professional. He's a fitness freak. He had a dashboard injury, 3 weeks old, isolated PCL tibial avulsion on the X-ray and MRI. So just going through the steps quickly, it's a right knee. So you have a standard anterolateral portal and a high AM portal. So you see that the PCL is lax. The ACL is also lax because, and you can see the floppy ACL sign in a bit. So that's the floppy ACL sign, which shows that the PCL is inefficiently working. So what you do is you go above and between the ACL and the PCL, and you start removing the fat synovium from there, and you have to reach the posteromedial portal to this view. Make sure you're not injuring the PCL fibers doing this. You remove the upper half of the septum and you straight away go into that posteromedial space. Once you are in there, you take a needle and you make the superior posteromedial portal. You make that portal with a blade and then pass your shaver, and then you create a pouch posterior to the PCL but anterior to the capsule, and this is how it should look from the anterolateral portal. Once that is done, you again make a inferior posteromedial portal, just like you do it normally. And then you put in a 6.5 mm cannula over there. So now you have a superior portal, which will be your visualization portal, and an inferior posteromedial portal, which will be your working portal. So this is how it looks from the posteromedial portal. You can see a lot of fibrosis over there. You have to release all that fibrosis, and then you will be able to identify the fracture fragment and the fracture crater. Be very careful to not face the shaver blade posteriorly, but keep it anterior towards the tibia, and that is the fracture fragment. Now you have to visualize it properly, and you have to create space inferolateral and inferomedial to the fracture crater. So if you see, that's the fracture fragment there, and you have to go inferomedial so that you can see the muscle fibers which are attached to the tibia over there. You can use the RF because then you get a good visualization. So now you create a inferolateral tunnel below and lateral to the crater. A tip is that this jig, which given by a company, this works very well for this, and you posteriorly deflect the capsule with a Wissinger rod. And then you drill in with a teeth pin, keeping it under vision always. Once the bead pin comes out, make sure that you are inferolateral to the fracture crater. Then take your PCL curette and you over drill it with a 4.5 endobutton reamer. Similar steps have to be performed on the inferomedial side. Now this side, the jig which I showed you does not work properly, it does not go there. This kind of jig works well on this side. And then again you over drill your bead pin with a 4.5 mm endobutton reamer. Next is you have to pass from the anterior portal a fiber wire number 2, one strand on the medial side and one on the lateral side of the PCL ligament to osseous junction. Use a grabber to get that suture, and all these you're working from the inferior cannula. Once you have that suture there, you have to tie a non-locking sliding knot and then multiple half hitches over that. Then you have to pass those sutures to the tibial tunnel which we have created. For that, you can use a crochet hook. That's the one end of the suture going through the inferomedial tunnel, and the other one then going through the inferolateral tunnel. And then you pull it up nicely and see how nicely that fragment gets compressed into the crater. Then you tie them over the anterior tibial cortex. So that's the post-op X-ray of that patient. You can see the two tunnels going inferomedial and inferolateral. And just a tip on how to avoid complications, you should be waiting for about 2 weeks so that there is capsular healing on the posterior side of the knee. You know your anatomy well, operate under vision, create a good pouch anterior to the capsule. You need good instrumentation, and the learning curve is a little bit high, but once you know it, it's very easy and you get very good compression. Thank you.
I would like to call Dr. Srinivas, sir, regarding a talk on extra-articular surgeries for ACL deficiency.
Thank you again for this opportunity. So my talk is extra-articular surgeries for ACL deficiency. I have nothing to disclose about this topic. Looking at the history and background, Segond was the first to describe capsulo-osseous layer of the iliotibial band. In the 1970s and 80s, ACL reconstruction was done by extra-articular procedures alone. And there used to be more than 50% failure rate using those techniques. It was largely abandoned in the 1980s. Kaplan coined the term anterolateral ligament in 1958. It was popularized by Vieira in 2007. There was renewed interest in ALL with ACL reconstruction from early 2010s. In 2013, Clays described ALL as a distinct layer of the capsule. It is found almost universally by 2015. The anterolateral complex is found by the ACL, ITB, and the anterolateral ligament. ALL originates from the proximal and posterior to the lateral epicondyle and inserts between Giardi's tubercle and fibular head of the proximal. Yeah, we have seen that in the cadaver dissection this morning. The ligament is about 36 to 50 millimeters long in extension, 6 millimeters wide and 1 to 3 millimeters thick, originating from 8 millimeters proximal, 4 millimeters posterior to the lateral epicondyle, 7 millimeters from the joint line. It is superficial to the lateral collateral ligament, and it inserts 1 centimeter distal to the joint line between the Giardi's tubercle and the fibular head. It's about 24 millimeters posterior to Giardi's tubercle and 26 millimeters proximal to anterior margin of the fibular head, and about a centimeter distal to the joint line. Kaplan fibers of the iliotibial band play an important role in anterolateral stability of the knee. Two important bands were found, the proximal and distal Kaplan fibers attaching the distal ITB to the distal femur, just distal to the intermuscular septum. Some authors describe another band called the condylar trap that's distal to these fibers, and the biomechanics of these are evolving. ALL is found in about 83% of the knees, isometric from 0 to 60-degree flexion and slack on further flexion. Increases in length on internal rotation of knee at 90-degree flexion and on varus loading. It is an important stabilizer of internal rotation at flexion angles of around 35 degrees and more. Cutting ALL in ACL absent knees increases the internal rotation. In anterolateral rotator instability, ITB is the main secondary stabilizer. So both the LET, lateral extra-articular tenodesis, and ALL reconstruction restore knee kinematics. Small attachment of the lateral to the lateral meniscus has been found recently. ITB tenodesis decreases the loads on ACL by about 43%, placing it under the LCL provided optimal biomechanical behavior. It is important structure in the pivot shift test. We have seen in the clinical examination, shift of the tibia occurs due to the shift of position of ITB from anterior to mid-axis posterior as the knee flexes and extends. The indications for lateral extra-articular procedure are expanding. Traditionally, the initial indications were young active patients, pivoting sports, high-grade pivot shift, generalized ligament laxity, hyperextension, revision ACL reconstructions, Segond fractures, chronic ACLs, lateral femoral notch sign, lateral coronal plane laxity, concurrent meniscal repair, and anterolateral injury on MRI have been included. The disadvantages are lateral pain, reduced quadriceps strength, longer time to recovery, and over-constraint of the lateral compartment with associated cartilage damage on lateral osteoarthritis. This systematic review of RCTs alone provides good evidence in favor of lateral extra-articular procedures. So LEAP improves pivot shift, patient-reported outcome measures, and reduced graft failure rates. Even skeletally immature patients may benefit from ALL augmentation when there is laxity or pivot shift or sporting career. Of course, in the very young, ACL itself is performed as an extra-articular procedure to avoid physeal damage. Mainly 3 types of procedures have been described: intra and extra-articular procedures using the same graft, and mainly in those with open physis, LETs combined with ACLR, and those with anatomical and anterolateral ligament reconstruction with ACLR. Lemaire was the first to do an LET in femoral side. He created a tunnel around the lateral head of the gastrocnemius. This is largely modified now. Either a tunnel is used with an interference screw or staple or anchors near the Kaplan fiber attachment. As we have seen, tunnel convergence can occur with the ACL tunnel. Here in this picture, you can see a staple coming into the femoral tunnel. Some surgeons actually do the ALL first and visualize through the tunnel to make sure there is no convergence. Macintosh is an extra-articular procedure. Graft is passed into the intermuscular septum. Zarin-Sunroe is an intra and extra-articular procedure. And these are the ALL reconstructions. They are anatomical, while the LETs are non-anatomical. Chahla uses semi-T and fixes femur 4.7 millimeters proximal and posterior to lateral epicondyle. Tibia is equidistant between Gerdy's tubercle and fibular head, 9.5 millimeter distal to the joint line. Fiera uses double gracilis, and most of these techniques fix proximal and posterior to the lateral epicondyle. There is no uniformity in the point of fixation between the techniques given, and they use different fixation techniques and grafts. Some use anchors, some use interference screws. Sonnery Cottet reported a large number of cases using their technique. They fix proximal and posterior to the lateral epicondyle and femur, and at the tibia footprint of ALL, they use a loop distally. ALL is more anatomical than LET. LET is more cost-effective than ALL, according to one study. Anterior stability is worse with LET, and postoperative knees with grade 2 and 3 Lachman are more commonly seen with LET. Looking at the outcomes at 2 years, using LET with hamstrings autograft have significantly better outcomes. When used with pivot shift grade 2 and 3, pivoting sports, or for ligament laxity. The Stability 2 trial, that was the Stability 1 trial. Stability 2 trial is underway. They are looking into LET for quadriceps and BTB grafts. For completion's sake, extra-articular procedures could theoretically include HTO and slope-reducing osteotomies in conjunction with ACL. Malalignment should always be corrected before ligament reconstruction. This is a malunited proximal tibial fracture with ACL deficiency. I did an HTO and reduced the slope, leaving ACLR for a second stage. The patient is happy and did not come back for ACL. So to summarize, ACL injury often associated with rotational component. Identify at-risk patients benefiting from LET or ALL. Associated injuries, lesions benefit from LET or ALL. Osteoarthritic changes have been reported with LET and are less with recent studies and modified techniques. Modifications of LET could further reduce the OA occurrence. Thank you very much.
Thank you, sir. Any questions? Questions? Dr. Mukesh, I would like to ask one question. We have seen so many patients who are having synovitis when we are using multiple sutures in shoulder while arthroscopy, okay? Rotator cuff repair. So have you find any such reaction in your that graph which you have used?
Not yet. That's what I told. I have not seen any synovitis or effusion in last 9 months in any of my cases.
Okay.
Just to augment the graft, I don't know the cost of that synthetic graft. 80K. So just to augment, we can use fiber tapes. Yeah.
So do you always advise hybrid graft or standalone synthetic graft?
Hybrid only if you are using it to increase the thickness of the graft. In case of complete ACL absence, the partial tear, you can use it standalone. Like remnant preserving ACL, you can do standalone.
Thank you.
Okay.
Thank you, Chairperson. I would like to say a small, short vote of thanks. It gives me great pleasure to extend a heartfelt vote of thanks to all the faculty members who played an instrumental role in making IAS1 on knee arthroscopy a resounding success. And first and foremost, I express my gratitude towards our national faculties, Dr. Srinivas Kamampati and Dr. Ramakant R, who have come all the way along from Vijayawada and Coimbatore just to share their thoughts with us. Your detailed explanations and practical demonstrations and interactive sessions have enriched our understanding and enhanced our skills. I would also like to thank our IAS President Dr. Arumugam sir and Secretary Dr. Sandeep Biraris and the organizing team of IASONE Nagpur and of VOS and ASN, Dr. Satyajit Jagtap sir, Dr. Samir Dwinmute, Dr. Mukesh Ladha sir and Dr. Navid Ahmed sir. So and the supporting faculty members for their tireless efforts in planning and executing this program. Thanks to Shalini Tai Mege Hospital, Dr. Vasan Gawande and Dr. Siddharth Jain and Dr. Tejas for helping us out and their support in cadaver live session. All your dedication has ensured that every aspect from the workshop to lectures were meticulously coordinated. A special acknowledgement to Osteocare, Mr. Talwar, for all the support. Yash Audio Visuals and Mr. Mithun for their help. And lastly, I would like to express my gratitude to the delegates for their enthusiastic engagement. Without you, this program wouldn't have been possible. So, thank you all for coming together and to make IAS1 a memorable and meaningful experience. And let us continue to collaborate and enrich our experiences with these stalwarts. So, thank you. Those who like to do meniscus repair workshop, the workshop is arranged.
Hello. Before we depart, I invite all the delegates and faculty at the dais for a group photograph, please.